ओके हेड ऑन. पोटी नंबर 2.
चेक 1 टेस्ट. हॅलो.
ओके
कशावर बोलताय?
हेड ऑन हेड ऑन.
लेवल जरा कमी.
कमी आहे.
हा कमी आहे कमी.
हा करतो. ओके
बघा तर.
हॅलो हॅलो हे बघ रे. हॅलो हॅलो.
एकच मिनिट जरा इथनं किती आहे बघतो आधी याची.
काल
नाही
सेटच
तुमचा कॉडलेस आला मगाशी चांगला.
हॅलो माइक चेक. हॅलो 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 हॅलो. ओके का? हॅलो हॅलो
लेवल कमी होता सर. थोडी वाढवा.
हॅलो हॅलो बघ. हॅलो माइक चेक. हॅलो माइक चेक.
हा ठीक.
बस का?
हा बस. येतोय आवाज? ऑडिओ येतोय ना? चेक 1 टेस्ट. हॅलो. हा 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 बरोबर आहे की पण. चेक चेक टेस्ट.
काय करायचं तेव्हा पाहिजे लोकांनी नुसतं बंद केला.
हॅलो. हा बोला.
इंडिया यायला बरं चेक कर जरा. इंडिया
हा आलेत आलेत. 2 कलर आहेत.
दोन्ही आलेत.
एक मिनिट. एक लॅपटॉप आहे आणि एक कलर आहे.
ओके इंडियाला आलंय ना?
हा आलंय आलं.
ठीक आहे. हे बघ.
हा
एक मिनिट ना. अमर बोल. बोल. डॉक्टरांची नावं नाहीत आली माझ्याकडे, तर नाही आली तर पाठवतो. इंडिया यायला का तुला? बर आता मला सांग. एन्कोडरचा 011 आहे. E3चा. लॅपटॉपला मी 012 केलाय. पण कनेक्ट होईना झालं. आता मी वर वर सर्च मारताना 011 टाकायचं का 012?
इथे जा.
11 टाकायचं का? ठीक आहे ठीक आहे ठीक ठीक. तुला बघतो, नाव पाठवतो.
आम्ही नाश्ता करून झाले नाही.
check, hello, hello, check. Check, hello, hello, check, hello.
अभी पहले ये लाइन तो बोल लेती तो सब आ जाएंगे. Okay. May I request the audience to kindly take their seats so that we can proceed with the program. G and Foxy Eagle Project. I, Dr. Mrunal Patil, extend a warm welcome to our esteemed delegates, faculty, surgeons for this prestigious academic event.
Now the question is, why this workshop? This Eagles project is a teaching initiative to learn laparoscopy, basics and advanced with simple steps to bring together experts and participants to share knowledge, exchange ideas and discuss important topics related to this field. Once again, I welcome you to this workshop. I hope you find this session inspiring, informative and rewarding, and I wish you all a productive conference.
We are now ready to cross over to the GMC Miraj Operation Theatre. We have an ambitious lineup of 11 live surgeries scheduled for today. To our delegates joining online, please use the chat function for real-time questions. To those present here, keep your questions concise as we go through the cases.
Chip.
Hello, Hemant.
Hello.
Am I audible? Yes, you are audible. Maybe you can brief us about the case and your preparations for that.
Yes. Good morning, everyone. Good morning, chairpersons and other esteemed faculty and delegates. Warm welcome to GMC Miraj, Abcde and IIG Eagle project. I'm really delighted and I'm really grateful because I want to admit that it is my parent institute. I completed my UG from here, the prestigious institute, Government Medical College Miraj, and I feel really honored that I am getting opportunity to operate here as a faculty, and it's all because of my gurus. Dr. Rawal sir, he is my guru. I trained under him. Dr. Rokde madam, she is also my guru. Dr. Gurav sir, I have very fond memories of this GMC, and I thank Dr. Vikas Devkare sir also to give me this opportunity to operate in a live surgical workshop here. We are all here to learn. I am not someone who's really very, what you can say, a stalwart or someone, but I'll tell you very basic steps which I have learned in my practice and from my gurus. I'll just taking this opportunity to transfer that knowledge to everyone who's watching and listening. So, as you can see, she is 50 years para to life 2 and previous history of tubal ligation done, and she has a 7 centimeters myoma, and she has abnormal uterine bleeding, so she is posted for total laparoscopic hysterectomy. So ovaries she has opted to remove or to preserve. Okay, she has opted for removing the ovaries. So usually we explain everything to the patient, the merits and demerits of removing the ovaries. So just a minute. So we give patient also the choice after counseling. So I usually prefer using this type of manipulator for hysterectomy. So this is the vaginal manipulator. She has a large size uterus, so I'll be using this is a removable part, if you can see. So according to the uterine size, you can change this screw. If you can focus. Yes. Okay. And this, the colpotomy tube, which has a bulge. So this is one modification which allows to prevent escape of the pneumoperitoneum afterwards. So patient is in lithotomy position, but in straight position, table as low as possible. So you must have seen in Dr. Vikas sir's video, which was a basic for any laparoscopic surgery. So the monitor should be at your eye level. So patient is completely draped. Patient should be preferably under general anesthesia. Should be catheterized. You should remember that patient should be catheterized, bladder should be empty. And you should be knowing how much pathology you are dealing with, so you can decide your port position. So according to pathology size, you will be putting your ports a little bit on a higher position. Okay. So remember that. And for creating pneumoperitoneum, there are various techniques, which is direct method, various needle, and then putting the trocar. So I prefer putting with varus and then proceeding towards the primary trocar. So I'll be quickly showing you how you put the uterine manipulator. So first you hold it with the tenaculum, dilate it a little bit.
A shift. Hello.
Yes.
Transmission is shifted to another OT. Please check.
Yes, Vaibhav, it's on now. How is there now?
Actually, we are not seeing the surgery by Hemant.
No, that right now the laparoscopy screen is off. He is just showing the external camera how he is going to put the manipulator.
But we are not seeing that.
Okay. So what is there in the screen now? Just now, you must be seeing that laparoscopy trolley, that one, no?
No. It is that transmit. Okay. Now it's okay.
Okay.
So have you seen the manipulator which I was showing? Am I audible?
Yes.
Dr. Vaibhav?
Yes.
Is Dr. Hemant audible?
Yes.
Yeah.
He is
Hemant gone.
Yes. Thank you.
So till Hemant start putting his trocar, I welcome all of you in the Government Medical College Miraj. I welcome all the operating faculties. I welcome all the anesthesia staff. I welcome all surgical nursing staff. And we have planned to relay total 11 number of cases from the 2 OTs. And at a time you will be able to see 2 screen in the hall, as well as it is available on the online platform. So I welcome once again, and over to you, Hemant, to just start about the trocar placement and everything.
So I usually use Veris. This is tooth forceps, BP handle, 11 number blade. So I'll take a good stab incision in the umbilicus, Veris.
Yes.
So before putting Veris, few important points. You should check the spring action of the Veris syringe.
Dr. Shintre,
Yes.
Dr. Haresh Wagashia here from Mumbai.
Good morning, sir. Welcome
morning,
to
good
the
morning.
Miraj and Sangli.
So can you just show the incision that you took with the forceps, right? You take it like that always?
Yes, sir.
Okay, so you have not faced any problem with this type of technique ever?
Till
But,
now, no, sir.
Yeah, so till now, no. So you don't, generally even Dr. Sanjay Patel I have learned from, and we used to do the similar way.
Yes, sir.
But when the patients are really thin, it is not very advisable to do incision like that, because with the blade only you can have some injuries.
True, sir. True.
Yeah. So
So
we
that
generally
time-
now what I have changed is we use Alice and lift the umbilicus up.
Exactly, sir.
Yeah.
But this patient was quite obese.
Yeah,
So I go
agree,
like that.
Yes, yes.
But completely agree, sir. In
Yes.
thin patients, we have to hold this abdomen with Alice on 2 sides with your assistant's help,
Right.
and then put the Veris.
Yes. No, not the varies. I'm talking about the incision.
Yes, incision also, sir. Yes.
Thank you.
Gas cable.
Hello.
Haresh sir. Hello.
Syringe there.
Am I audible?
Yes, you are audible.
Sir, according to experts, sir, which entry is better? It's a varies or direct trocar?
Okay, so direct trocar entries, have you found references? Have you read about it?
Yes,
Did you
sir.
find any evidence?
Sir, evidences are there, but there is no clear idea.
So that is what, basically if you write a textbook, direct trocar entry is not an entry which is mentioned in any textbook, standard textbook. And now when you are trying to defend your primary port entry in the court of law, primary port entry is
Yes.
defendable, provided you've done a textbook or a referral work.
Yes, sir.
Okay, if you've done some work of your own, like if I put my knife in my wife's abdomen, I cannot defend it.
Yes, sir.
That's not something given in the textbook. So the court sees like that. So when the direct trocar, generally I try and discourage it. Of course, it becomes very easy. Another reason why you should not put direct trocar is that if the patient is slightly compromised, you are inducing the CO2 insufflation very rapidly. So when you induce, this anesthetist would answer better. When you induce CO2, you are actually inducing something called as restrictive syndrome. And a restrictive syndrome in a compromised patient, compromise means cardiac compromisation or pulmonary compromisation, the patient will throw some reaction or some stressful event will happen on those aspects. So varies would give a gradual, some time for you to induce CO2. Am I understood?
Yes, sir. Yes, sir.
So because I'm dealing with large pathology, I'm taking primary trocar 2 finger above the umbilicus. So always remember that you take just adequate incision to put the trocar, not more than that. That will help you to prevent any air escape 10 mm trocar. So because it's a nave abdomen, only history of tubal ligation done. So I'm using sharp trocar.
Anything you want to comment on that blunt trocar, which are safety trocars, generally we call it as?
So you can see the hissing sound, you will get the giveaway.
Yes.
Then I'll close this, I'll just put the camera in, then only I'll start the further pneumoperitoneum.
So blunt trocar and the safety trocars are totally two different things. Blunt trocar is meant for open technique of entry. Okay, like Hassan or any other blunt trocars. Wherein you do not incise, you incise the sheath, you incise peritoneum and you place the trocar directly under vision. And safety trocars are like VC port or self-retracting like Very's needle. Okay, they are actually not having any trocar or the trocars are under vision. So you create a pneumoperitoneum, you put a scope into the trocar, your trocar is transparent. So you can see when you are entering, you see different layers. So that is safety trocar. Another safety trocar is when you overcome the resistance, the blunt part will swallow the sharp part, something like Very's. So what happens in Very's is the same thing. As soon as the resistance comes, the sharp part comes forward and the blunt part is retracted behind. And as soon as the resistance goes, the blunt part comes and protects the other structure. So that's the difference between the trocars.
Sir, any tips for beginners that how you
Yeah,
can
so,
solve that?
so any trocar technique is not superior to one another.
Yes, sir.
Okay, it is one technique that you prefer, that you are very well versed with. You should continue mastering that particular technique, and then that is the safest technique for you, not for everybody else. So for example, now what Dr. Shintre did is, he did pneumoinsufflation from umbilicus and he put in supraumbilical. Now according to my practice it is totally wrong, but according to his practice it is totally right. So I should not be correcting him. But yeah, I can add that, if I am well versed with my techniques, then I can improvisation over a period of time. Then if the patient is getting unnecessary incisions, then I can change. But then that comes after you are very well versed with entry. Because in entry, most important is understanding the layers that you are traversing during the time of entry. So that gives you a very good haptic feedbacks.
Left side, okay.
Yes, sir.
साधा bipolar. किती लावलंय bipolarला? Okay. स्कोप कॅमेरा द्यायला लागलेत.
So before putting primary port, you don't keep the camera ready?
Yes, sir. It was supposed to come. So in surgical workshops,
I
some
agree.
limitations.
No, not like that. What I'm saying is that if we should not have put the primary port unless the camera is ready.
True. Completely true, sir. So few other important points that you should arrange all the cables.
Yes.
All the tubes.
So can you please show that arrangement of hardware? Yeah.
Yes.
So how do you arrange it?
हे card.
नाही नका काढू नका ना असं just describe it,
No,
sir.
sir. No, sir.
Again, don't remove it. Huh?
They
We saw you tying.
Yeah.
So that is
my
harmonic and
assistant mistakenly did that.
Okay.
It was not supposed to be tied.
Okay.
Yeah. So what you can see,
So you stand on the left side, right? And then, yes. Sir, Shindri sir.
Yes, sir.
बोला ना.
So the CO2 cable and the light cable is coming from the trolley, that is laparoscopic trolley.
Yes.
So this is usually lying on the medial side of the thigh.
Right.
Then it is coming and there should be adequate length so that the trocar can move easily.
Right. Yes.
Then the cautery cable and my harmonic cable is coming from this side. Usually, ideally, the cautery or your energy system should not be on your camera trolley. That should be on the separate trolley.
Why?
Because there are some electrical waves that travel through radiation or something, and sometimes you will get disturbances in the your monitor output.
Yes.
So that will happen in between your surgery. It will have some problems.
So if the earthing is common, then
Yes.
you get sometimes the disturbance.
True, sir.
Because
So-
what happens is they are centrally, I'll just add some points if you don't mind.
Please, sir. Please, sir.
So these are RF generators. So radio frequency. So radio frequency generator should not give any disturbances of muscles and the other things, but they will give different, some amount of disturbances in the signals of the monitor. So what you said is correct, that you put the generators on the separate trolley, or if they are put, then the connection also is separate, then it is also okay. You can place it in the same trolley, but the connection, the power supply should be coming from some other source.
How you can confirm that you are in, especially for the varies? We welcome anesthesia HOD in the operation theatre.
Gauze, please.
We welcome all anesthesia faculty in the operation theatre.
White balance कुठला आहे? sir?
Hello Hemant, this is Dr. Rohit. Could you please explain the CO2 insufflator settings, flow rate and everything?
So I usually prefer 10 to 12 millimeters. So if the patient is obese, sometimes I prefer 12 millimeters pressure. And if I am doing morcellation, then I prefer around 15 millimeters. So the flow rate is set at 5 liters and pressures are at 10 millimeters right now. So I was telling you about the cautery cables arrangement and everything. So usually what you can see, your forearm's length, double of the forearm length should be the cautery cable kept on your and then it should be fixed. And I usually prefer with the gauze piece or saline that pipes. With that I tie the cables and tubings because it is non-traumatic and you will get a good life on your cautery cables. So I have done the white balance. I have done the focusing of the instrument, focusing of the camera. Then I am putting. So as you can see, I am inside. I am starting the pneumoperitoneum. Gas चालू है का? Head low down, please.
Meanwhile, in second OT, we are inducing second case.
टेबल वर जात आहे का? लोएस्ट आहे ना? थोड़ा हेड लो करा. गॅस प्रेशर जरा 12 करा प्लीज. तिकडे हा. सो स्टार्ट विथ लोएस्ट. जरा एखादा प्लॅटफॉर्म आहे का टेबल वर गेलं. सो आयडियली युअर टेबल ऑल्सो शुड बी laparoscopy friendly actually. So some tables they are designed for ortho or uro OTs where a C arm can go below the patient. So for
Do you have a fixed practice or you also roaming around?
I am also roaming around, sir.
So when you have come across a case wherein you go there and you see that there is a ortho table, what would you do?
I would flip the side of the. What you can see, what you can do is you can
Rotate the
table.
the head end to the bottom and
Yes,
the bottom
sir.
end up.
Yes, sir.
So that changes the fulcrum.
Yes.
Yeah, okay. So that's another tip that is given by Dr. Hemant, that you can, it's not necessary that you need a specific table, but if the table is arranged before you take the patient in the theater, then it is much better. At times it happens that you understand this much later. So, but then before starting surgery also, if you change, it's still better, because otherwise the entire surgery is going to be slightly difficult.
Sir, how is the vision in the auditorium?
Yeah, it's very nice. Only the camera is fogged, but we can do that later on once he sir is. Can we increase the pressure for a while, till he's put the ports and pack the bowels?
Yes, sir.
I think even the head low will help him. Packing the bowel. So what I do, Dr. Hemant, is I take about 16 to 18 pressure just for 2-3 minutes. Okay, to begin with, and I give extreme head low to begin with.
Okay.
What happens is that you don't have to manipulate bowel for packing them up.
Okay.
The bowel goes on its own. And once the bowel goes on its own, after that you can reduce the pressure also, and you can reduce the head low one after the another.
Definitely, it's a good advice, sir. Thank you so much. Can we have that? A little bit more head low, please. And increase the pressure to 40, please.
This is orthotable.
So, secondary trocars, I always put under vision.
Right, yes. Secondary port should always be, as you said very rightly, because they are not defendable in the court of law. If you injure secondary port and you injure something, you are having complete liability of negligence on it. So it is very, very necessary that you have a recording of the secondary port, especially when it is coming inside. So that is one thing which is recorded. And how about you? Do you record all the cases, sir?
Yes, sir.
And do you give it to the patient?
I usually give only photos of
Pictures.
Important steps.
Okay. So, and do you have a permission, or at least told to some patient who is, very much aware about it, that we are going to record?
I have included one point in my consent.
Consent, right?
Yes.
Yeah, okay. But you don't speak and say that we do that. Generally what happens is, whatever is there in the consent, ideally you should have been
Communicating to the patient.
But it's not necessary, not mandatory. But what many people say, that I don't give any photo, I don't give any video. So as per the law, the documentation of whatever you document, like papers, when you write OT notes, patient has a right to have that OT notes. Similarly, when you record, it's a documentation. So patient has a full right. Patient has more right than you yourself, because it is patient's property, not yours. It's like my wedding album and my wedding videography. If a cameraman doesn't give me, I can just bash him, He cannot keep it and say that it is my property. So it is similarly, this is patient's property. So you must have a very empathetic way to understand that if they need video, photo, you can ask for hardware, that you can give me pen drive, hard drive, and we will give it to you. And what quality you have to give, that also you can decide. You can also put in your watermark or whatever you want. All that you can do. But you cannot deny if you have recorded. You can delete it and say that it was not recorded. Now that's a different issue altogether. Sir, how do you prepare bowel before surgery? Like, what is your protocol?
I usually tell them to take a liquid diet around 12 hours, she should be on liquid diet. And from overnight, I usually do my surgeries in early in the morning. So from myomuscular. So from 12 o'clock in the midnight, she is NBM, nil by mouth.
Yeah.
I give 2 tablets of Dulcolax and 2 tablets of Gasex
Okay.
to the patient.
What is Gasex, sir?
It's a Ayurvedic preparation, sir.
Okay. But are you allowed to prescribe it? As a...
So they are allowed.
Sorry, I'm just taking you.
Yeah, they are allowed to prescribe allopathic medicines. We can prescribe.
So as for the Ayush, we can prescribe any medicine now. Anyways, so you are using manipulator also and the screw also?
Yes, because it's a large pathology on the posterior side.
Otherwise you don't use?
No, sir. For simple size uterus, I don't.
Can you clean the lens bit with either betadine solution
It
or
is getting frequently fogged. Thoda sir, what is the temperature?
No, this is not fogging. This is debris on the scope. So if you can just clean it with a diluted betadine solution.
Yes, yes.
And go without touching the flap. The cameraman, when he's entering, ask him to remove the flap. Ah, yes, thank you so much. Yes, lovely. Amazing picture. Yeah, lovely. Okay. So your choice of instrument is harmonic.
Sir, I got trained under Dr. P.G. Paul.
Oh, wow. Okay.
So there I learned on this NC and harmonic.
Okay, okay.
So they are kind of.
Yeah, PG Paul sir is very senior and there,
Yes,
I'm
sir.
sure she is getting all very affording patients. What about your setup and type of practice? I mean, generally what happens, suppose I learn a car on a Mercedes Benz, then I will not drive Mercedes Benz because I will
No,
see.
sir, I have shifted to bipolar shearers.
Okay.
But always my comfort is on the
Of
harmonic.
course, yeah, this is preferably. So can you tell us some functionality of the harmonic and
दोन्ही बसना नाही खाली ठेव. I'll use. Don't worry. Yes, sir.
if you can hear?
I'm really sorry. Can you repeat the question?
Yeah, so if you can tell us about the functionality, how the principle of harmonic scalpel, how it works.
So, see, sir, I'll just take a few moments. I've shifted to bipolar shearer
Okay.
for my routine cases because it's not really what you can say economical to use harmonic in all cases.
Okay, fine.
What I had first done is I tried coagulating with bipolar and then using harmonic for cutting. That helped me a little bit on longevity of my harmonics a little bit more. But then I shifted because of what you can say, I was under Devkare sir also. I was seeing Yogesh Shirguppe sir also and our Drodacharya, Anil Magdum sir also. So I shifted towards that. So there are all energy devices available in market.
Yes, yes.
So whatever what you can say a good learning curve, then only you should shift towards another energy source. So harmonic, this is ultrasonic energy device.
Okay, sir.
Yes, and there is what you can say an active blade and a passive blade. So what you can say, which is in line with the shaft,
The straight one, the straight
one, that is the active blade.
And it's immobile.
Yeah, it keeps on vibrating at
Yeah, of
ultrasonic
course, of course,
speed.
but it doesn't move like how you see major.
No, this is the movable blade.
Yes.
And this goes on in and out,
Understood.
inside the shaft. So this is the active cutting or coagulating blade, and
So
this
how
is
does
for
cutting
holding.
takes place, sir?
So it vibrates at ultrasonic speed.
Like what speed?
It's in the ultrasonic hertz frequency.
Okay. So that is 55,000
Yes, sir.
times, 55,000 times per second.
You cannot
That's a
visualize
very-
it.
Of course, you can't visualize, can't even hear.
Yes.
Only you can hear is the sound of tissue or the machine. Okay. So then how does it cut and how does it coagulate?
So you can throw some light. I'll just.
Okay.
Yes, sir.
Okay. So harmonic basically when it vibrates, the strong ultrasonic vibration of 55,000 times per second generally breaks down the hydrogen and the oxygen bonds in the water molecules of the cell. And when the water molecule is broken down, the tissue denatures. It becomes denatured protein. So whenever the protein is denatured, like if you break an egg, it has a structure, some structure. But when it is denatured, it loses its structure. So that is how it gets cutting or coagulation. So it is a limitation in coagulation, but
Yes.
Hemant,
That's why I use bipolar and
yeah,
harmonic.
right.
Yes.
What is this bipolar that you are using is what company?
This is Bissinger.
Bissinger, huh?
Bissinger.
Is from Germany.
Yes.
Hemant, you have put in a vaginal manipulator as well as you are using myoma. Won't there be limitation to or a resistance to manipulation if there is a vaginal tube or vaginal probe?
Sir, when I am using myoma screw, my vaginal assistant is just holding that. He is not manipulating right now. When I'll be going towards the bladder dissection or what you can say vault opening, that time his active part will be there. Because it's a large pathology, I prefer using both. Because just uterine manipulator might not be able to completely elevate or deviate or manipulate the uterus inside.
Okay, actually you are losing one port, so that makes it very slightly difficult. Of course, with the, so if somebody can give a traction, that's perfect. Nice. Also at times people inject vasopressin before putting in the screw.
True, sir.
I have no such experience. And you are not removing the ovaries?
I am removing the ovaries, but I will remove it afterwards, sir.
Okay.
They keep on coming in the field while doing the surgery. So I will be removing afterwards.
Right. Okay. So even I used to do that because that is what is the traditional teaching. But like last about 20 years, I have not done that. Because suppose if there was a pedunculated myoma, would you keep it away from the body of the uterus? No. You would continue taking it. So if you keep that mindset, what happens is you are taking 2 pedicles twice in a surgery.
True, sir.
If it is for teaching purpose, it is very, very good for the students. But generally what happens in India is that we are loaded with a lot of work. We don't have only 1 or 2 cases in a day. We have to do multiple cases plus a lot of other things to do like OPD, unless like in Europe, they do only 2 cases a day and that's what the entire work that they have. So that is fine, but here it becomes slightly challenging for us to keep up with the time. But yeah, at times it makes sense to separate it because you get a good traction. Now see, your tube is already there on the uterus. So if the ovary was also there, it would be okay. But it gives a good traction at the end of the surgery on the IP for you to have a good sealing there. So now I see that you're reaching broad ligament.
Yes, sir.
And harmonic works perfect and beautiful in broad ligament especially. Because it creates a cavitation, right?
Yes.
It gives a good dissection wise, it is a wonderful tool. Any other thing that you like about harmonic that you want to tell us, that what you like to do?
It has very minimal spread, lateral spread, sir.
But that is for the patient, not for you. For you, what is the most important thing?
For me,
as a surgeon.
Yes, sir. For me, I get the liberty to cut as much tissue I want.
Yeah, so basically if you are not very well versed with the tissue, harmonic can also cut bones.
Yes, sir.
Okay, so it is very good for the surgeon. Surgeon can go endlessly cutting, and as we say in our training period, cutting mila kya? That particular satiety gets satisfied with harmonic.
True.
So, but you have to be very, very cautious, you have to be understanding your hunger that you are full now and you should not continue cutting something.
True.
So that is one thing, is very surgeon satisfying. That's why most of the surgeons who use harmonic cannot give up. It's like the small child liking sweet and then they continue eating it for life. So lateral spread, I would argue with the harmonic as well as the shearer or a bisector that we use nowadays. Okay, it actually is operator dependent. There are so many people when the harmonic came in market, purchased harmonic, did couple of cases, injured ureter, bladder, bowel, and kept the harmonic just like that packed. Have never done any case. So what happens is that you should not think that some instrument is safer than the other instrument. No, one surgeon is safer than the other surgeon. Am I right, Dr. Hemant?
True. Completely true, sir. And another thing I like about harmonic is it's not bulky.
Yeah, it's very light to use because it is made for single use. If you don't know, I'll just throw some light on the anatomy of harmonic. Is it okay?
True, please.
Okay, so this harmonic scalpel, in the shaft there are nodes. Okay, there are multiple nodes. There are 6 to 7 nodes depending upon what generation shaft it is. At every shaft it is designed to amplify the number of vibrations or the amount of vibration. So the generator, let's say it gives 25 or 30,000 times vibration. At first node it will amplify to 40, then the second node it will amplify to 45, and at the terminal end it will be 55,000. So if the nodes are very delicate, so as per the use, the node starts getting damaged. That's when Dr. Shintre, you must have experienced that some harmonic scalpel after 2 uses, it doesn't function very well.
Yes, sir.
So if you want to prevent that damage, it is very mandatory for you to periodically clean during its use.
True, sir.
So when you are using it, don't allow too much of debris to collect on the terminal end. Otherwise, it will require a lot of amplification. And in amplification, there is a lot of temperature gain at the silicon nodes and they break. So this is something that you would not find in.
I usually keep a soft, ultra soft brush on my trolley, instrument trolley. And whenever there is too much debris on the blade, I usually prefer to clean it in between. So just remember that any energy source has to be perpendicular. If you are finding it difficult, because you will be dealing with the least possible diameter of that vessel, and you will be getting maximum output of your energy device. So sometimes when you are dealing with large pathologies, you may find difficulty in getting the correct angle. So don't hesitate to change your instruments in between. Undue tension or undue handling can land up with some problems. So another important point is don't go too much near to the uterus also. Some, because of fear, undue fear, they might go on this side and end up injuring some of the branches of the uterine artery, the spiral branches. Am I audible?
Yes, you are audible.
Yes. So just keep adequate distance. Don't go too much medial, don't go too much lateral. Whenever you are dissecting, you can use in avascular spaces a small dissecting movements. You will get planes, and then you can allow the air to enter and then separate the tissues.
Hemant, telescope 30 degree है और 0
30 degree है sir.
Okay.
तू फोकस कर हाँ स्क्रीन तेरे दिसू दे.
At what stage we'll start opening the leaves of broad ligament?
Sir,
From laterally or central?
yes sir. असं. असं. धरा असं. दाबून द्या.
Am I audible?
Yes, yes.
Harish sir, Vivek sir, Anil Magdum sir, we welcome you all.
Good morning, Vikas sir.
Yes, sir, I am about to start second TLH scar uterus. Someone must have narrated the history there.
No, nobody.
Will you please narrate the history from MOC?
Yes.
Sir, you know the history, you tell us.
Yeah, sir, it is, she is 42-year-old female.
40?
42, sir.
Okay.
Sir, she is having previous 2 scars and both scars are horizontal only. She is little bit obese, weighing around, sir, 91 kg.
Okay.
And her uterus is almost about 12 to 14 weeks, adenomyosis, and she is posted for abnormal uterine bleeding.
Okay.
And before I start, I wanted
So the
to...
previous to cesarean, huh?
Yes, sir, yes, sir.
So with such a obese patient, you will take any precaution while positioning the patient?
Yes, sir, definitely. First thing that we have to take care of all the nerves, whatever there are in the legs and the hands.
Okay, okay.
So your position should be like that only. We are not going to damage anything. Because surgeons and everything always they are busy with the taking out the uterus anyhow. So
Right.
no one is taking care of these things. So I prefer generally that whatever the comfortable positions in which the nerves should not get compressed while
Okay.
positioning your legs specifically, so that the tremendous positions and the table should be that specifically where we rest the legs. That should-
Understood.
Yes, sir. Well
And what
padded.
about the arms of the patient? Do you keep them both on one side, on the side, or?
Sir, both on the patient side only. We use that extension of that IV
Okay.
set, sir. Yes, sir.
Anything to remove the tilt of the pelvis if the patient is really obese and sometimes?
Yes, sir. Sir, we simply use, sir, one 500 ml NS bottle just below the, this one, the, just back of the patient.
Okay.
So it will lift the, this one, sacrum.
Right.
And all the upper bowel will be, or the lower bowel will be shifted in
Shifted
the
up.
upper abdomen.
Yeah, okay.
Yes, sir. And as you rightly told that we initially we take the pressure to some high extent and then we slowly decrease that.
Understood. Great, great.
Sir, I wanted to show some what instruments I generally use for routine.
Please, yeah, go
So
ahead.
external camera, can you please?
Yeah, it is there.
focus on
It
this?
is focusing on your
So, sir,
trolley.
for easy understanding, we have made one rule of 2, sir.
Sorry to interrupt you, but we are also seeing Dr. Hemant. Please continue. You are doing wonderful dissection on the bladder.
Thank you, sir.
We finished seeing that and we are with Dr. Devkare for a while.
Sir,
Sir, go ahead.
sir, we generally follow, sir, all whatever base
Okay.
me is in Mumbai. So, sir, we have made one rule.
No,
that-
your voice went away in between. You can start from beginning.
Yes, sir.
Yeah.
Sir, generally I follow you people that Vivek sir, you, whatever you have taught me in Mumbai, so I just follow that. Little bit changes I have made while practicing
okay.
in the last 5 to 6 years.
Amazing.
So sir, I use, generally there is rule of 2, sir, where I use, sir, all two instruments on my table so that there should not be any difficulties while taking out the.
Only on the OT table that rule
Yes, sir.
applies, huh? Not nowhere else, no?
Yes, sir. So, no, no, sir, that is secret. I should not reveal here in this one social media. So you
Thank you,
can
sir.
see that 2 metallic trokers, 2 plastic
Okay.
trokers, sir,
Yes.
specifically we call it as apple troker.
Okay.
One is one is of 10 mm, one is of 5 mm.
Very good.
Okay, and then if you see that all laparoscopy instrument will be of 2 in number. So 2 graspers, one for assistant graspers whenever required, one for me.
These are atraumatic graspers.
Yes, sir, automatic.
Does it have a ratchet?
Yes, sir, definitely.
Okay.
But sir, while operating on, whenever I put this inside, definitely I will keep
The
it.
ratchet
open.
will be open. Yeah,
Yes,
yeah.
sir.
Okay.
Then sir, 2 needle holders.
Okay.
Sir, then 2 Myma screws. Generally,
So
we-
both these needle holders are identical or they are having some changes, slight
Sir,
changes?
no, sir. What Vivek sir was following since long days,
Ah.
I just use that. So it's long curved at the end, sir. That's it.
Both of them are curved and toothed.
Tooth, sir. Yes.
Okay.
Because they help me a lot for doing
Yeah,
hysterectomies and holding
Yes,
the
yes.
vault and.
again, keeping two separate will confuse.
Yes, sir.
Which
yes.
one is coming in your hand, which one is not.
Great,
That
sir,
way.
great.
Yeah, and then 2 screws.
2 screws, sir. 2 screws mean just to save the time. Suppose while that taking out that Myma screw from the opposite port, or when pathology is bigger, we use simultaneously both the for the good traction.
Okay.
And then, sir, these two instruments I wanted to highlight. One is plain bipolar forceps. And sir, one shearer, that is bipolar sealer, bipolar cutter.
Yes,
or
got
sealer
it.
cutter.
Shearer, yeah, okay.
Yes, sir. And then, sir, we need only one suction, one scissor. That's enough, sir. That will be my
So
trolley.
certain things are only one, huh?
Yes, sir.
That's
And
good.
two speculums, two that one towel clips, two arteries, and two this one helices to take out the specimen from below.
Right. What else?
That's
For colpotomy, what do you use?
Sir, I directly open at the fornix with my shearer only, sir.
So you use your head.
Yeah, yes, sir.
Okay, that's
Sir, no
nice.
fancy instrument from below or no fancy instrument from the above. Generally, here, wherever I practice, we call it as the Garib gynecologist.
Do you always, there is nothing like Garib gynecologists. All gynecologists are very rich. You have not seen Garibi in the country. If you go and see farmers, cobblers,
Yes,
and potters,
And seriously, I tell you, sir, only both person will be operating, sir. Only one
gynecologists are
assistant.
rich.
Only one assistant in front of me, and that's it. Lastly, we are going to wash one single.
No, Vikas, I'm sorry to interrupt, but
Sorry, yes, sir.
you cannot be Garib, but you can be Garib's gynecologist.
Yeah.
मतलब गरीबों के gynecologist. So गरीबों के gynecologist will use very few things and do the same result by using it very efficiently. So arrangement of your hardware, please.
Yes, sir. Same whatever Hemant has told, sir. Absolutely, we use that one only. So whenever.
And you always keep this the drape high up like that on the IV set
No, sir. Today.
because that hinders the camera movement. No?
Yes, sir. Little bit.
Yeah.
Definitely, sir. Here I wanted to highlight one thing that while putting your primary ports, you always the patient should be flat.
Perfect.
And when you put your secondary trocars, your patient should be in the working position. That is head low position.
Right. Why is that?
Sir, because if I put that my 10 mm trocar in this one head low position, sacroiliac joint will be lifted up. At the same time, sacroiliac vascular system will be lifted up almost by 3 to 4 centimeter. That one. So there are chances
Right.
of hitting
Chances
the
of
vessel.
injury, yes.
Yes, sir.
Again, chances of tracking the port increases by changing the
Yes, sir.
position.
It's very high, sir. Yeah.
So generally you put your port straight at the perpendicular side or slightly track it down?
Sir, I put perpendicular whatever,
Right.
but
Okay.
as you said rightly in the beginning, when patient is very thin, I little bit take care that I lift little bit. I give
Yes,
angle
I'll
towards the
continue.
rectum. Yes, sir.
Hello, Vikas, could you give us an idea about sterilization of the equipments?
Welcome, Rohit, and see that I use only autoclaved instruments. So whatever instruments I have just shown you, everything is autoclaved except that my shearer and all that we take it from the Sidex. But no formalin.
Okay, we are seeing that, yes.
Yeah, sir, so before I give any incision on the patients, I always check everything is working or not. So even I myself checked whether this cautery is working or not, and all cables are well arranged out, not even the suction machine and this one irrigation system is there or not. So I checked my trolley myself, I have checked the position of the patient, the height of the table, I have discussed with the anesthetist, I have once one look on the patient's monitor also, what is the pulse BP, because whenever, as you rightly said just before that, when I put the pneumoperitoneum, there will be the sudden or the shock to the lungs, what is happening to me, and there is always decrease in the tidal volume and there is load on the heart will be increased. So just before give anything, so if the pulse and all this in the same range while taking the pneumo, so that's gives me idea that everything is, patient is tolerating well to the CO2, so I can start my surgery.
Okay.
I am not various person, I am direct trocar person. So if external camera can show this one.
Can we go to the other OT for a while?
Yes, yes,
Is
sir.
it
Yes, sir.
possible?
Yes, sir.
We
Yes,
just
sir.
want
Sure,
to
sir.
highlight certain things there. so
Yes, sir.
that-
Sure, sir.
Yeah, bowel preparation will go back to him again and ask him. But I want to know, Dr. Hemant, are we with you?
Yes, yes, sir. Tell me.
Okay.
Hello,
Hello?
am I audible?
Yeah, you're audible. So we saw you taking the uterine.
Yes, sir.
And there is some hemorrhage. Slightly. Yeah.
Slightly,
Yeah,
sir,
yeah.
because
It's not, this hemorrhage is not going to cause any
Yes.
hemodynamic issue, but it is going to cause surgical issues.
yes.
Can you please highlight what is the strategy that you
Actually, myoma is on that side.
do? Okay.
So a little bit vascularity is more that.
Understood, yeah.
Yes.
So what is your strategy then when it bleeds? Suppose it starts bleeding, so what is your strategy to control it?
So basically,
So what you're doing right now is a perfect thing what you're doing.
yes, sir.
So you will
what I
start
usually-
evacuating the blood which is there, because with the bleeding continues, yes. Yes, sir, tell me.
we have to visualize properly from where the bleeding is happening.
Yes, so you use suction.
I clean the camera.
Okay. Okay.
Then I visualize from where the bleeding is there. So it's just the collected blood or backflow of the blood. That's what I feel. So what I'll do is, if I'm finding any difficulty towards the difficult side, I'll just apply the pressure and I'll go towards the normal side because it's not pulsatile bleeding.
Yeah,
right
so
now.
even with the traction it stops at
Yes,
times.
sir.
Yeah. So it's a venous bleeding which is there, and that's why you would like to do this strategy.
Yes, sir.
Okay. But you should never do coagulation in the blood pool, because that's the most hazardous thing.
Never.
One thing is that it will carbonize the blood and make your bipolar not work on a proper area of your interest. Another thing is that you in the pool of blood, what you are coagulating, you don't know. So it's better to avoid that. Clean the pool and then clean the bipolar, clean the lens, as Dr. Chindre said correctly. Are you putting additional port?
No, sir. That trocar came out.
Okay.
Usually, I also use trocars with what you can say screw-like serrations.
Okay.
But I had few cases yesterday night, so
Okay, no problem. Yeah, I can understand, don't
yeah.
worry.
But usually it is preferable to use trocars with serrations because they don't come out easily.
No, I generally don't use that way because it gives a very bad scars. But it is personal preference again, what you wear. So something like that. So it's fine. Whatever you are using is perfect.
Hath khali.
But yes, the threadless trocars tend to come out with manipulation.
Yes.
So because when you use screw, you tend to do a lot of traction and counter traction, and that makes the trocar very loose. Now you're taking the uterine on the right.
Yes, sir.
So what about the posterior peritoneum?
I do, sir.
Okay, skeletonization.
Yes, sir.
So some advantage of skeletonization if you can
Because
highlight.
it will take your ureters away, sir.
Okay.
Now from both the OTs, Hemant, I would like to know which is the camera which you are using. We could feel the difference in both the vision. Both the views could seem different. Both of us, can you tell us which camera you are using? Both of you?
So I usually prefer after
No, right now what camera are you using? That is the question.
Pardon, sir?
Right now what camera are you using in the OT?
Sir, I have two OTs. I have one Esculap 3D, sir.
No. Right now means right now.
Right
on-
now,
on
okay,
the-
sir. Okay.
Yes.
So this is a Univ Labs camera, sir.
What is it?
Univ Labs.
Okay. So it's a 4K camera.
Yes, sir. Yes, sir.
Okay. Now, because there are two parallel OTs going on, so the
Yes, sir.
audience would like to know which is what camera. So this is definitely Karl Stroh's Carrara Chroma, Karl Stroh's Image 1 Spice, and
Yeah.
yours is the camera make is some other company.
Yes, sir. Some
I
Univ
didn't get the
Labs.
name.
Yeah.
Okay. So we can go to Dr. Devkare.
Go ahead. Put it.
Vikas, are we with you?
I can hear you, sir.
Yeah, okay. So you did the internal cleaning of the
Yes, sir. I just
highlighted, come in the cannula, no? Come the camera in the cannula.
yes, sir.
Please come.
I just cleaned up.
Come
sir.
back. Yeah, come back. rotate your this thing.
Able?
So please keep the endoscopic view. Mixer. Go back. Put the cable down 6 o'clock. So you see, this is the highlight. The cleaning of the cannula inside. Dr. Vivek is here now.
Welcome, sir.
Welcome. Thank you.
Put please. So I just came in, sir, and what we were discussing, these adhesions generally we come across, so that whenever I want to just release these adhesions, I should not start from here. It should be always start from the base of that anterior abdominal wall. And being I'm going to using that shearer, so you may get some kind of fumes inside the abdominal wall. How is the vision, sir, there? I'm using spice. Am I audible?
Vision is good.
Vision is good, okay. I am facing little bit difficulties, and that's why I'm asking. Okay, so I was discussing that whenever I want to take out these adhesions, make sure that you are not taking bowel in it. Okay, and this, as I have already told that this is shearer, so the long blades, we should not take the long, the long length of that, this one, adhesiolysis band in it. So just millimeter by millimeter and fiber by fiber dissection. Now you have noticed that I have stopped from here and I am going somewhere where the thinnest part is there. So I will just take out this, and now this is clear. So I will just open divergent force of this my grasper, and I will open up and I will see. So this is clear. So again I will come upward and I will start dissecting from this end. So it will start going down. Can my assistant please take out little gas? I am little bit getting the hazy vision inside. So now I have seen that, so this area is clear. I have not taken my screw inside. Hello?
Hello.
Yeah. So now see that my cable has just turned down, so I can able to see the nicely on the anterior abdominal wall, or the posterior part of the anterior abdominal wall, so nicely, so that I can take out these adhesions effortlessly. So these are flimsy adhesions.
Hello.
Yes, sir.
You are audible.
Dr. Vikas, we would like to know the make of the cautery and the cautery settings.
Yeah, actually I am using here Allen generator, and cautery setting generally what I keep the ligate mode on the 2 and the cutting mode on that 5. So that you can notice that right now I'm using only my both hands only. My assistant is doing nothing. And right now I'm tackling only the adhesions. In the lower port, on my left hand I'm using to just release the adhesions. And in the my right hand I'm using that camera with myself, because I know where I'm going. My assistant or the camera person may not know what next step I'm going to do right now. So almost we have done with this one omental adhesions, and now you can notice that uterus is ventrofixed, and as soon as I reach here, so the main problem here, sometimes this may not be the uterus but maybe bladder. So from here onwards I have to be very careful. So now if you see that still some bands of flimsy adhesions are lying into the lower pelvis, I am just clearing it that.
For bipolar Vikas, if you give traction, it is easily cut. So if somebody can, for omental adhesions, pull it from below with a good traction, it will easily cut.
Yeah, absolutely right, Rohit. I have just discussing with my assistant, and he has already taken that one grasper in his hand, and he is about to come inside. So if you notice that he has taken that grasper and he is just coming there, and now he will just retract these bowels. Vinayak, bowels, And now you can see that uterus is little bit 12 to 14 weeks size and it has come out of the pelvis. So here I am expecting that sacral promontory and these are the all adnexas. So my first step in any of the hysterectomy, we always start from the sigmoid colon adenolysis. So these are our standard protocols that we follow in routine cases, whether they are coming in my way. If they are not coming my way, still we follow the same principles. Generally, we don't change our protocols because my assistants, they are well trained with me routinely what we follow. So we just follow the same techniques what we do routinely. Camera. So now my second, now I have given my camera to that my assistant, and now I will start idealizing the sigmoid colon first. So here you can notice the nice traction is given by myself, and here we need to start from where to start. So, and see that I am not holding bowel, but I am holding that mesentery. And now I will give the sharp the camera.
Hello?
Yes.
Vikas?
Yes, sir.
Can you focus it a bit or clean the lens or something?
Sir, before that I would like to welcome you in Miraj. Welcome Sanjay Shanbag, sir.
Yeah, thank you.
Yeah, sir, Vinay, sir, camera clean करें, थोड़ा सा focus कर. So we did all that white balancing, and we have checked I have checked myself yesterday only whether these systems are working or not. But today I am not getting that circular vision what generally we get on that SPICE camera.
No, the outer ring maybe you might have to turn a bit, no?
Sir, outer, sir, I did up to maximum possible I did that.
Okay.
Still, sir, I am not getting that.
Okay.
I don't know suddenly what has happened to it. Will you थोड़ा सा uterus lift कर?
Hello, Dr. Vikas.
Yes, sir.
There is one question from
Yes,
audience.
yes, please.
Kindly explain Shearer practical aspects, how to use the instrument with the settings and simultaneous foot movements. Means he want to say ki, when to use cut mode, when to use coagulation mode, and how to use that Shearer.
Yeah, it's very nice question whoever have asked. The thing is that, see that now, if you see that till time, whatever I have used is only cut mode, yet I have not used any kind of the coagulation mode. Only because this, I am expecting there is very little blood supply to this, all this, only capillaries are there. So it is working as good as harmonic only. So just little, every time when I want to cut, now see here, I will just show you the demonstration. So this tissue is little bit avascular, and I don't want any kind of coagulation current that much. So I will use cut mode. It is Allen generator, Allen foot pad. So my middle foot pad, which is in yellow color, which is written as cut mode, and I have kept my setting as C5. So now see here, I will just take this and I will just lift up. Now see here, so I have just, my assistant has taken the bowels away. So this is my correct plane, and now I am firing my foot pad. Now see here. Can you see this? So little small, even I am giving small tug also. So it will just retract. So it is good dissector also, it is good coagulator, as well as it work as a scissor also. But if you talk about the lateral spread, I am not little bit happy with the Shearer. Always harmonic is better.
Do you dissect all the cases, all the patients with sigmoid adhesions? Will there be some sort of adhesions there? Do you dissect it in all cases, or?
Yes, Rohit, I dissect in all cases. There is no option for that, because see that now, can you see this, whether it is enlarged or not? Suppose I wanted to take, because most of the cases we take out the ovaries also wherever indicated. So I wanted to suppose start at this level. So this part should be free. Now see here, this bowel was almost up to this level. So, and it will hinder my vision also if I wanted to go for some time at uterine at its origin. So I have to take out, I have to dissect this pelvic triangle. At that time, definitely that sigmoid colon should be away from me. Now see here, now I am going to use my coagulation current. So I am pressing my extreme left foot pedal. I have just little bit cauterized. See, very small burst I have given, and now I am cutting. So cauterization was like this, and now cutting only small part I am taking. So this is something called as fiber by fiber dissection or millimeter by millimeter dissection. So this trick we have learned from Vivek sir and Sinjini madam. Routinely they were using that, and they use harmonic. I use here Shearer. That's it. So in this case, I'm going to keep the ovaries, and she's just 42-year-old. And now see here, while taking out the tubes, you should be very, very close to the tube. So because this is the blood supply to the ovaries also. Can you see these vessels? How is the vision there? Sanjay?
It's better, yeah, it's better.
It's better. So now I will just take out this tube and I will try to maintain the blood supply to the ovary. Okay, so now I will, generally we keep this ovary, this tube as it is, though sometimes is comes in my way, but now see here, this, now I just move forward. So here the message to the newcomer is that when you start from the adnexa, so whatever structure is coming in front of you, start with that. So now round ligament is welcoming me, so I will start with the round ligament. So can you see this? This is the round ligament. Okay, so now little bit good size uterus or the large uterus. So I will not go very close to the uterus. So I will start somewhere here. So this is ideal. I'm not going too much laterally. I'm not going too much medially. If I stay too much medially, I may hit the uterine vessels there, not uterine vessels, that blood supply to the uterus. Very at the cornu level, there is blood supply is too much. Okay, so now, so three structures will be there. So I am tackling the broadly, this one round ligament now. So as soon as this one cut the round ligament, I am exposed to the retroperitoneum and the anterior lip of broad ligament is opened up. Can you see this? And now I will just come back and now I will handle the, now I am going to put the myoma screw soon. So before that, the tubes already, the quadrates well. So now what I will do, I will just hold the ovary, but now see here my instruments are crossing. So this is not the ideal way. So what I will do, I will change my instrument to the right to left. I will hold the ovary with my one hand and I will start dissecting or the coagulating and cutting the ovarian ligament. So here is the ovarian ligament. I will use the 3-clip method. So one is very close. Can someone take out the gas please? So I am just tackling the camera. So now I am going to take the manipulation with the myoma screw. So 1, 2 and 3. So here this one, the trick is that, so that bubbles should form, bubbles should increase and bubbles should stop. Or your machine, the cautery machine will give one alarm that the vessel is completely cauterized or that tissue is completely cauterized. If you see now that bubbles are completely stopped, so now I will start dissecting the or dividing the ovarian ligament. So as see almost the ovarian ligament is done. As soon as I open up, the posterior lip of broad ligament will be opened up. So can you see this? Now everything is clear in front of me. So but yet I have not seen this one uterosacral ligaments. Okay, so now I will just lift here and now I will tackle the mesosalpinx. So main culprit at corneal bleeding is not ovarian ligament, round ligament, but it is always the mesosalpingeal vein that is very dangerous. So what I am now tackling is the mesosalpingeal vein. Okay, so these three structures are very crucial because it is all about the surgeon psychology. If you get bleeding at very initial part of your surgery, so it is little bit psychological upset will be there and it will affect your further surgery. So now can you see this? The corneals are done and I'm just trying to expose the both leaves of the broad ligament. Okay. So now I'm going to put the myoma screw. See that? And one more thing I wanted to tell here that that pedicle will carry its own blood supply. So that round ligament will be carrying its blood supply. We call it as the Samson's artery. The tube is having that mesosalpingeal vein and the ovarian ligament is having the one more vein. So always make sure that myoma screw please.
Vikas sir, Soumil here.
Yes,
I would like to shift the focus to Hemant sir. Hemant sir is at a very crucial step.
Yes, please go ahead.
Hemant sir, can you explain what we are at vault right now and you always prefer to use harmonic while opening the vault?
No. I use many surgical energy devices.
Okay.
But with harmonic, you have good coagulating as well as cutting effect.
Excellent.
So you are fast when you are doing surgery with harmonic.
Yes.
But if I am doing with, I usually use monopolar hook also for vault opening.
Yes.
But when you are at this level near to the uterine artery, So at 1 o'clock and 4 o'clock, this region, there are many, what you can say, branches of ascending cervical artery.
Yes.
So you might get a lot of bleeding, and it is really cumbersome to handle that when you are doing surgery.
Yes.
So usually what I do is I do a quite good amount of bipolar here and here when I am doing it with monopolar hook. And I usually use a monopolar blended current when I am cutting in here. So it's a blend of cutting plus coagulation. So it will give you quite good results.
Okay. And you always open the anterior
First, and then I'll go back. And I usually do not prefer cutting the uterosacrals completely. I maintain this U. Can you see this inverted U?
We maintain.
So I prefer maintaining.
Yes.
It is said that because I have not done that much years of practice, that's what my teacher told me about. He says that it decreases the occurrence of word prolapse afterwards.
Absolutely.
So maybe my TLHS cases, I'll see them as a follow-up case after 5 years or more when they'll reach that stage. But I prefer doing that, and then I'll be having a great idea about what the results are without cutting the uterosacrals.
Okay.
But when you open the vault from the posterior side, you have to cut the uterosacrals first, and then the vault is hanging down.
Yes. But sometimes with the amount of weight uterus has, it becomes difficult to cut the posterior aspect later.
True.
Sometimes. Yeah.
True.
We'll shift the case to Vikas sir. Vikas
Yes.
sir is at the very important bladder dissection. part.
No problem.
Yeah.
Vikas, yeah, hello, can you hear me, Vikas?
Sir. Yes, sir, I'm with you, sir.
Yeah, tell me, this is a very interesting part of the surgery that you have come to. Where exactly do you decide where to cut? Is it closer to the peritoneum? Is it in the middle? Or is it close to the uterus? And why?
Yes, sir. So first thing is, sir, if you have noticed, when I started, because little uterus is big, I just started to take out the cornu from here. So I got stuck. My instruments are just hitting here. So then I tried this one, I got failed. So now, before I start cutting anything, I have just confirmed, because I was here about to open the UV fold anteriorly, and I have confirmed that bladder is somewhere here. And now the big question was that whether that bladder is coming on that side of this one or what. So I just took little bit risk and little experience to cut the uterine wall here. Whatever I cut, and you must have noticed that whenever I saw this yellow thing, I just stopped and I took the shearer back, because I was expecting, whenever I see the dictum almost explained by Kundambekar sir worldwide, that is, the fat belongs to bladder, fat belongs to rectum. So I just suspected there may be bladder or something else. So I just little bit, and I was a little bit worried for this one, but whenever that uterine tissue was there, I was using my full pace of my blades of that shearer, and whenever the peritoneum or yellow things were coming, I just taking very small part of this one.
Okay, excellent. See, each one has got his own way of doing it, and each one has got his own experience. But
Yes,
what
sir.
generally happens is this part, there is never the bladder, and behind this adhesion, there is one small window,
Yes,
after
sir.
which the
Yes,
bladder
sir.
will come.
Yes, sir.
And if in this area you go very close to the uterus, now you will encounter bleeding.
Yes,
So
sir,
generally
correct, sir.
what we do is we go very close to the peritoneum in this area.
Yes,
And
sir.
once that window comes, now, then the bladder comes after that window. There will always be a window. Now here you can go very close to the peritoneum up.
Yes, sir.
And then there will be a window, and then you will come across the bladder.
Yes, sir. And one more thing is that, sir, it's tactile sensation what I'm getting to my shearer.
Absolutely, absolutely.
Yeah, sir. Now, so see, this is definitely not the bladder. This is definitely not the bladder. And as soon as releasing, the uterus is falling down. And now this yellow part has come, I should be little bit careful. And instead of going too high, I will just check from the reference point, that is virgin point, I will start and I will come to the midline adhesions. So now this is little bit cooperating.
Hello, Vikas.
Yeah,
Hello.
yes, sir. Good morning, sir.
Good morning, good morning.
Yes.
Excellent dissection and very good picture here, the audio visual transmission.
Yes, sir. It's all because of your blessing, sir.
So, one more thing, you are applying a good traction on the uterus.
Yes, sir.
So that also helps. And as Dr. Sanjay said, ki you don't go very close. You go close to the abdominal wall. So don't leave a lot of uterus on the abdominal wall.
Yes, sir, yes.
Second thing is there is a small chance that you go in that retropubic space.
Yes, sir, space of yes, I was about to mention.
Yes.
So if I go from here, I will be going above the bladder. So one should not be doing that.
Yes, yes. So the traction helps you, and then
Yes, sir.
most of this ventroplex uterus, this part you will never get the bladder. Bladder will be down.
Yes, sir.
Yes. Good.
Sir, how are you? You traveled night completely. I was worried about that. Sir, did you sleep in the night?
Yes, yes. I am.
Sorry, sir, for troubling you. I know that yesterday you are
No,
operated.
it is very
so
nice,
many endometriosis cases and
Meet
still you
everyone
managed to
here.
come here. That's thanks to Anil Magdum sir and Haris sir who encouraged you to come here.
Dr. Harish, Dr. Neha, Sanjay, Anil, everyone is there.
Yes, sir.
And we can see you operate.
Yeah, thank you, sir. It's all your blessing, sir. Now, if you notice that as soon as I'm going close to the bladder area, my speed is decreased as well as the whatever the tissue I was taking in my shearer has been also decreased. So now a little bit happy because I'm getting some veins here. One more thing I would like to tell you here that, so whenever this bladder, that UV fold, vesicocervical fascia, so these two fascias will have their own blood supply, and if you stay in between these two fascias, so you will never encounter any kind of bleeding because both blood supply, the bladder blood supply will be with that upper fascia, and the uterine blood supply will be with that lower fascia. So make sure that you are staying in a plane. So this is for newcomers. Then now see that I am purposefully not using myoma screw right now only because I am worried about little bit bleeding, and this is the only steps, sir, I have not just changed from your this one particular steps because your this one the fan of that V manipulator and one of your assistant is using that. So here I would like to tell something about the difficulties what we feel as a freelancing surgeons. We can't take so many people in my car to the various places, and because of that it will be the one extra person we need because we need one expert in that in the vaginal end because everything is
So you don't use any manipulator for normal uterus also?
No, sir, I definitely use. Here I am a little bit worried about the large uterus.
Yeah, large uterus, it doesn't make sense to use the manipulator. You will be acting against your own forces.
Hello.
Yes.
Good morning, Dr. Vikas. Can you show the vaginal end also how he's holding the...
No, ma'am, we are not using anything from below. We are just using that external camera focus. See that only 2 persons are operating and there is nothing on my trolley also. So there is rule of 2 is 2. Means 2 assistant also we have carry forward that. And all instruments are in the 2 in number.
Suppose because assistant is not an issue, if you have ample assistants with you, which would you prefer, V manipulator or?
Definitely with V manipulator. I'm big fan of V manipulator. Only thing is that whenever I go outside, so many things I have to encounter. First thing that most of the time I have faced difficulties, this one cervical dilatation. Though I operate so many endometriosis cases, radical hysterectomies, but I'm always worried about that tackling the cervical dilatation. And in this case where that ventroplex uterus is there, it is most of the time service is not accessible. But whatever you are saying, that absolutely right. If the given chance, that definitely I will prefer this one V manipulator.
Hello, Vikas.
Yes, sir.
If you are comfortable, I'll ask you something about the ports.
Sure, sir.
Yeah, say you are using ipsilateral, right?
Yes, sir.
And mostly it depends on the training how the students start.
Yes, sir.
Whom they are trained with, whether they use the middle port or the ipsilateral port.
Yes, sir.
But given a choice, at the beginning, what habit you develop, no?
Yes, sir.
You continue mostly with that. What would, as a young student who's just starting to learn endoscopy, what would you advise? What is the advantage of a middle port and what is the advantage of a ipsilateral port? If you are comfortable answering, otherwise continue with the surgery and ask Dr. Chintri.
Sir, definitely, Hemant will also answer, but I would like to say, whatever your boss was following when your training program, you should follow that. And sir,
But what are the advantages of Abcde and what are the disadvantages? That means what, means the students given a given choice, they can do both.
Yes, sir.
In the beginning, what would they opt for?
I don't like that middle port, sir. The reason is being that it comes in my way of surgery, my field of vision will be decreased, and advantage is that I can access from both the sides.
Absolutely. There is one more thing about the middle port for people who are short, no? They'll have to take
Excuse me, sir.
small stool.
Excuse me, sir, pardon me. Am I audible?
Yeah,
Yes,
yeah.
yes.
Hemant,
Yeah. I'll just show how the lateral coring technique works in cases of vaginal removal of large specimens. Am I audible? Am I visible?
Yeah, Hemant, continue.
So what I do is I have put my one speculum in the upper portion, that is anterior, and lower portion also should be retracting quite good. You can take a suction tip if you want for better visualization. And what you do is just try to give a cut, a good bold cut, and then you apply your instrument up, put it inside, rotate, take a new area, and then give a cut. Then I'll put again my instrument higher, put it inside, rotate it, give a bold cut. So slowly you are just creating a strip out of your specimen to deliver it out. Can you appreciate that?
Yes. And each successive cut should be medial to the first one.
Yes.
Vikas, can you take us through the lateral window technique? Can we shift to other OT?
Am I audible?
Yeah, Vikas, please take us through the lateral window.
Rohit, if you have seen that in the when the audio was shifted to that OT, so I was just doing this part was little bit here, so I did fiber by fiber dissection. Okay, and now I was trying to separate the two leaves of broad ligament nicely. So if you see here, so these two leaves of broad ligament, so this is something called as surgeon friendly tissue. Okay, and from here my lateral window already started. Okay, but yet I have not reached up to the bladder as such. And one more thing in the initial part, I will tell you. So just decrease the pressure on the myoma screw. So if you see that now, little bit, it is not that cooperative. But here you will get, when I release the pressure on the myoma screw, I will notice that there is bladder markings. So the impression of bladder will be visible here. So I am suspecting somewhere bladder is here, and my window has been already started. If you see here, this is posterior lip of broad ligament, and it is, if you are in correct plane, you will not find any kind of vessel. So these kind of vessels, they are going towards the corner, what I am just facing that issue. Can you please take out the gas? Okay, now see here, I am just tackling this posterior lip of broad ligament, and so this is, so again come back to the, this one, surgeon friendly tissue. So now see here, I am trying to, actually this bladder is going down, okay, and if you come here, I am expecting all uterine vessels are here. So descending, ascending branch will be somewhere here, descending will be somewhere here. So now can you see this? So already I am in that window only. Here, see, I will show the window. See, this one is, and now I am taking my scope into that window. So I am going in, going in, going in. So you take your cable down, please, little bit. So now what I am expecting, again, little bit tactile sensations, what I will get of the cervix. Here, three things will be changing. First thing that the uterines will be away. Now these are the uterine vessels. How to identify that you are in window, I am telling. So uterine will be going down or just lying below, and white glistening structures you will start to see immediately. Now see here, can you see this white? Rohit, are you with me?
Yes, we are with you.
Yeah, and see that so many vessels I have started encountering right now. So all vertical vessels that I am seeing that are belonging to the cervix. Now can you see this? I am slowly going down. So if you come across any this, zara khali rakho. Any kind of blood vessel, just cauterize little bit. So here don't give so much cautery because here maybe bladder may be there. So I think almost this window, I am going 90% window has been completely cleared. So now the main concern, if you see this is bladder. Okay, and I have stayed in correct plane. That's why I am not encountering any kind of bleeding till time. Can you see this areolar tissue? And see, I am separating these vessels, those are belonging to vesico-cervical fascia. So, and the cervical, they are staying down. So now I am exactly on the cervix. Vinayak just close the camera cable straight karata. So everyone just notice the vertical vessels on the cervix. So this is my landmark, this is my GPS, this is my everything. If I see that any kind of previous two section, previous scar uterus, I really become happy that I am going to finish this case soon. So now with one hand, I am just lifting up this one and I am further, the camera, I will just clean up the camera and I will again come back. Now I will just change the plan. Now definitely there is nothing left here. So still what I will do, one up with my hand, I will be nicely giving traction on the UV fold as such and I will start cutting here. Definitely there is no bladder here.
Do you always do this or you're opportunistic sometimes?
I am lucky today that I am in flame.
Okay.
So see now instead of cutting this one, I should start this one first. Sometimes many times I take that anterior U cut first, so that once this is done, then I am happy that at least one part of surgery I have taken up and now I can go further and I can. Now see here, same thing I am doing. So instead of that cutting this whole window, whatever I have cut, so when you are sure that there is nothing, no bladder is there, I can cut. Now I am 100% sure there is no bladder here, so I am cutting. Now see here, this areolar tissue, this kind of tissue, surgeon friendly tissue, definitely you can little lift. Zara focus kar Vinayak please. And now I am cutting. See here again. See the hand movements wherever it is required. The last to be cauterized. I am using the full face of my blades of my instrument. And whenever see now this is nothing is there. This is surgeon friendly tissue. And almost I am creating that window on the right side. So this vessel just cauterized. So just small burst to be given. Can you see this now? So almost, so yellow as came, that means somewhere bladder is about to start. So now the only midline part is remaining. When I lift kar uterus, focus kar rahe bada. Light source full like a baga jara. Actually, Sanjay sir, I am facing little bit vision issue. Whatever the routine this is spice, whatever I am routinely using, I am using the same. I thought nothing to be changed today, and but I am facing so much issues with the vision. I am getting little bit blackish vision, but still I am trying to somehow to make up with that. So now you can see that the cervix is completely down. I have gone nicely into the window. There is, so don't think that this is bladder now.
Because the light is less, I think, the cable or the light source.
The cable at the
and that is one thing.
Yes, sir.
That is the most common thing which is a problem. And this instrument you are using,
yes, sir.
Do you have to change the blades very often?
No, sir. I seriously am telling that this instrument is just costing 4,500, sir. I do minimum 60 hysterectomies with this, sir.
And when you plan to, when do you decide to change it? When
sir, when it is not giving actually cutting things, then I change it.
Okay, and you are using cutting of this bipolar?
Yeah, yes, sir. Shearer, sir.
Okay.
Because if at any point, if inadvertently you have opened the bladder or you have nicked the bladder, what are your next steps? What is next course of action?
The first thing I pray God that everything should go smoothly, and I pray that nothing should happen. Today also I followed Vivek sir. Vivek sir used to that नारळ फोडायची सरांच्याकडे एक पद्धत होती. So in the morning only we have that ceremony first, and then we prayed God that everything should go smoothly in this live workshop. This is first workshop of this medical college in the history of GMC, and I have to take care with my HOD. We have done everything whatever we can do for this. And suppose now see Rohit, though I am damn sure this is not bladder, okay. So and now what I am using that cutting current of the this one shearer. even with that if I open that small part of the bladder, I should not worry and immediately no need to call that urologist in your OT or surgeons in your OT. So small injury with this one small, the blades, so you can just take 30 Vicryl with you. You finish up your hysterectomy, nothing will happen. Don't worry about that bladder and all that. And you just go ahead with your hysterectomy, finish your hysterectomy. Then nicely you have to dissect the bladder, and both the walls of the bladder should be very, very, very pliable, or there should not be any tension on that. So even if you need to dissect little that space of edges, you should do that. If it is not required, you may not need it. Now can you see this? Again Vivek sir and this one Harish sir has habit of putting one nice gauze piece inside whenever we are operating this kind of cases. So we have kept that one gauze piece ready, and I am going to insert it soon. So if you see that my gauze piece is in this way, and I will always put it that, and always we keep 1% to have the count of that gauze pieces, because in endometriosis and difficult surgeries, so many gauze pieces are required. And this is only thing is that when blood comes into the picture, your light will be absorbed by that blood, and you will not get any kind of vision. You will get black vision. And now see,
Can we shift the audio for a while?
Yes,
on the
yes,
other
yes.
side, Hemant
Sure,
side.
sir,
He
sure,
has
sir.
started suturing the vault.
Sure, sir.
So maybe he can share. Hemant, we are with you now.
Yes, sir. Hi, sir.
It's going well.
Yes,
So maybe you can share a few tips about
Yes, sir.
suturing.
So previously I used to do contralateral suturing. Now I have shifted to ipsilateral one. But for both the suturing techniques, there is one thing: you have to make a good C. C on this side, C on that side, and then you take a throw. And in ipsilateral suturing, what you do for tightening the knots is you do movements like this. And for contralateral suturing, you have to go like this to tighten the knots. Am I right?
Yes, sir.
No, I want from the stalwarts, Anil Magdum sir. He is the master of suturing. I have seen him suturing beautifully. But ipsilateral suturing, it reduces the strain on your shoulders. Otherwise, for contralateral suturing, tips to reduce the strain on your shoulders, you can give a tilt towards your side to the patient. So, before suturing, you have to have a good surgical field. You have to keep the bowel away from your suturing field. And you have to have a good needle holders. And another important point is, you have to have good wrist movements. So, if you keep on applying force, the needle will not pass. But if you are following the natural curve of the needle will pass easily. So you have to get into the habit of good wrist movements. That's the technique.
Sir, do you include the peritoneum always? The posterior peritoneum?
Yes, I do.
Okay. And like you said, you have shifted from contralateral to ipsilateral, but for the pectopexy and all the things, you still prefer ipsilateral or tubal recanalization?
Tubal recanalization, pectopexy, Birch corpus suspension, I do contralateral.
Yes.
You are using Vicryl, Hemant?
Yes.
Doctor. Dr. Hemant, excellent suturing tips. Dr. Sarungi speaking. Hello.
Hi, sir.
Hello. Yes, we can see
Welcome to Miraj sir, Miraj Sangli.
Thank you so much.
It's a really pleasure.
We were talking about tightening the knots, so we should see for good tightening spaces where we can not tighten over the bladder or the bowel. The instrument doesn't touch this lateral pelvic wall.
Yes, sir.
So accordingly, that was a very nice tip given by you. Yes. And you have any assistant port from that side? Or?
Yes, I have assistant port from that side.
That is retracting the bowel.
That is retracting the bowel, sir.
Yes, yes. And only one on that side, right?
Only one on that side, sir.
So do you change to two on that side anytime?
Sometimes when the bladder is falling or the bowel keeps on coming, sometimes that time I use another one.
Yeah. So if you have to take a fourth operating port, you take it ipsilateral on the right side or you will take it suprapubic?
I'll take it suprapubic,
or
sir.
it will change according to your case.
I prefer getting that into suprapubic, sir.
Suprapubic, yes.
Yes, sir.
Yeah, again, suprapubic port has a very good reach.
Yes, sir.
And especially in very large pathologies where the ipsilateral port on the other side may not reach to.
And it gets a good fulcrum if the bowel is coming in between. So you can retract the bowel or rectosigmoid quite nicely with the suprapubic port, sir.
So good morning, Hemant. Would you, since you've kept the uterosacral, would you be plicating them?
Pardon, ma'am?
You've kept the uterosacral, so would you be plicating them?
Yes, yes, and it will happen naturally, madam, because I have kept the uterosacrals. The uterosacrals will be with the vault only.
Yeah, so Dr. Hemant is including the uterosacrals at least in 2 stitches on each side to the vault.
Yes, yes.
So basically it's a reconstruction of the pericervical ring. The
Yes, sir.
pubocervical and the rectovaginal fascia, and then you get a nice elevation to the vault. So if there is a apical descent, will you do the uterosacral plication separately?
Pardon, sir?
If there is a apical descent to the vault or laxity,
Yes, yes, sir.
as a preventive measure, will you do any uterosacral plication?
Yes, yes, sir. I do Macquart's scaldoplasty usually when there is apical prolapse.
Yes, yes.
From down, because I was quite trained by Ashokanand sir in my UG days. So I am quite well versed with that technique.
Okay, sir.
Yes, that and high ligation of the uterosacrals, that also helps with that.
Yes, yes. Very nice.
I welcome Dr. Shrikant Ahankari sir, Vice Dean of Government Medical College, Miraj. Thank you, sir.
कुणीतरी सांगा शिफ्ट करायला माईक माझ्याकडे. I don't respond. Am I audible?
Yeah.
Yeah, Rohit, if you see here, I'm little bit struggling with that posterior peritoneum. 2 things here I would like to highlight. First thing, I'm not having the good position of surgeon himself. That what the Harish sir was talking about, the positioning of the table. So it is little bit ortho type table, and I'm having difficulty in that. My hands are not reaching there properly. And now you see here, Somehow I have reached that uterosacral ligament nicely without damaging any uterine vascular system there. And now I have successfully reached the uterosacral ligament on the right side. If you see my hand movements, one of my hand is resting on the patient's leg, and this port, lower port was absolutely doing nothing. Only because of that, the large uterus touching my ports. So I have to be little bit, what we can say, patiently I should be working there. Now see here, the posterior lip of broad ligament has been done. Definitely I will be using my bipolar instrument to tackle the uterine vascular system there, because what generally newcomers make mistake that they consider uterine as a single vessel. It is not single vessel, it is vascular system which is supplying and draining blood from the uterus. So there will be the vein, there will be the ascending branch, there will be descending. Now see here, this is definitely broad ligament part, but some of the vessels must be there. Gas please. Yeah. Now see here, where to tackle the uterine vascular system. Now if you notice, right side uterine, I am tackling on the right side with the prongs of that my bipolar staying perpendicular to the uterine vessel. I have tackled left side uterine artery from the left side only. This is the take home message from this topic, because whatever ureteric injuries that happens in initial part of your career, only because of this mistake, people take right uterine from left side of the patient, and see that if I come from this side, see that somehow I will try to reach, I will tell you, see that now, suppose if I reach like this, so definitely my tip of my instrument will be going towards the ureter, and I will be landing into the big trouble. And second important thing is that, Rohit, I have seen while operating you, most of the time you tackle uterine at the internal walls. This is absolutely correct way to tackle the uterine, because if you go a little down and by chance if that vessel breaks, it will be directly retracted to at its origin, where ureter is very close to its in its course. So always tackle uterine, ipsilateral uterine from ipsilateral side only. Now see here, slowly I am going down. This is something called as the slow cooking of the tissue. How still today I am not happy with myself. My instruments are not cooperating me with at all, because I have lot of struggle here, and but still I am trying to do my best.
Yes, Vikas, you are trying to do your best, and we are also enjoying your surgery.
Vision is not
everybody here, Vikas, is thoroughly enjoying your surgery, but we are falling short of time. And we have to proceed now. Proceed further with all other surgeries. We are 11 surgeries waiting back. So we'll just move ahead faster and try to finish it as early as possible.
Am I audible?
Yes.
See that I am taking little extra time to coagulate uterine artery. Okay. See that now everything is done on the right side. Only thing is remaining that descending cervical and little bit that the middle portion of the uterine artery. Now I am using 4 chunk of my this one bipolar forceps, and I am trying to kiss the cervix and come back. Can you see this? And now I am using the full force. If you press it completely down, the forces will displace the blood on either side, and when you press down the foot pedal of your cautery, what it will happen, it will displace the blood, and the voltage required to coagulate that tissue will be less, so that your lateral spread will be minimum. So I expect uterine artery has been completely coagulated well. This one, na?
Because
yes, sir.
We'll shift to Hemant for a while. He has just finished suturing and everything.
Sure, sir.
We'll thank him, and then we'll come back to you.
Yes, sir.
Hemant, we are with you.
So my surgery is finished, and I have done the irrigation and suctioning, and we have removed both ovaries also as the patient requested. And I thank organizing team Abcde Miraj. I thank all my assistants and beautiful anesthesia team, and especially Dr. Gurav sir's daughter. She is there, Dr. Katyayani Gurav. Am I right? Yeah. Thank you so much. Thank you all. And I thank Dr. Vikas Devkari sir and all the esteemed faculties and all the organizing team. Thank you so much.
Thanks a lot, Hemant. Thanks from all of us here.
Vikas, we are with you, but maybe dignitaries are here for the inauguration ceremony and we can go a little fast now.
Yes, sir, yes, sir, yes, sir, yes.
Meanwhile, we can request the anesthesia team to induce cases on both the sides so that by the time we finish with the inauguration, we can start immediately after reaching the
Yes,
theatre.
sir. In another OT, someone please take care of that, the 3D camera where Vivek sir is going to operate on the endometriosis, and in the another OT will be having the Harish sir will be operating on the polypectomy. Sir, is there any changes made meanwhile I was operating?
No,
No, okay, sir.
we'll stick to the plan as of.
Yes, sir. I will be there within 10 minutes, sir. I will just finish up this one and I will come down.
Yep.
Just because guide us through opening of what
Yes,
we have
yes.
seen opening on tube by Hemant. Now just guide us through your technique.
Yes, Rohit. I will just finish this uterosacral and the Macon rods from the right side. And again, I prefer to open on this one left side itself. So now, if you see here, a little that sigmoid is troubling me. I'll just take it back. Rohit, Vinayak pakad. So now see here, if you see Rohit, I am in the fornix only. Even if I wish, I can open from this side. But as we have made some rules that, and one should not break the rules, because if I open from this end, I may have little difficulty. So see here, now the remaining part of uterosacral I am tackling, and this is the end of that fornix on right side also, and immediately I will be shifting my this one whole system, that myoma screw and all this one on the opposite side. So this is the last part I am operating on the right side. In the myoma screw, please. And now you just concentrate what we do. So my left port will be used for myoma traction, and now I will shift my myoma screw little bit down so that I can get good traction at the this one fornix on the left side. So see, so it was here. So I'm little bit shifting myself to the down. So now the myoma screw has been placed, and now for the first time I am taking away some different instrument. So in my left sided upper port, it's the needle holder, which gives me the good grip, and this fine adjustment, please. Yeah, fine. And now see this again my shearer has came down. So I am expecting this little uterine musculature to go down, and now I am trying to find out the exact fornix. So I think here is the fornix. It's all about your experience and skill, because many people use vaginal tube. I am not against vaginal tube, but my boss was doing this kind of surgeries, this kind of techniques, and I have learned from him. So it's Sinjini ma'am or Vivek sir, they find out the fornix like this only. Now see here, within 1 or 2 this one strokes, I will be into the fornix. Can you see this? This is one stroke. See that in one stroke only I reached the fornix. So it is my correct prediction that I have gone up to the right fornix in the right plane. So see that sometimes you may go down, sometimes you may go up. So here one should take care that you should not waste the vagina of the patient. She will have problems with the intercourse later on. So do not shorten the vagina at any cost. Just go on dissecting, close to the cervix. Now see here how I am close to the cervix, and here much cauterization should not be done, otherwise patient will be end up into lot of vaginal discharge after your surgery. She will be at least minimum for 6 months it will be there. Now see here I am very close to that, and now if you see that I will just take out the myoma screw. I have taken out my shearer, and I will just show the this one. See that how completely cervix I have taken out. Can you just focus on the cervix, please, Vinayak? Cervix will daakho fakt. Now see here, there is nothing no part of the cervix has been left. And now just concentrate how we do that now. Okay, how to take out the specimen. It's very simple. That Vinayak will be retracting the bowels down. So what one gospice we have kept jara maage ke. Now, so this is, see that patient blood loss is almost zero. We haven't encountered any kind of bleeding from that, and it is all about that myoma screw and the previous fluid was there. Can you see this? So that one gospice we have kept, I am taking out that gospice first. So I am telling my nursing staff also that I have taken out the gauze piece. I am lifting up the vaginal wall, anterovaginal wall, and I'm just placing this cervix into this one. This is previous to C-section. I'm expecting little bit narrowing up the vagina. So now see here the wall, what we are doing. Focus on my external camera, please. So I have kept that cervix into the vagina. I am giving little bit downward push. My assistant will take out the camera port. We will deflate the abdomen so that I will go down. While going down, I should not face any difficulties with that blood is coming and pouring on my whole body. So we don't like that blood, whether on it's patient's blood or on my body. We don't like any kind of bloods. Now, can external camera just show the how we take out this one, a specimen. I am little bit fast because all dignitaries are waiting for me to initiate that light, please. Initiate that the inauguration program. Can I get the tinaculum, please, fast?
Dr. Vikas,
Yes.
very good vault. The vault is so clearly delineated.
Thank you, ma'am.
Because you did the lateral approach.
Yes, ma'am.
Does that help in delineating the vault so well?
Yes, ma'am.
Thank you.
So now see here what I am using the two tinaculums, Vinaxod, and as soon as I hold the cervix, my assistant will take out the needle holder from its position, and now abdomen is completely deflated. I have guarded rectum with one speculum and it is going into the pouch of Douglas. This is very, very, very crucial. Can I get the stool, please? And one of my speculum is guarding the bladder anteriorly. I am sitting comfortably here and both the assistants are doing good job to retract the bladder anteriorly and the rectum posteriorly. So now here that I think Hemant has already discussed how to take out the specimen. I have very narrow vagina here, so definitely I am going to face little difficulty while delivering the specimen. This is something called as the lateral coring method, and I have seen Anil Magdum sir is very, very expert in that. I have taken lot of tips from him, and now see the one cut external camera is there. Can you see this?
Not properly.
Jara focus kara please चांगलं. So now the tip is
In
that
the center. Camera
should come from the left shoulder of Vikas.
yeah, please इकडे या मध्ये यायच्या. See, I am trying to step parallel to the cervix so that cervix should not get cut.
Better.
And first that from anterior to posterior, 12 o'clock to 6 o'clock, complete nicely cut to be given. Now see my next step is that I am forwarded my this one instruments. I have taken out that this one speculum. I am retracting downward and little movement. I am giving fractional force on the uterus, and now little part is exposed. I am giving the next cut. Now if you see this next cut is giving, and I am almost into the endometrial canal. So if you stay in that endometrial canal and you are getting good traction movement downward, then you are in correct plane. Now see, I little bit changed and I am moving forward. I am cutting the uterus. Now I got the good plane. Still I am also not having good vision. मला तर light दे ना वरचं, light source light खाली घेऊन दाखव ना please. इथलं light source light काढ.
Sir, any particular reason why you are cutting with your left hand?
I am left hand only, though I operate on the right side, but my dominant hand is left hand, and this is what आता बऱ्याच वर्षानंतर same methods we are following, आणि immediately I can't change, but I am little bit what we can say the means comfortable with my left hand itself. Still, there is very narrow vagina. I may opt for vaginal morcellation from above. I will just trying to take out the specimen. Let's see what happens. Very, very narrow vagina. Even that my speculum has hardly gone inside. जर इकडून नाही पकडायला लागणार आहे जरा. One good cut and that everything will be done. Here I don't want to cut the cervix, but most of the time when the narrow vaginas are there, So now here I am trying to rotate the uterus. So now whatever part I have cut, I am rotating the uterus. See my pronation movement of my left hand. Okay, don't take out the stool, please. Yeah. So now see here, and conference means padala naku mi. So now I am just cutting the cervix. This one, cutting the uterus. So still not any single good cut has been taken. I am trying to rotate the uterus. Peculum जरा मी नेक्स्ट धरतोस का Suresh, get ready with the morculator. I will see whether I can take out easily from the below, otherwise I will use the morculator. मॉर्सला आणला का वरती जोडून ठेव सोड जरा
Hello.
Yes.
Because after each cut, put the uterus inside and just rotate and then give next cut. It will be helpful.
Okay, definitely I will follow that. फक्त मला I am worried about if I give excessive traction right now, it may that cervix will come in my hand and again it will be very difficult. So on my left side I can see the uterine wall nicely. So I am trying to go into that and I will give the rotational force on my right side. Sorry, left side. Now see, I have held it nicely and now I have rotated little bit. Now I can see the wall of the uterus nicely. It may not be visible nicely at that place, but here I can see that. Can you see this now? On the left side of the patient, so the all vaginal, all uterine wall is visible. Yeah, almost now, first time out, I got confidence that I can take out from the below. Now, and it is completely adenomyotic uterus, very hard to hard, and even though I am applying the good, the force with that, even the blade, it is very difficult to cut. Now see here, can you see this? Almost that 30% of the uterus is out. And now I am very much confident that I can take out this uterus from this one below. So there is 90%, I think I may not need that morculator. Oh, Vaibhav, are you with me?
Yes.
Okay, can you see this now? See, the difficult part has already came out.
Yeah.
And as you rightly said, sometimes we need to put what I was worried that if I put that uterus inside, if I do in the wrong direction, again I will be stuck with the difficult step. So I just keep that. But now see here, now this posterior part is little bit cooperative, but what I will do, that rotational force are happening from the left to right, so I will continue with the left to right. Now see here, this one. अजून जरा द्या. Actually, I had examined this case in wards when admitted. It was good case, and now it is giving little bit trouble.
Cut it from below slightly.
You mean to say on the posterior aspect of the uterus?
Posterior aspect ला कर थोडा.
Okay.
झाले बऱ्यापैकी.
Yes. Grip is little bit poor here. If Anil Magdum sir is there, can you just give some idea regarding the ideal way to do vaginal morcellation, sir, please?
Whatever you are doing is correct. Just keep doing it from 10 o'clock or 11 o'clock position to 6 o'clock, 5 or 6 o'clock position.
Yes, sir.
Not 5, maybe 7 or 6 o'clock position. पण ते खालीपर्यंत तो इन्सिजन जात नाही. तो खालीपर्यंत इन्सिजन गेला की डी बल्क व्यवस्थित होईल.
Sir, I tell you why I was purposefully not doing that. I was worried to cut this part. So if I cut this one, then again it will be very difficult because now I am getting good grip. But what you are saying, now I will follow that. Once that, now see here, now this one is 12 o'clock and I will go completely down.
And initially we have to be slow only because till we debulk the uterus sufficient enough so that it rotates on its own. तोपर्यंत ते slow जायला लागते.
Yes, sir. Yes, sir.
Fibroid is still inside, right?
Yes, sir. And I am that ribbon-like thing is coming down, so I am little bit confident that I can take out this vaginally only.
It's almost done now.
No, sir, it is still inside. See that now you can see the major bulk is just about to come. Now my that complete cut has gone from 6 o'clock to 12 o'clock to 6 o'clock. See that every time I am taking this part, I am a little bit rotating like this, and every time you have to take out the speculum, and every time you have to put it again back and guard your bladder. So if you have taken out, then don't forget to put it inside again.
Because Dean sir and everybody has already arrived, so in 5 minutes we'll be proceeding to inauguration.
No issues, Rohit. You please continue. Just once the specimen come out, I start suturing, then you can just shift this one. Or if everyone is that ready with that, then you can just start this one. You can stop my camera, doesn't matter.
We can see is trying to avoid excessive pull. Sometimes we feel that it's just a pull away and we try on pulling it. So it causes vault tears which are very dangerous at this point of time.
Yes, Rohit, absolutely. Uterus is not that small actually. I thought it's the clinical examination was also went wrong, I guess. She's fatty. So even she was not cooperative to the PV also. No. स्पेसिमेन पण उचलले. Rohit, are you with me?
Yes, we are with you.
Yeah, just keep on talking so that these two special instruments that what I'm holding in my right and left hand is very important. And so always we keep this because we don't know which case will require this. Now see, can you see this? And it was literally, the specimen was almost like very, that if we like this, so it was quite good, and not problem with the length, but it was very, very thick, I tell you. Yeah, sorry, they wanted to show you.
It has a very large, laterally it was enlarged.
Exactly.
Rather
The
than
problem is with the consistency. It is not fibroid, it is adenomyosis. So I was had difficulty with the forces was I was like, actually I was tired now at what I was pulling and pulling and pulling. Okay, so I will just clean up, and if sir has arrived in, sir, I welcome him, and you can proceed with your this one inauguration program, so that we should not waste any kind of time. See that I'm just cleaning up, and I have checked vagina. There is Karjarvair. So there is no any vaginal tear or anything else. I have already taken out the gauze piece what I have taken inside, and now I will just suture that the vagina, and within 10 minutes I will be back to the hall. This vehicle cut करूँगा मैं. Onion tuck. Suction irrigation. The Swesh, please. Swesh. लाईट बंद केला तरी साहेब.
एंगेज कर काहीतरी फिलर्स एंगेज करा काहीतरी.
Don't you think it will come in the suture when you close it? This bleeding?
Otherwise, routinely I don't cauterize too much there. Suction on, please.
Vikas.
Yes, sir.
Please tell some tips whenever there is a vault bleeding.
Yeah.
After.
Yes. One thing is that there is something called as focal coagulation and not the global coagulation. So what I have learned from sir is that, so now see, everyone can see that there is bleeding is happening from this area. So immature surgeon or the newcomers, what they do, just take the this one cautery and they will globally cauterize all the things. Now what here I am trying to do that, just make out the which artery or which capillary is bleeding there. So now as this one Anil sir rightly said that it is going to come in my suturing, and now there is no any kind of active bleeding is happening. So I will just release this and quickly I will suture the vault, and I will try to take this angle nicely. पानी सोडलं नाही का दोन्ही पण सेक्शन आहे. How to hold the needle I will just tell. So this is the, never hold the needle. Okay, always hold the thread, and when thread is there, just the distalmost part of the needle to be held like this, and if this is happening, then you have correctly held the needle. Use tip of the needle holder. As I have already cut the uterosacrals, my first stitch will be the hinging the uterosacrals in my this one the suture material. So I have taken one nice bite through the uterosacrals. I will take the vaginal angle. I will continue with the remaining vaginal angle. I will not go too laterally. Sometimes there is the kinking of ureter may happen. I will take one figure of 8 bite here. So this is vaginal again the angle. Don't take so much extra vagina. The thickness, whatever it is there, only that thick part to be taken, the muscle part and the mucosa and the serosa to be included, and just take the good bite. So now see that, just keep on pulling the thread. This is enough. Try to make the nice C. This has happened. 1, 2 throw, go again close to the vicryl, hold it nicely. 1, there is large space, C is there inside the vagina. Nicely hold the sutures in both the hands. One hand will going into the vagina. Give little tug there. If you confirm that 8 of the that knot has been nicely formed, take the next throw. Now again hold the thread nicely. There is lot of space inside the vagina. Go in, tight the second knot. You have to always, the configuration of vicryl is 2 + 1 + 1 or 3 + 2. Even that is sufficient. So now see, this is angle is nicely being tightened. Again I will hold the needle. I will follow the thread. I will take the needle nicely. It is held. Then simply go 2 or 3 bites are enough, but take full thickness bite. So this is full thickness bite from mucosa to serosa. This is, don't see that this is the difference between open surgery and lap surgery. See, the struggle is very less here, what I feel. In open surgery, we don't, every time that third assistant or the second assistant is struggling, he don't see anything and he's retracting that Doyne's retractor, and he's been always fired by the main surgeon. Now see here, almost the vagina is done. I am about to go on the left side of the patient. Here I will make out where is that again.
Suppose because at this point you feel that the uterine, there is a ooze, the uterine is bleeding, what care will you take while coagulating it?
Rohit, first thing I will stop my suturing immediately. If I see that bleed, I will drop the needle. I will suppose now this uterine is bleeding. So now see, already I am giving nice traction. So I will keep that traction nicely as it is. Now though I have loaded with the shearer, but one should not use shearer at this point. I should take the plain bipolar with the 2 prongs nicely. I will hold the uterine artery, and I won't do like this. I little bit lift is required because something called as water under the bridge. So this is bridge, somewhere that water is going down, must be ureter. So just hold, little tug is given on the middle side and start coagulating. So now though I am using shearer, I have little confident that it is not going to bleed at all. So I am just trying to coagulate it. Now if you have seen that my movements, I was not pressing the prongs of shearer too much. I was just holding that. And now see here, this could be the last bite on the vaginal, this one. So this is the last bite. I will be taking the angle, full thickness vagina. This has came, and now this is the angle of the vagina. And now see, don't go too laterally. Even if you take the little vagina is fine. But if you go too laterally, there are high chances of injuring the uterine artery there or the descending cervical. Give nice pull over it. No need to tight it so tightly that you are. So if you go too close to that, what will happen? It will be again ischemia will happen, and you may face the vaginal discharge after the surgery. So don't do that, because patients don't want any kind of complications immediately. This thread is even not working well. Today everything is little bit not in my favor. Instruments are not supporting me, especially my camera, because it is little brightness is too low. So what I will do, same thing, I will give one good bite. Full thickness bite. There are fine adjustment, please. Inauguration fine adjustment, please.
Hello, Dr. Vikas.
Yes.
My name is Dr. Ravindra Das. Hello, how you can prevent adhesion again in this case? Hello.
Now here what I will do, the new thread, I will take only 2 throws, and for third throw, because I will take that another one, that the loop I will incorporate, so that the suturing will be done.
Hello.
Yes.
How you can prevent adhesion again in this case? Hello.
Swish. Cleaning certificate. Am I audible and my
Hello.
Yes.
internal picture is visible?
Hello.
Yes.
There is one question from audience.
Yes.
Please go ahead. Who is asking question?
Yes, I am.
How can you prevent adhesion in this case again? Because we have seen lots of adhesions in starting.
First of all, Ravindra, thanks for coming for this conference from such a long distance. And see that adhesions won't happen here because there is no much this one what we can say raw surfaces.
Because there was one question from audience.
Yes, sir.
Initially, we saw so many adhesions, and now to avoid similar kind of adhesions in future, are you going to do anything actively now?
Sir, see that one thing I can do that this can be sutured well, but here, sir, I am not going to do that because I think in laparoscopy, particularly in this surgery, I am not expecting because this part will be healed up immediately within 2 to 3 days of this surgery. Pani, please. NS there, please. Sir, am I correct or you want to correct me, sir, to some extent? Anil, sir. Pani देणार आहे.
I think this will heal. This won't need much of
Yes, sir.
additional precautions to avoid adhesions.
Because sir, we have done so many this one wire and cyst in post hysterectomized patient, and in which we are operated with the similar kind of methods using shearer and all this kind of this one. We have not encountered any kind of adhesions thereafter. Pani, please.
That ventrofixation, do you feel, is it related by any means with closure of the peritoneum, which we stopped doing in between during cesareans?
Yes, sir. This was the definitely the post C-section. We can say the remote complication, but must be while suturing that peritoneum and the muscle layer, they have must gone through the one bite has gone through the uterus. That's why there was unilateral or one-sided adhesions were there. Panika. So I'm just checking up with the all pedicles once again. So you can see that there is very little charring of the tissue has happened.
Excellent one. Hardly any charring we can see.
Please, Panika, please. Yes, thank you everyone, and thanking everyone for coming to Miraj and attending all the cases. Thank you, Dean sir. Sorry for the little delay. Cases are little bit difficult. I thank all the anesthetists, Tubal sir and his team, HOD and the all anesthesia team, OT staff, all the residents, my HOD, Vinayak, Tanvi for assisting me in this surgery. And thank you everyone. I will be there soon. Stop Karama.
Dean sir has already left his office, so he will be coming here within a few minutes time. Probably he has arrived. So till then, bear with us. And the next surgery probably will get induced within 1 to 2 minutes. Sir will arrive and we'll starting with the inauguration function. Till then, any audience, any questions from the audience, so that the dignitaries, the stalwarts can answer them. Any question from the audience? You can ask simplest question also, because this is definitely A, B, C, D, E. Anybody can learn endoscopy. So you can ask simplest question also.
In multiple previous surgeries, sir, if the primary trocar, if you find out that it goes into bowel, what are your next steps?
Okay. First of all, I will plan the surgery or my incision. I always go, even now, with the direct trocar entry. With the previous multiple incisions, we'll try to choose the most virgin area, the unscarred area, so that the bowel adhesions may be least possible. Having said that, the incision or the scar on the anterabdominal wall won't match with incision in the peritoneum. So maybe we can expect adhesions even higher or beyond the limits of the scar which is seen outside. That is one. Second, the tactile sensation while going in, while putting the trocar, that will guide you a lot. On one of the occasions, it was like the primary trocar, I pushed it. I was sure that I had entered into the peritoneum, but I pushed it little beyond, and the bowel which was adherent little away from the site of my primary trocar, that got injured. So with these kind of things, I depending on what is the which part of the bowel is involved and how much, what is the extent of adhesions. So maybe I will pull it back, the telescope, will try to judge where I have entered, and then go ahead with either in the another area, put the trocar in another area where the bowel is not adherent, and start releasing the bowel from shifting the telescope to the other trocar, and then start releasing the bowel and repair it. Or if I feel that no, it's lot of adhesions, extensive adhesions, then maybe I'll just go ahead with open surgery in that case.
How to proceed while performing TLH? To proceed with the TLH first or repair whatever we have injured?
Okay. Depends on at what stage. If it's not, the leak of urine is not soiling my operative area, I will wait, because that will keep guiding me throughout the surgery. Otherwise, if the urinary leak is spoiling my image, the operative field, repeatedly, I will suture it and then go ahead with finish with the surgery.
See, what happen is bowel you might lose in, you'll have to search for the hole later on. So first the bowel, you have to do something about the bowel, finish it and then proceed with the thing. Bladder, it doesn't really matter, because bladder doesn't have that much of a morbidity consequence other than having the catheter for a few more days.
So the one very important point sir has mentioned, that if your trocar has gone inside the bowel, do not try to remove the trocar. You have to put another scope. See, because if you remove the trocar, you are losing the bowel. But if it is anchoring the bowel, you might easily get the injury where it has happened.
No, this is more of a theoretical thought. Practically, this would not be possible, because see, primary port is in. You would want to see something, right? When you get up from the sleep, you want to see something. So obviously, you will withdraw the trocar, and then only you will realize that you are in the bowel. So you free the bowel so that the free bowel can be sutured easily. But all this takes a lot of skill, right? So those who have injured are not skillful, then they can put a flag. They can just put a flag. What do you mean by flag is take one, any random suture near to the injury, and then proceed for the rest of the surgery and allow the expert to come and do the job.
And another thing is, if you have, if your trocar is out of that bowel injury, you can just hold with a traumatic forceps that near to that injury site, so that you don't lose it.
Good morning, respected dignitaries, esteemed faculty members, delegates, and dear postgraduate students. To begin with the inauguration ceremony, I would like to request our respected dignitaries to kindly grace the stage. I humbly invite Dr. Prakash Gurav Sir, Dean of Government Medical College Miraj, Dr. Shrikant Ahankari Sir, Vice Dean of GMC Miraj, Dr. Priyanka Rathi Ma'am, Medical Superintendent of GMC Miraj, Dr. Vikas Devkare Sir, Medical Superintendent, Organizing Secretary and Official Eagle Project Coordinator, Dr. Somshekar Patil Sir, Senior Consultant of OBGYN and our mentor, Dr. Ravi Rawal Sir, Head of Department of OBGY, Dr. Ujwala Khairmode Madam, Head of Department of Anesthesia, our Matern Madam, Vandana Shahane Ma'am. Also, I humbly invite
I welcome Dr. Vivek Sarangi sir and Dr. Harish Vagasia sir and all the operating faculties.
Now, I, Dr. Rajarajeshwari,
and I, Dr. Ashlesha, gets an immense pleasure to welcome you all to this auspicious event.
Today, workshop brings together renowned national and international experts in gynecological endoscopy, providing an opportunity for learning through live surgical demonstration and academic discussion of interactive sessions. Wonderful insight in world of endoscopic gynecology. Now we are moving to lamp lighting ceremony. To mark the auspicious beginning of this event, let's proceed with lighting of ceremonial lamp, which symbolizes knowledge, positivity, and new beginnings. I request all dignitaries on this kindly, yes, sir, to kindly forward for lamp lighting ceremony.
Gurur Brahma, Gurur Vishnu, Gurur Devo Maheshwara, Guru Sakshat Parabrahma, Tasmai Shri Gurave Namaha.
Thank you, respected dignitaries, for inaugurating this workshop and illuminating the path of knowledge. Thank you, everyone.
Let us give them big round of applause. Every great achievement begins with a vision. Every successful event is built on the guidance of our mentors and leaders. Therefore, to express our gratitude, let's honor and welcome our esteemed guests whose dedication, achievement, contribution have truly inspired us all. I request Dr. Vikas Devkare Sir to welcome Dr. Prakash Gurav Sir, who is Dean of GMC Miraj. Thank you, sir, for guidance, support, and continuous motivation.
I request Dr. Ravi Rawal sir to welcome Dr. Shrikant Ahankari sir, Vice Dean of Government Medical College, Miraj. Thank you sir, your presence makes ceremony special. I request Dr. Jyoti Rokade ma'am to welcome Rajendra Bagu. Usha ma'am. Sorry, Usha ma'am.
Ujjwala Khairmode ma'am, HOD of Anesthesia. I request Dr. Harish sir to welcome Dr. Somshekar Patil sir, our mentor.
I request Dr. Vaibhav Patil sir to welcome Dr. Harish sir. Sorry sir.
I request Dr. Baba sir to welcome Dr. Vivek Salunke sir.
I request Dr. Kiran Srivastav ma'am to welcome matron ma'am, Shahana ma'am.
Ladies and gentlemen, after witness...
I request Dr. Ravi Rawal sir to welcome Dr. Anil Magnum sir.
I request Dr. Vikas Devkare sir to welcome Dr. Sanjay Shanbag sir.
I request Dr. Prakash Gurav sir to welcome Dr. Hemant Shintre sir.
I request Dr. Prakash Gurav to welcome Dr. Neha Lalla ma'am. I request Dr. Prakash Gurav sir to felicitate Dr. Vikas Devkar sir, our operating faculty. Now I request request Dr. Dean sir to facilitate our poster presentation judges, Dr. Somsekhar Patil sir. Dr. P.A. Pawar sir. Dr. Suman Kulkarni sir. We are starting felicitation of our operating surgeons. May I request Dr. Prakash Gurau sir to kindly felicitate Dr. Vivek Salunke sir. Now may I request Dr. Prakash Gurau sir to kindly felicitate Dr. Harish Wagasia sir. May I request Dr. Prakash Gurau sir to kindly felicitate Dr. Sanjay Shanbag sir. May I request Dr. Prakash Gurau sir to felicitate Dr. Magdum sir. May I request Prakash Gurau sir to kindly felicitate Dr. Ravi Rawal sir. May I request Dr. Prakash Gurau sir to kindly felicitate Dr. Vikas Devkare sir. May I request Dr. Prakash Gurau sir to kindly felicitate Dr. Hemant Shindre sir. May I request Dr. Prakash Gurau sir to kindly felicitate Dr. Neha Lalla ma'am. Once again, on behalf of the Department of Obstetrics and Gynecology, Government Medical College Miraj, we sincerely thank you all our operating surgeons for making today's workshop academically enriching and inspiring for all of us. Thank you everyone. Let us give them another big round of applause. As a token of our appreciation, we will now like to felicitate our respected moderators. May I request Dr. Jayant Vatwe sir to kindly felicitate Dr. Rohit Khote sir. Thank you sir. I request Dr. Mangala Rajput ma'am to welcome Dr. Abhishek Kulkarni sir. Thank you ma'am. Thank you sir. I request Dr. Veena Tangri ma'am to felicitate Dr. Soumil Nitwe sir. sir. I request Dr. Tabassum Shikalga ma'am to welcome Dr. Vaman Godke sir. Thank you, sir. I request Dr. Vaishali Chandrapattan madam to welcome Dr. Alpana Vatve ma'am. I request Dr. Jyoti ma'am to welcome Dr. Alpana Vatve ma'am. I request Dr. Jyoti ma'am to felicitate Dr. Ravindra Das sir. I request Jyoti ma'am to felicitate Dr. Vaibhav Patil sir. Thank you ma'am. Thank you sir.
To formally welcome everyone and share the vision behind this workshop, I request Dr. Vikas Devkare sir, Organizing Secretary and Official Eagle Project Coordinator, to kindly deliver the welcome address. Sir, the stage is yours.
So I will not take much time because we are already behind the time and so many cases are pending in this one. So I sincerely thank first Dean sir to inspiring me, and he wanted that our medical college should perform such a event. Until I think there are so many medical college, we have sent 47 emails to different deans, and everyone had told that no one has taken such a wonderful workshop till date. We are going to operate total 11 cases in this workshop, and none of the medical colleges, at least in Maharashtra, had conducted such a kind of workshop previously. I thank both the MS, this one Deputy MS and this one Rupesh sir for inspiring us and telling us, you just go ahead, whatever you want, we will provide you the platform and everything. Then I sincerely thank our HOD sir. Whenever I just told him that, sir, we can conduct such kind of event in our medical college, he was the first person to say, yes, you just do it, we are with you, and everything he has planned. Every day he was inspiring us, from selecting the cases to guiding the residents, arranging the events, the OT things, the instruments, everything. He just acted as a big brother to me, and every day we had conversation in the night, what we can make more and more smoother this program. Then I sincerely thank all the operating faculties. If you see that there are no words for them. Dr. Nihal Allah has traveled across so many countries. He was in Dubai, and just only for this conference she came, and she landed safely in India. So we welcome you and thank you. Dr. Sanjay Shanbag sir, he is very close to us. Every time, whenever I call him for any difficult cases, he is always there to support us. He has taught us how to practice in very narrow kind of instruments, very narrow things, and how to practice in periphery aspect of the India, where so many things are, we have to struggle, and this one, how to come up with that. Then Anil Magdum sir. So everyone is aware of him. Wherever you are in doubt, it's a obstetric hemorrhage, it's a myomectomy, it's a fistula, obstetric, laparoscopic, hysteroscopic, wherever you have any doubt regarding your personal life, professional life, he is always there for all of us. So again, I thank Anil Magdum sir. Then come back to Haresh sir. Haresh sir, I have no words for him. So I have how to drive car, or specifically how to park car in Mumbai. He taught me that first thing in my laparoscopy training. So every time he is with me, difficult cases, small cases, whatever it is there, he always scolding me. So you are doing in this wrong way, you have to do like this. But always just like big brother, how he scolds us. And he was totally busy in his schedule. He operates more than 5 to 6 endometriosis cases at his center and across the whole Mumbai. And he somehow managed to take out his time, and he came for us. Then Dr. Vivek Savanke sir, he is God for me. He has given everything, whatever I am today, I am standing in front of you as a laparoscopic surgeon. So this is the man behind me. He is taught each and everything, how to paint the patient, how to drape the patient, how to arrange the cable. This was the first 15 days I was doing that things only. How to arrange the trolley, and specifically he taught me discipline in my life. I was literally, I don't know, agar wo nahi hote the main kya hota aur kya karta. So he has bring discipline in me, in my surgical skills, and every time, whenever, see, I tell you seriously, yesterday he was operating till 9:30 p.m. in the Mumbai. He was about to come or no, because he has not taken almost last every Sunday he is somewhere doing free workshops across the country, and he is the real king of endometriosis, all we can say the India. When I was doing training, one doctor in Mumbai said that if you have taken, I repeat myself, if you have taken birth as a gynecologist, you must see Vivek sir operating in live surgeries. So we are fortunate sir is here, and he is about to start his endometriosis case in the operation theatre. And lastly, the Miraj OBGYN Society, our mentor, Somshekar Patil sir, when I told him, sir, we are going to conduct this kind of things in Miraj, first live workshop in GMC Miraj, sir was so excited. Sir has given full support from whole Miraj OBGYN Society. Daily he was guiding me, this you can improve, that you can do. The cases he has discussed with me, he told me that you can keep this kind of cases. Yes, you can finish 10 cases nicely. So thank you Somshekar Patil sir for guiding every time with me. I thank Matron ma'am, I thank whole GMC staff, all my residents, whole my unit, all my lecturers, all my SRs, who has, without them, it wasn't possible. Whole cases, all my residents has collected, they have selected under guidance of SR and lecturers. So I thank everyone, and we'll just begin with the next session.
Now, with great respect, I invite our esteemed HOD, Head of the Department of Obstetrics and Gynecology, GMC Miraj, Dr. Ravi Raval sir, to address the gathering and guide us with inspiring words.
Good morning to all. Respected dignitaries on the dais, Dean sir, Dr. Prakash Gurau, Medical Superintendent of both the hospitals, Head of the departments of various departments here, Acting Matron of the Institute, and all the esteemed faculties, participants, and all the students over here. A warm welcome to all of you to this workshop, ABCDE. It gives me immense pleasure to welcome you all here today, and I couldn't believe that this day would be this bright and this successful when we first started this. It's a great honor. Really, it's a great honor to have such esteemed faculties operating over here. It's highly encouraging. It's highly inspiring for us to be with you and to see you operating live. The whole objective behind this entire exercise was to stimulate students, to teach them the basics, and of course, to make them know what is happening in this world of endoscopy. With such great stalwarts here, all the recent advances and all the recent techniques which they have skill would be evident to them, which will be really helpful for them to go ahead and practice endoscopy. The real crux or the success of such workshop, I feel, would be then when students go out inspired in search of a place where they can go and learn endoscopy. Today, when I stand here, I really want to thank Eagle Coordinator, Dr. Vikas, and all my PG students who have put tireless efforts to make this day so beautiful today. And I hope, and I really hope, that all the students from here go out with a lot of insight and a lot of inspiration to practice endoscopy. Thank you.
Thank you, sir.
Now, it is my privilege to invite Dr. Prakash Gurav sir, Dean of GMC Miraj, to deliver the inaugural address.
Pratamta, I must say thank you to all faculties who has traveled from far away. त्यामध्ये आपले senior most faculty just now our Devkare said, Dr. Vivek Salunke, Sanjay Shanbag, Harish Wagashia, Dr. Anil Magdum, Hemant Shintre, Neha from Dubai, and our own faculties like Vikas Devkare, Ravi Rawal. I must say thanks. Thank you in the sense that you organized this workshop in Government Medical College premises. This is a pride privilege for our institute to host such an important academic event that brings together experienced clinicians, skilled surgeons, and enthusiastic learners. Live surgical conferences such as this provides a unique and valuable learning experience. Observing procedures in a real time allows participants to understand not only the surgical techniques, but also the critical things, teamwork and coordination that are essential for successful outcome of obstetric care. With the rapid advancement in the medical science and surgical techniques, it is essential for all of us to continue updating our knowledge and refining our skills. Academic gatherings like this create an excellent platform for sharing experiences, discussing challenges, and learning the latest developments in obstetric surgery. I would like to sincerely congratulate the organizing committee for their dedication and hard work in arranging this conference. I am confident that today's live demonstration and academic discussions will be highly enriching and will inspire all of us to further enhance the quality care we provide to our patients. Lastly, before I conclude, I must say thank to all the departments, Department of OB-GYN. Of course, I must congratulate Department of OB-GYN. They are enthusiastic in arranging and doing this workshop. Let me tell you frankly, this is the second workshop which has been arranged in this institute. It was way back in 2018. The surgery has arranged one workshop for hernia, and after 8 years' time, this is the second workshop has been arranged by gynec department. I think we should cut short the distance, the gap distance and gap period, so that frequently all the departments should come across and arrange multiple such events, either conferences or workshops in this institute, so that there will be academic activity will be going on in the colleges and everybody will be updating their knowledge and all. So thank you all. Thank you very much. And I think everybody will enjoy this particular today's workshop and enrich with knowledge and everything. Thank you very much.
Thank you, sir, for your inspiring guidance and for encouraging academic excellence.
Now I request Dr. Ravi Rawal sir to felicitate our moderator Dr. Rahul Sangolkar sir. Now moving on to our poster presentation prizes. We appreciate the enthusiasm of all participants. Today the winners will be awarded by Varies needle, symbolizing the spirit of laparoscopic surgery. I request Dr. Vivek Salunkhe sir to felicitate our winners. Third prize goes to Dr. Rishikesh and Dr. Pooja. Second prize goes to Dr. Aditya and Dr. Tanvi. Thank you, sir. I request Dr. Somsekhar Patil, sir, to finally our first prize for best poster presentation goes to Dr. Shruti Ranjanagi. Second prize goes to Dr. Aditya and Dr. Tanvi.
I kindly request Dr. Harish Vagasia sir and Dr. Vivek Salunkhe sir kindly move to OT for next case, sir. Thank you, sir.
I request Dr. Somsekhar Patil to announce first prize. Finally, first prize goes to Dr. Shruti Ranjanagi. Shruti Ranjanagi. She is not here. Kindly hand over the.
Resist to mention one thing, sir. I just operated in our OT as they're working in this institute. I am an alumni of this institute, and in 2009 I was there doing my internship and running in the corridors and supporting in the OTs. But now the OT which I have seen, it's almost or better than Leelavati OT which I had worked before. I completely congratulate the administratives behind this. It cannot happen without such good administrative support, and it will definitely help improve the quality of healthcare which we are giving, and also the expertise of the nursing staff, the residents, and all the lecturers and the surgeons which are operating there. I want to definitely admire and congratulate the administrative support for that.
I kindly request Dr. Vikas Devkare sir to felicitate Dr. Ujjwala Khairmode ma'am, Head of Department of Anesthesia. So this way we conclude the inauguration ceremony, and we will now move forward to the next live surgeries.
चालू करूं या तो चालू करेंगे क्योंकि दोनों साथ में इंड्यूस हो रहे हैं अंदर लिया है Polypectomy. बुलाते इसलिए बुलाते लिया है स्टार्ट करूं क्या मैं स्टार्ट कर रही हूँ मैं बोल रही हूँ फिर
May I request the audience to kindly take their seats so that we may proceed with the program? May I request the audience to kindly
performed by Dr. Vivek.
but everyone can hear now
I request all the moderators to come back to the hall.
kindly
I request all moderators to kindly come back to the hall.
kindly have their seats kindly have their seats so that we can move forward.
Now kindly I request all moderators, please come to have their seats so that we can move forward. Please.
नेक्स्ट केस के लिए मैं जा रही हूँ नेक्स्ट केस चालू हो गया
Now we are introducing our next case of today's workshop, endometriosis. The procedure will be performed by Dr. Vivek Salonke sir. He is a senior gynecological endoscopic surgeon with 25 years of surgical expertise. He has been the director at Nalini Specialty Hospital and consultant at Leelavati Nanavati Hospital, and he has been expert in advanced endometriotic surgeries and has expertise in dealing with complex endometriotic cases involving bowel, bladder and ureters. The case today is 28-year female, para 1 living one, previous LSCS with endometriotic cyst, MRI suggestive of 8 into 7 centimeter endometriotic cyst. Now we kindly request all our moderators and
वामन गोटके सर
and Dr. Vaman Godke sir specially
to kindly moderate this session. I also request Dr. Rahul Sangolkar sir to moderate this session.
now we are connecting live to our OT complex. Thank you.
Simultaneously, another fourth case is getting started in another OT. This procedure is hysteroscopic polypectomy with scissors. This will be performed by Dr. Haresh Vagasia sir. Sir is renowned gynecological endoscopic surgeon with over 12 years of experience in laparoscopy and hysteroscopic surgery. His key area of interest include infertility endoscopy and advanced endometriosis surgery. Currently practicing a consultant gynecological endoscopic surgeon in reputed Apollo Hospital, Mumbai. So this case is 41-year-old female with abnormal uterine bleeding with polyp. USG findings are suggestive of moderate hydrosalpinx with endometrial polyp of 14 into 6 mm. May I request our moderator to kindly guide through the procedure. Specifically, I request Dr. Alpana Watve ma'am to kindly moderate this session.
Hello.
Yeah, thank you everyone. And since there's some time, I would like to make a few comments. So hysteroscopy is one of the easiest procedure that you can learn. This is especially for the PG students. The learning curve is much shorter than laparoscopy. And you'll be surprised to know that the first hysteroscopy was done in 1869 by the help of a candlelight, that too, and with the help of a concave mirror. So now we've come a long way since then, and I'm sure we'll be looking at very nice surgeries now. Thank you. So if we can connect to the OT, they can show us the trolley and the instruments maybe. Can we connect to the OT?
तुम्ही बोला.
So good morning, everyone. Two cases are planned. One is endometriosis and another is polyp. You have seen the history of the case of a polyp. Previous to LSCS, prior to living to chief complaints, they mention pain in abdomen. So hysteroscopy is the basic procedure which everyone should know and everyone should supposed to do it to evaluate the cavity. So per se, meanwhile till it will start, we'll see what is exact hysteroscopy and where it starts. The hysteroscopy starts at the level of introitus. Don't go directly into the endometrial cavity. You put the scope at the introitus, you will see the introital pathology, vaginal pathology, cysts, even grade 4 endometriosis can be detected with vaginoscopy if it is puckering on the posterior aspect. Then go for the furnaces, external arch, cervical canal fibrosis, cervical canal tract, then polyp, any fibroid in the cervical canal, you can diagnose it and then enter into the endometrial cavity. Once you enter into the endometrial cavity, you should take the panoramic view and have to visualize both the ostium. Then you come to notice that the cavity is good, adequate, or it is T-sept or any other developmental defects in the endometrial cavity, and then you can start with your whatever the procedure you have planned for. OT connected नहीं है क्या?
Can we please connect audio to the OT?
So OT2 is case of
this light is not adequate.
And Dr. Harish is operating.
It's okay.
Hysteroscopic polypectomy.
But fine, we'll try. Light incompatible है तेरी, इसके लिए grainy दिख रहा है. This light is less, so it is grainy picture. Okay, anyways, no problem. It's okay. So no worries. Am I audible?
Yeah, Doctor.
Okay, so when you starting the hysteroscopy, we do not use any speculum, valsalum, anything. Okay, so we do vaginoscopic approach, and the scope, the light cable is at 6 o'clock. Okay, with which 30-degree scope will have a beveled edge coming forward. Okay, are you seeing me?
Yes, sir.
Okay, so the beveled edge is forward. So when the beveled edge is forward, that means when you want to see down, you will have to lift the camera up. And when you want to see up, you will have to lower the camera down. Okay. And of course, this one will come in the picture, but later on. So you see the way I enter. Okay. And this is how you hold it. Okay. The pen holding initially, just to have the vaginoscopic view. Once I have the cervix and the external os in my vision, I will change the grip from pen holding grip to shake hand grip. Okay. So can you have the flow on?
Sir,
so right now the flow is 400 and the set pressure is 80. Make it 80. 80. Yeah. Okay. So the set pressure is 80. Now if you look at the flow here, okay, can you see the flow?
Yes, sir.
Okay. Now what happens to the flow and the pressure? It depends on everything on the channel what you are using. Ek instrument de kutla tari. Any instrument. Huh? Okay. So when you put an instrument, automatically it's causing a coefficient. No, I want a gauge piece here. Okay. That's fine. So automatically you see the flow will reduce. Okay. You see the flow is reduced. Are you able to appreciate?
Yes, sir.
Okay. So now these are the all coefficient that is going to change our configuration in the theater. So I do not want to do anything. I would just, do the hysteroscopy with the instrument inside. Okay. And I would just enter like that without touching the patient. Okay. Why I am doing this way is because I do a lot of office hysteroscopy wherein you don't touch the patient. Particularly being a male operator, patient do not like to, that you are touching her. So if only the instrument is going in, now you can see three things, okay? The upper one is the anterior vaginal wall, the lower one is posterior vaginal wall, and in between is the cervix. So now you can see some mucus coming in at 3 o'clock position, okay? So I will go towards that area and I can see the external cervical orifice, ECO. I do not call it external os or internal os because there are no full form of os. Do we have that? Do we have full form of os? No. So ECO is external cervical os. Most importantly that we should come, together for a terminology. Okay. So that's the external os. Now I'm putting my scope there and allowing the fluid to go inside the canal. Okay. And it's going to respond by ejecting some debris and the blood and all that outside. Okay. So now I'm going to go and negotiate. How do you negotiate? So you go on one side, you see the arrow right now is at 6 o'clock. The pointer on the laparoscopy or a hysteroscopy vision is at 6 o'clock. Okay. It goes to 3. Then it goes to 9. Okay. And I'm inside the canal. Okay. Yeah, it's on. Yeah, it's okay. So yeah, light is fine. Nothing to be changed. Now we are inside.
So I just have a question. Sometimes the cervix is very badly fibrous. Would you like to do some pre-operative preparation with maybe prostaglandins?
No, ma'am. I do not want to do that because this is under vision. So if there is a fibrosis, I will show you how to deal with it.
Cut it with the...
Yes, we cut it with a Caesar. We do not dilate or we do not depend upon the drugs, but purely on the surgery and haptics and understanding the pathology, because you want the pathology to be there without any effects. Now, because I use 4 millimeter Batocchi hysteroscope, 4 millimeter hysteroscope does not mean hysteroscope size. It is a sheath size. The sheath of the Batocchi is 4 millimeter. Today I am using 5 millimeter. So whenever you see a notch, a small point there at 6 o'clock, that means it is 5 millimeter Batocchi. If in the 4 millimeter Karlstroh's or any other scope, you do not have any notch because there is no space for it. Are you getting my point?
Yes.
So it's just a round without any pointer. So this is the internal os. You see, I have allowed some fluid to go. Now you can see at 3 o'clock position, there is concentric wall like thing. That is nothing but a fibrosis. So my Caesar is ready. It's going to come in. Okay. And, oh no, it's not focusing. No. This camera is not focusing. Devkare sir, your camera is not focusing fine, okay? So we are now, you saw how I can remove the,
very nice.
So the Caesar just comes in and it just divides the fibrosis, all those concentric, I have to go slightly away to understand the focusing, okay? Now again on this side you can see,
yes.
Okay, so I will go there and give a small cut there. Okay, and you see both the hands work together. It's not only that the Caesar goes in. Okay, now both the side the incision is made. Now I will slowly lower my scope and enter in the cavity by negotiation. Okay, again, so now I am inside the cavity. You can see some shedding of the endometrium happening. The patient is in her menses right now. And sometimes people think that, oh, patient is in menses, so you can't do surgery. It's not like that. Suppose you are operating a case and she starts bleeding, then you cannot evaluate endometrium, that's for sure. But you cannot operate in bleeding, that's wrong. Because suppose if I operate and start bleeding, that means I'll continue operating, I'll not stop. So you can obviously do the surgery in the bleeding. So this is the polyp, okay, and this is the shedding endometrium. I'll throw you some light on evaluating the endometrium, and then I will go to the polyp, and I'm going to do something called a slicing technique, which is with your existing instrument how you can do this polyp without adding a resectoscopy. However, if you want to see resectoscope, I can put in resectoscope as well. So that depends upon your interest, but I will show you a slicing technique right now. Okay. So there is a breathing, okay? There is breathing. Can we have increased to 100? So flow is pulsatile. Pressure 100.
What are you doing for
Okay.
the distension in the uterine
So what I'm doing to maintain the distension in the uterine, I'm using a Hysteromat, okay, from Phlomasis, and that is giving me a constant flow, not pulsatile. So what happens is that when the patient is in menses, uterus will contract, and once the contraction occurs, the good a good Hysteromat will talk to the uterus. So as the uterus contracts, it will not go against it. For example, a good CO2 cylinder will not insufflate too much gas when the patient is coming out of anesthesia. You all must have experienced that when the patient comes out, the CO2 pressure actually drops. Okay, similarly, a good Hysteromat, when the uterus is contracting, will not flow excessively. Okay, so now what I want to do is I'm going to evaluate the endometrium. You can see this is all secretory endometrium, which is now almost ready to shed. Okay, and there would be some hematomas inside that also. I will go close, but actually, unfortunately, the fine adjustment is not working very well. So I can't show you the details of the glands and the spiral artery and all. Otherwise, I would have shown. We need to have a good, clear, near focus working. The existing camera, what I am having, has very poor near focus. Means it is coupler is not very nicely. But still, I can see you the spiral. Can you see the spiral vessels?
Yes, sir.
Are you able to see the spiral vessels now? And parallel to the spiral vessels, you see thread-like things. That is nothing but the glands. Okay. So this is how you evaluate the gland. You see the regularity, numbers, vascularity, and then that is how you notify whether this uterus has got good endometrium or no. Now this is the pedicle. Can you see the pedicle here?
Yes,
the posteriorly.
sir.
Okay.
Yes.
That's the pedicle. I will show you the ostia. So you have the orientation. Can you see the ostia?
Yes.
This is the right ostia, and I will go to the left now, and that's the left ostia. The saline is ice cold. My hand is freezing, okay? If my hand is freezing, I'm sure we can do something to the saline. Can we?
Warm it.
Not warm, but at least normal temperature. They are in AC, no? So if they continue, that's okay. Let it be. Let it be. Let it be. Now let it be. But दूसरे saline थोड़े बाहर ठेवा, outside, not in the OT. So I'm going to slice it, ma'am, now. Because you see my opening here is this much, okay? It will never accommodate that big polyp to draw it out. So I'm going to make my delivery easy. So I have to make this singleton into twin. So then my delivery will be easy. It's exactly like, so I don't leave my obstetric understanding. So that way I will reduce the bulk. You go in the center and divide the polyp into the pieces that will accommodate the internal loss, okay? And once the piece is done, you do not come out of this area ever, okay? And you can see now the piece is almost done. I'm at the base, and that's the base. Focus. Only if you change the head, no, will be better. If we can. So that's, you can see now two clear
bisected.
Can you see that?
Yes, yes,
yeah?
sir, very well.
So now all those people who are doing vaginal and bisection is missing, they can satisfy their bisection satiety here. Hunger.
No pouring required, yes.
Yeah, no pouring required. So this is bisection, and you do not do that, you do not do anything to the pedicle right now. Okay, so that's one, and I will evaluate the other piece if it is too big or no. Okay, so it's okay. So now I'm going to go to the base. The base is in the posterior wall. So you see I'm going to take it at 12 o'clock. Okay, and then that's going to be very clear for the base. Now base is slightly challenging. You can see that base now? I hope you guys can understand. This is the base, yeah?
Yes.
Yes.
No, is the audience understanding?
Yes, yes.
Yes.
Because Vikas may say yes, I know Vikas very well. Vikas may say yes sir, but I want audience to understand. No, it's okay, beta. I know Vikas. So that's the pedicle here, okay? This is the pedicle. And I'm going to be taking the pedicle with the scissor. See, I'm pushing it, I'm not cutting it, okay? By pushing it, you make it more available for your cut. That's the pedicle. Are you all appreciating? I hope you guys are.
Yes, we can.
Oh, that's great. See, that's the pedicle on the, it's actually posterolateral side. No, it's fine. So what is the most ideal time of surgery? Okay, now in hysteroscopy, generally when the patient comes to you, you don't want to lose that patient. So you say that I will do. So, but then whenever you post the patient, like this patient is almost day 1 or of menses, okay? So she's all in the secretory phase. Now can you see, appreciate the pedicle now?
Yes, sir.
Okay, it's generally the base of the base of the polyp is very, very important for you to remove. If you don't remove the base, the patient will have there is a fantastic study on more than 30,000 cases by Bataki. You can read that paper. I can forward it on the group, and Miraj, I think Devkare can forward it to you guys, and understand that whenever we do polyp by just cutting the pedicle, it will come back. Okay, it's not like a myoma, which is pedunculated myoma, wherein you just divide the pedicle and leave some pedicle on the body. Fibroid will not come back, but polyp is going to come back because the rise of the polyp is from the pedicle. Okay, so we do not have very clear picture now. So what I'm going to do is I'm going to have much better to understand. Wait, we'll show them. So one piece I will remove with the grasper. Okay, usually leak कर देगा तो current remove still. So I'll remove one piece with the grasper, and then I will put in the mini resectoscope for you guys to understand how the resectoscope works. I'm not going to take long. So if Vivek sir is ready there, I will just give you a video and the audio in about couple of minutes, not more than that. Okay, so you see now, this is the grasper, and you go at the base of the polyp. Okay, like that, you hold it, don't pull it out, push it inside, make it free. Okay, now can you see the polyp coming out, the piece?
Well.
Yeah,
Yes.
Do not hurry. Do we allow the delivery to happen hurriedly? No, wait for a while for the uterus to deliver it out slowly. Wait, and wait. Light off, money off. Hey, can you see the piece of polyp in my hand there?
Yes, sir.
Yeah. So that's the polyp specimen which is going now in the bowl, sorry. And now I'm going to change. So what I'm going to do is keep the camera light same. I'm going to only change the inflow and outflow to the resectoscopic sheath. Now why am I taking resectoscopic sheath? You will understand it in a while. Okay. Yeah, so you don't change the camera, the scope, because I'm going to use the same 2.9 Bataki hysteroscope. Put in the resectoscope above it, a loop. Now to understand the mechanics of resectoscope, the resectoscope handle will always come opposite to the light automatically. Okay, while in operative hysteroscopy, you will struggle to bring your scissor down. Okay, are you understanding? See this here, the handle and the light are opposite each other.
Yes, sir.
But when you put in scissor, you want to work like this, like that, okay, and that is when you have a lot of breakage of your instrument. If you learn to work with the scissor grasper also reverse way, means keeping it on the top,
180.
okay, and when it comes up, this goes automatically down, then it will remain straight and it will never break. So loop of electrode will not get broken ever, it will get burnt, but it will never get broken. But scissor on the other hand gets bent and broken. Okay, so now we have a resectoscopic mode. कौन सा है ये? आपला हिस्ट्रोकट नहीं है, हिस्ट्रोकट मोड नहीं है याच्यात, हिस्ट्रोकट मोड आएगा, नहीं है. Okay, fine. So there is anybody who has Allen Combi Max can send the machine to the company and get it installed. Histro cut. Okay, it's a wonderful cut that we have devised. So now you start the flow. Okay, so again I'm not dilating, not touching the patient, going without that, okay? And now you can see the blood coming because we have done the polypectomy, and I'm going to be going inside without, you see that resectoscope?
Yes, sir.
And now resectoscope will go by rotation, okay? So you can see the rotation happening, okay? Done. Bas, okay? Now you will see.
What is the diameter of the resectoscope, sir?
This is 18.5 French, so nearly 6.2 mm. Can you see the pedicle now?
Yes, very well.
Yeah, so that is because of the distension. And what I'm going to do is just push the pedicle and bring it to the, to the minimum area of my, and she is anyway completed family. So now that's the pedicle, you see? So the pedicle, I'm going to be jabbing the pedicle, and that's it. It's all over.
It.
Okay, so the pedicle is gone and the polyp is now free. Okay. So that polyp is free and is going to get delivered. Is it free? Yes. No, not free yet. And that's it. Okay, so the polyp is coming out. Still there. And the part is here. Yes, that's the final part of the pelvic. Okay, can you see?
Settings?
Yeah.
What are the current?
The current setting is 70 cutting. Okay. Now I'm only using a cutting, 70 cutting. I never use more than 70 cutting.
Okay.
So that's my cutting. Even in myomas, I use only that much. That's the pedicle area. You can see that pedicle area. Yeah.
Yeah, a few tags are still.
So this is all endometrium. You can see the glands on it.
Yes.
The cut dots.
Right.
Yeah. So that's the endometrium, not the pedicle. Pedicle was here. This one was the pedicle. This.
Yes, we can appreciate the
Yeah.
glands.
That's the pedicle. Okay. And
Very nice slicing movements.
so that's it. We are done with the polyp. You can change the audio now to the other side. What we have done is, another thing to appreciate here is the polyp has come out. Okay, out. You can see here what we have done is, can the camera come here? Just showing a quick point. You see what I have done is, while working, I draw this bucket slightly out. Okay, and there is only the plastic sheet. Can you see?
Right.
Yes, sir.
And I have not covered this one right up to here. Otherwise they get wet. So there is no nuisance loss of fluid. So now if I want to just understand how much is the fluid loss,
Yeah,
I just remove this suction from here and dip it into this bucket.
Okay.
Okay?
Okay.
And as soon as I do that, all my tissues, everything, all the fluid will come in this suction, and it will give us the output. Okay?
So
So you can then calculate
You
input and
are
output.
keeping the outlet open at all times.
Yes, ma'am?
You're keeping the outlet port open at all times.
I am keeping, yeah, obviously it is always should be such continuous flow.
Yeah.
What does
So that
continuous
you
flow
can
mean is, yes. Otherwise it will become stagnant and it will become very hazy and dirty picture.
Yeah.
yes,
So you need to always keep it. You can play with it. You can
Yeah,
keep it
sometimes
less.
the pressure
yes.
is less,
So
you can
depending upon
just-
how much income you get, you spend that much.
Oh, yes.
Exactly like that. So if you earn a lot, you spend a lot.
Lot, yes.
So if there is too much of distension, clear picture, spend a lot of money.
Yeah.
If you don't have, restriction, there is a lot of debris, lot of things.
shut down.
Then you shut it down.
Okay.
Correct, sir.
Yes,
Very
sir.
nice demonstration, Dr.
Thank you
Aman
so
here.
much. Thanks.
Two more things I'd
Yeah.
like to add.
Yes.
In fact, you should tell us, all the audience and the new learners, whenever this loop is our curate, the loop is the curate for the hysteroscopic surgeon.
Yes.
Instead of using the curate, we always use the loop to do the DNC for an infertile hysteroscopy for the evaluation.
Right.
One thing, and another thing is subendometrial blebs of adenomyotic lesions in the infertile patient. Sometimes it will mimic the early gestational sac. Even if you push the endometrium, the bleb will come out, and if you cut it, endometriotic fluid like things
Yes.
will come out.
Yes.
So these are the beautiful aspects of the
Yes.
loop.
Loop,
So loop
yes.
is our curate and
No, another thing, Dr. Godke, is that the resectoscope is much easier to learn.
Yeah.
You know why? Because it's like automatic car. There are hardly any things to change.
Yeah.
You don't have gears to change. You don't have clutch to press every time. So the scissor and grasper is like a manual car.
Yes.
So you have to press the clutch, then you have to change the gear. You have to understand what gear is in. So
it is like an automatic car.
Yeah. So this is like automatic car. You know, you don't have to change anything. You have to just do something like a plowing. एक फावडा घेऊन आपण ते फार्मिंग कसं करतो, गार्डनिंग करतो, something like that. You have to just do only one thing.
Yeah.
While in mechanical instruments you have it's for the people who know their hysteroscopy well. But our understanding is other way. We learn it other way. When the students are going out, they have very limited resources. So they always say, sir, एक चीज लेना है तो क्या लूं? So obviously then the option is operative hysteroscopy.
Thank you so much.
Yeah.
Dr. Hemant, we are pleasure to watch you, and we are so lucky to have such a great hysteroscopic person in front of us operating. Thank you so much.
Very good work. I would like to ask one question.
Yes, ma'am.
Would you like to do a 3D ultrasound for a polyp to look at the stuff before that, if you are doing ultrasound?
Yes, ma'am. So basically, 3D ultrasound I would like to do for polypectomy if the patient is having infertility for sure. But if the patient is coming in perimenopausal, most of my sisters, I have done this. I have not even done TVS. Okay, because they have come to me with irregular spotting, bleeding, and I have taken them in the office without IV line, without investigation, because it's like an office procedure. How you do TVS, I use my hysteroscopic like that. So I just give a polyp in their hand when they come for the first visit. So this is only reserved to the perimenopausal. But otherwise, perimenopausal and menopausal, you will see diagnosed polyp very easily because there will be some fluid there sometime. But in the infertility patient, most of the time the polyp is missed. So either combining with sonosalpingo or
3D. Good
3D will be better. Yeah.
And that will also show you the feeding.
Also, it will give you the idea about dysmorphism in the cavity. Whether you want to combine it with some metroplasty, you can do that.
Yes, sir. Dr. Hemant here, sir.
Yes, sir.
Few bullet points for the beginners. For diagnostic scopy, how much histomat pressure? For operative scopy, how much pressure?
So for all practical purpose, please forget the term called diagnostic hysteroscopy. Now, madam said 3D sonography. Now, 3D sonography is a diagnostic tool. You cannot do anything to the polyp. Now, after you diagnose a polyp, which thing you will use? Hysteroscopy. Suppose there is a missing IUD, what will you do? Hysteroscopy. If there is a Asherman, what will you do? Hysteroscopy. So you will not do diagnostic hysteroscopy in today's era. It is scrubbed. This particular terminology has been completely opposed by European school, and Batocchi hates people who say that diagnostic hysteroscopy. So we do not buy diagnostic sheath. We do not do diagnostic scopy. We do all operative scopy.
So you would be
minimum you can do is take a biopsy, right?
So you would be putting in the operative directly.
So you always take, and the pressure does not depend upon whether you are doing diagnostic or whether you are doing operative. It depends upon how is your clarity, how much space do you have. Exactly when we discussed the first two cases about the intra-abdominal pressure, I said that I initially take higher pressure. Here in office hysteroscopy, I initially take lower pressure because I give patient to understand some time, the uterus to make it my friend. So then after some time, if I increase the pressure, then the uterus will listen to me.
So just
as soon as I introduce...
With what pressure you start?
Okay, so around 60 to 80 is my pressure. Today also I started with 80 and then I increased to 100. Now let me make you understand two things. That you are also sucking out some fluid, okay? So when you suck out, the coefficient at 0.2 bar changes to 15 mm minus. So suppose you started at 60 and there is a 2 bar suction, then you will get somewhere around 45 millimeter of mercury in the uterus. Are you getting my point?
Yes, sir.
Same way, when you start with 100 and use 2 bar of suction, the pressure will be somewhere around 80 to 85.
And for resectoscopy, also same.
No change.
Okay. And if you encounter a septum, we have a case of polyp here, but we have to discuss septum also because we get so many septums.
Yes.
So any take-home points when we are dealing with septum, sir?
Yes. So now there are two school of thoughts in septum. Batocchi school and the other rest of the world. So now what happens is, like, suppose do you guys this is the point for you to introspect. Generally septum needs division, okay? That's what has been understood. Now suppose the septum, whether septum is SOL or no SOL, Is it space occupying lesion or not space occupying lesion?
Sir,
If you do a 3D, suppose there are two patients with identical dimensions of the uterus. Two patients, one with the septum, one without a septum. Now one with the septum will have some area of septum occupying in the cavity. Am I understood?
Yes, yes. So
And
it'll be
the
like
patient
that,
without septum will have a good area. Now just by dividing the septum, it appears to you on hysteroscopy that you have done something great. But there are so many patients who come back with recurrence of septum in some part of the septum. Of course, there are people who do it very diligently, but some portion of the septum which is fibrotic, you need to excise it. So I generally excise some portion with a loop, or if the patient having thick septum, then I just go with the Collins knife and divide it in the center. But again, you will see this.
septum is supposed to be vascular now, not avascular. So we have.
Ma'am, it depends upon the thickness of the septum. The septum which is vascular is on the upper part of the septum. The part which is in the cervix or in the isthmic area is not very vascular, but the part which is higher up in the body and the fundus is more vascular. And it is histologically proved that that part is fibromuscular and the lower part is fibrotic. Another point I would like to highlight is whenever you are posting a septum, you must prepare this patient with either OC pills or just progesterone, like Dynogest or any progesterone, for 2 months so that the endometrium is suppressed. When you do a septum, you see a lot of endometrium with polyposis, and then that makes your resection not very good. I mean, not complete at times. Okay?
So, Dr. Hemant here, pardon me for asking 2 more questions.
Yeah.
What is your expert advice on resection of the endometrium and endometrial ablation?
Endometrial ablation is not a hysteroscopic question at all. And endometrium resection, that is TCRE.
Yes.
So you see less number of TCRE nowadays because TCRE had very high risk of recurrence coming from the cornual area. And the endometrium extends laterally, the cornua is round. So the endometrium used to come almost up to the mid cavity, and again TCRE making it inaccessible for biopsy later on. So the TCRE is not a very famous procedure now, but it was a procedure of very much choice when the TLHs were difficult. Now the TLHs has become very simpler, and that's why the TCRE has become, again TCRE will only address to the endometrial pathology. It will not address any adhesion, endometriotic foci, fibroid, adenomyosis which is in the uterus, generally seen along with the AUB pertaining to only endometrium.
And for submucous myomas?
Of course it is myoma resection, but again,
do you use cold knives or resectoscope, sir?
No cold knife, resectoscope always.
Okay. Thank you, sir.
Cold knife you use it to dissect, like suppose if I have a patient who is a tricky myoma, say around 4 centimeter, and then now this patient has FIGO 2 or FIGO 3 myoma, I would use cold knife. Do you know what is cold knife, by the way? Anybody knows cold knife? Cold knife means no scissor. It's a resectoscopic loop which has no electric supply. So there is a special sturdy Metzon resectoscopic loop which comes, which you put it in the, so you give a cut to the myometrium just like laparoscopy, you give a cut on the myoma and then dissect this both the side and allow the fibroid to come out and then do the myomectomy. Yeah, we go to the other OT now.
Yes. Thank you so much.
Thank you so much. Thanks.
Your sentence like uterus will listen to you.
Thank you.
In another OT, Vivek sir is operating endometriosis. Can audiovisual people shift mic to him?
Hello.
Yes, sir, you are on, sir.
Can I be heard in the auditorium? Hello?
Yes, sir, you can.
Yeah. Okay, so very good morning, good afternoon to everyone. And I'm extremely happy and elated to come here. My colleague Vikas, we worked together for some years, some months, and then he's doing wonderful work here. Then my friend Anil, Hemant, everyone is doing very good work here, and all of the medical college infrastructure, we can find so nice OTs. So thank you for inviting me. And I am demonstrating a case of endometriosis. She is a 28-year-old patient, pelvic pain and dysmenorrhea to the score of 8/10. These are symptoms. And she has pain mostly on the right side, radiating to the back and the legs. Otherwise, she doesn't have dyspareunia, she doesn't have dysuria or any changes in the pattern of urine or motions during periods. So that emphasizes the, yeah, this is nice. Yeah, what is?
Sir, good afternoon. Everybody is eager to watch you and understand the endometriosis from you.
Yeah. So deep endometriosis, whenever there is deep endometriosis surgery, how is that? Are you getting a good vision in the auditorium? Yeah, this is
Excellent vision, sir.
Yes, yes. Okay, so we thank this Escalab team also to arrange a 3D, because I am quite used to working in 3D. So any complex deep endometriosis cases, you have to, the requirement is a 3D vision. You can do it in 2D, but then you really have to maintain a very clean field all the time, and it may not be possible for endometriosis cases. So to assess, we use #Ingens classification. We see the peritoneum, ovary, tube, rectovaginal septum, parametra, and the rectum involvement itself. And then for adenomyosis, ureter or another distant lesions. So peritoneum, we see the lesion. If you see, she has a lesion in the peritoneum from here, starting from here. You can see the peritoneum till here. After that, it is adhesions. On here, again, you can see the normal peritoneum here and the affected peritoneum. Can you see the thickened the peritoneum and the implants here?
Yes, sir.
Yes. So this is the uterosacral ligament. This is the parametra. So parametra, you should understand as a lateral parametra, posterior parametra, and anterior parametra. The most commonly affected by endometriosis is the posterior and the lateral parametra. The posterior parametra would be the uterosacral ligaments, lateral parametra over the iliac vessels. So you understand this. So there is a B compartment involvement, B1, B2 or 3 here. There is ovarian cyst which is attached to the bowel. The MRI has confirmed there is no deep infiltration inside the bowel. So we are going to do a conservative surgery for her. So peritoneum, ovary, tubes are normal. Rectovaginal septum looks okay. There were adhesions, and parametra on the right side more, left side less. Actual involvement of rectum is 0, that is C0, and mild posterior wall adenomyosis, that is FA. So this is the Engens, #Engens understanding. So it's a communication language which tell us the disease load of the deep endometriosis. So can we see here the ligament? You identify the ligaments here. This is the infundibulum pelvic ligament.
Sir, Dr. Aman here.
Yes,
can you elaborate it from the pelvic brim so that from non-disease portion we will have a better understanding?
Yeah, so this is a pelvic brim, Dr. Aman. So this is a promontory. Then this is the external iliac artery.
Yes.
You can see the ureter. This is the infundibulum pelvic ligament. So very important to assess the area in at the brim, because this is a
virgin area.
To understand. Okay, the all dissection may be starting in the virgin area or a non-deceased area.
Yeah.
So this is yeah. 1 minute, sir. So let us start the dissection.
After evaluation, sir, what should be the first point in that endometriosis surgery? How to begin?
So whenever we are doing a posterior dissection, first thing is you go and identify the infundibulum pelvic ligament and start your dissection from just above the diseased part. Identify from the brim, but start above the diseased part. So I open the. Can you?
That means from virgin area towards the disease area.
Yeah. So this is a disease area. I want to excise this. Can you see these implants?
Yes.
And then I would like to see the ureter at this place. Hold this here. Pull it out.
You always use harmonic?
Yeah, I use harmonic because it becomes, I'm used to basically.
Yes.
You are using a wonderful instrument sharer which is more cost effective. Can you? Yeah. So identify the ureter here just below the infundibulum pelvic ligament. Can you see the ureter?
Yes.
Ureter is identified by the vascularity.
So for all endometriosis surgery, this is your standard approach.
Yeah, whenever you are there, you are going to do some peritoneectomy on the back side. Pad, can you give me the pad?
So you use 2 energy source at a time?
Yeah. But if you don't find the grip of the bipolar very good, then it is better not to use the bipolar.
Yes, sir.
So can we see the ureter here? Let us see.
Very nicely we can see.
Let us see whether it is ureter.
Yes, sir.
Yeah. So once we see the ureter, we go and identify the ligaments here. This is a infundibulopelvic ligament. This is a uterovarian ligament. So
We can see lot of congestion. Is it a camera or actual pathology? No, sir, pathology, sir. Yeah, looks like pathology only.
Camera also.
Sir, we are using 3D, sir, here.
Yeah.
Hospital of 3D. Yeah.
पकड़ नहीं है. So I will, first step is from the infundibulopelvic ligament, open the peritoneum, identify the ureter, trace the ureter to some distance and lift the ovary. So what is the
lower limit to dissect
the first incision will go from the infundibulopelvic ligament to the uterovarian ligament. Can you show me the uterovarian ligament here? This one, okay? With ureter in mind, okay? So once you reach here, so this is lifted. You have lifted your ovary completely, okay?
Yes, sir.
That is one thing, and then we will hitch this ovary. We do the same thing on the other side. Leave that. Come get the uterus on this side.
So first you are trying to release the ovaries.
Yeah, release the ovaries and hitch them.
Yeah. No. So what are the chances of encountering uterine artery close to that uterovarian ligament? Sometimes anatomy is changed in endometriosis.
Yeah, if there is a lot of fibrosis, maybe yes. Just hold the tube gently.
Bowel is pulling there. Just elaborate on that also. How at the middle aspect it will get attached and pulled.
So we
what
see,
precautions
so
we should
can we see here bowel is going down here?
Yeah. Yes.
This is some, so whenever there is a bowel and the ovary or the uterus, first thing we will try to release is slight tissue on the bowel.
Yeah.
So try to not make a bowel
with the sharp dissection only you are doing.
Yeah. So we can see this, it is getting separated.
Yes, sir.
Yeah, come. Now we will go for the ovary. You can puncture the cyst. Suction there. Make a small puncture and don't make a big spill, because whatever spill you make, you only have to take care of it.
It will hamper vision also.
Okay, make a small spill. If you want the large cyst is there, you can give a wash also.
To use any kind of vasopressin at this point?
Yeah, whenever there is a lot of adhesions, we use vasopressin. We have it ready also, sir. You are not lifting.
So basic here is you want to create a space for you for your dissection.
Yeah.
Yeah.
I want to lift up the ovaries on both the sides now. Can you see the puckering in the parameter here?
Yes, sir.
Yeah. Yeah.
Peritoneum is completely affected here.
Suction.
Suction is working.
So to understand the dissection of the endometriosis, we need to understand the spaces. So again, the dissection will start at the pelvic brim in the normal area. You see the infundibulopelvic ligament and the ureter. You make an incision in between the ureter and the infundibulopelvic ligament.
Yes, sir. And Vikas has chosen the case very well for you.
Yeah,
to demonstrate everything.
Yeah.
Bowel adhesions, ovarian adhesions and all.
Yes, it is.
Always he is an intelligent guy, so he chosen the right case for you.
Right case for me, yes. So that everything can be demonstrated.
Yeah.
So we identify the ureter. Can you see the ureter?
Yes, sir.
Yes. So we see the ureter, we trace the ureter.
So it is excellent use of harmonic probes. You are simply changing here and there. The active blade is always away from the vital structure.
For any complex surgeries, we require something which can cut and coagulate at the same time. So, yeah, 1 minute, sir.
Instead of that, it is very important to watch you instead of changing the instrument, how you manage everything from the same pose, same instruments with beautiful dissection. So all these things, everyone I think has learned from you only.
Sir, thank you so much. And this one is the, can you see is the vision good now there? Less red? We changed the sheet, there was.
Sir, how is the vision at hall, sir?
Hello?
Sir, how is the vision?
Dr. Vaman, how is, I think we lost.
Yeah. Audible, sir. Continue.
The vision is good?
Yeah. It's good, but it's coming, going sometimes.
Okay, we'll ask the audio visual things. Can we see
we can have a beautiful views now.
Can you see the ureter getting pulled up in the parameter fibrosis?
Yeah.
Yes, sir. Yes. Okay, so the idea of endometriosis surgery is you do good excision, because again and again, first time you take the best chance.
Yeah.
You enter the same place again, even an expert endosurgeon will not be able to do a good job if it is already operated
So
on.
first surgery is the best surgery in complete surgery.
Yeah, first surgery you should try to have can you see the ovary getting adherent to the parameter?
Yeah.
So there is a disease. So learn to identify the endometriosis in deep, and whenever we approach for the first surgery, try to have a good excision.
Yes.
So now you can see the ureter go on tracing the ureter and lifting the ovary. My aim is to lift the ovary as we lifted the other one.
Just at the same time, elaborate the techniques also to say dissect the ureter and medialize it.
Yeah, so one minute, just leave. Yeah, hold like this. Hold this. Yeah. So generally the technique to dissect the ureter, you have to have a divergent forces above the ureter. Don't go and close. See, there ureter has an advantage here and the vascularity.
Yeah.
So I will not go and dissect here. I will go and dissect here. Can you see?
Yes, sir.
I will not go and dissect on the ureteric.
Yeah, very nicely we appreciate here.
So once I know that it is there. What is that? So, yeah, so we see the ureter going there, and now the ovary is nearly getting lifted. I know the ureter is going there, so I can lift this part.
So every gynecologist is worried regarding the ureteric injuries.
Yeah.
At the same time during surgery, it's again your job to create a confidence in everybody's mind that ureter is our friend and it usually not get injured, and if at all to dissect it, how to do it.
Yeah, there was always a tendency like we just stay away from the ureter, don't open the retroperitoneum and keep on doing the surgery, being close to the uterus. Now over a period of time, this concept has surely changed.
Yeah.
1 minute, sir, 1 minute. And basically the idea is whatever you are likely to injure or whatever is you are going to come in the way, you dissect it positively. You dissect the ureter, you dissect the nerve, you dissect the rectum, and then excise the disease. Simple it is.
Yes, sir.
So you can see the thickened uterosacral ligament pulling the. Turn the camera. Yeah. So we go. This has a function of flip. You can go from the 30 degree. Seeing from lateral is not possible. Seeing from up and down is possible.
So you change here your approach.
Yeah. So I'll just leave this. I'll open this. Yes.
Badly adherent there.
Now you can see this is a thick uterosacral ligament. Can you see it nicely?
Yeah. Yes.
And we have attached, release the ureter. Now we can fix the ovaries. First thing is we'll release it completely. Just hold it nicely, sir. 1 minute. Hold it nicely here. Hold it without pressing. Yes. Yeah. So you can see the utero-ovarian ligament and the uterosacral ligament have come together here.
Yeah.
Because of it affects the vessels and the ligaments. So and makes them come close to each other. You can see the hardening here. It's not a supple peritoneum.
Yeah. Everything is puckered there.
So as you say, this was a good case for demonstration of the principles. So what
in one case you can demonstrate multiple cases.
Yeah. So seeing the ureter, I have lifted the ovary.
Yes, sir.
That was the principle. Ureter is where? Ureter is there. Okay. So I will just take this. Yeah, 1 minute. Leave. Can you leave the ovary, sir? Okay. So we have the ovary which is lifted. I will lift it nicely more. Yeah. 1 minute, sir. Yeah, hold like this, sir. Yeah. 1 minute. So this is the ureter here going. This is the ureter. Yeah. So if we are doing even benign or onco cases or endo cases and want to do complex surgeries, it is important to learn the ureterolysis.
Yes.
So ureterolysis.
That is the basic principal process.
Yeah. So that will make your surgery very safe and.
Sir, any tips to prevent ureteric thermal spread?
Yeah, the harmonic is quite safe close to the ureter that way.
Yes, sir.
I don't have lot of use. I am not very comfortable to use the sharer very close to the ureter as I use harmonic.
The area you are operating at that place. So everybody will come up to that space, but this is a very difficult step.
So here I was telling you about the lateral parameter. Can you see the lateral parameter? This is a uterine vessel.
Yeah.
Okay.
Yeah.
So one thing understand, we want to release the ovary, we have to travel above the vessel. Okay.
Yeah, that is very important.
If you are above the vessel, you will not injure the ureter. And moreover, whenever you have a lateral disease and you are not getting some large nodule sitting on this area, you dissect the iliac tree positively. That will help you to
At this point, do you think dissecting for the uterine artery is bit helpful for the ureteric dissection?
It is helpful if it is really bad.
Yeah.
Hello. Sir, in which cases would you prefer ureteric catheterization?
Where there is a ureteric involvement and dilatation of the ureter, there we are catheterizing nowadays. Plus use of ICG, we are having the cameras with ICG nowadays, so we can put the 2-0-ethylon. You can put ICG around 2.5 ml on each side in the biureteric catheter, wait for around 5 to 10 minutes, and then you can keep on seeing the ureter in ICG mode.
That requires different camera system and all.
Nowadays new cameras all will come with ICG now.
Yeah.
All the newer cameras of Striker, the Escalab, the Stores, they are having ICG. I think, I don't know whether this particular camera has.
Stores has?
Stores has, Escalab has a beautiful needle holder, open needle holder. So I'll hitch the ovaries now. Yeah, show me inside. So you can use a T-lift or you can use a 2-0-ethylon to hitch the ovaries. Yeah, hold this. Needle holder. Yeah. Sorry, Aditya. So I've been assisted by Dr. Aditya, Aman, Jashish. What is your name, sir? Avinash. अजून एक ग्लास पर दे वरून दाखव.
So here you want to fix the ovaries.
I'll fix the ovaries, yeah. Because ovaries cyst, I'll see it last. And meanwhile, if we are starting any case there, we can always transfer in between so that we finish the list today.
Yeah.
So that cystectomy part you are going to do later on. First posterior dissection.
So approach is like this. Whenever I am operating in conference, I try to do the posterior show the posterior part first, because that is many people are interested in that. And cystectomy last. But when I am doing a case in my, the cystectomy is slightly boring part of the surgery, so I do it first, okay, and then hitch the ovaries. Ek minute, tu light लावा वरचा. 1 minute, सोडतो. ये ले. Yeah. So this is ovarian suspension.
It is excellent method to expose the posterior part by itching the ovary. because T-lip devices sometimes may not be available at periphery, and secondly, it is too costly also.
Yeah, that is true.
Yes, sir. Sir,
This is
see the
very-
exposure excellently, sir, did it within 1 to 2 minutes only. That,
Very good method, very simple method and cost effective method to hinge the ovary.
Yeah. So it is always better to hitch the both. Yeah.
yes, sir. Your assistant will have the free hands to manipulate other things.
Yeah, again, this is 4-port assisting technique what we are using. Always there are 4 ports, 2 on each side.
Can you show the port positions also to the audience?
External camera, please. Show this one port placements.
Yeah, can you show
You
the
said 4 ports, no?
So
Yeah.
2 on left side, 2 on right side.
Yeah.
It like that.
So this is a supraumbilical port and these 2 on the left side and 2 on the right side here.
Yeah.
So we have a camera person who is different.
What ease he will have by putting 4 ports instead of 3 ports?
The 2 ports which the assistant is using, one will be for the constant retraction, other will be for the active help and counter traction and counter traction.
Okay, yeah. That's why all your trainees used to get good exposure, you know.
Yeah, they have to help.
Yeah.
The light. Because are we starting anything on that OT also?
But in that OT, sir, we have taken one more polypectomy.
Arey wow, okay.
And once you start dissecting that, this one, then we'll shift to another OT.
छोड़ेगा क्या? छोड़ेगा नहीं तो पड़ेगा ना. Okay.
Are sir, are you ready with the case?
Sometimes while doing port closing, the same thing will happen and some bleeding will start at port site.
Yeah.
Just while doing your procedure, just elaborate on that also. How will you take care of that?
Like suppose this bleeding stop, you can start to do a small cautery, but it will stop on its own.
Yeah.
Yeah, clean करने.
So best thing is don't do anything.
Yeah, wait for some time,
Yeah.
or you can cauterize it from inner side. Stitch side bleed generally always stop. As in myomectomy, when the stitch side starts bleeding.
Sometimes we have seen that you hitch bowels also.
Suction.
So whenever you have a problem, just wait, don't do anything. That is the best solution.
Yeah. Time is the solution.
Yeah.
Yeah, so bipolar. Yeah. So now we have done the same thing on both the sides. Now
you have exposed the POD very nicely.
Yeah. So now what happens is I will be taking the transverse cut now. Can you see the apex of this was the first cut? IP to uterovarian.
Yeah.
IP to uterovarian.
On either side.
Seeing the ureter. Okay.
Yeah.
Then my second cut starts from the apex of the first cut, apex of the disease. So I want to do the peritoneectomy till here. So I will start from here.
Okay.
The second cut will start from here. Along the pararectal space, it will cross over the uterosacral till the bowel fat. Can you see? This is uterosacral, this is the bowel fat, this is bowel. Can you see the bowel?
Yeah.
Bowel fat, uterosacral. So my incision.
This is your standard cut or depending upon pathology?
Generally, this is a standard way we are defreezing the pelvis.
Yes. Thank you, sir.
So it becomes easy to. Can you stretch?
So sometimes here always there is confusion which one is bowel and how to identify that fat from that bowel. So any highlights on that?
No, you can very well identify most of the times with good cameras.
Yeah.
I
So
think,
the point is need good vision for us.
Yeah. Basically in grade 4 endometriosis, when puckering, multiple puckerings are there, then that problem will arise.
yeah, so I am traveling. Your direction traction is totally wrong, sir. ऐसे नहीं करो आप थोड़ा इसको हाँ yeah this is getting loose 1 minute you hold this yeah can you see the fat now fat and bowel can you identify
Yeah.
yes
You can see it clearly. Yes.
so I am traveling with this cut so I am localizing the disease
Yeah, here your 4-port position
we can understand better how it is useful.
Yeah, so most of the surgery there are 4 ports.
Yeah.
So I have reached the bowel fat. Can you see the bowel fat now nicely?
Yes, sir.
So this is bowel, this is bowel fat.
Yeah.
Okay, so I will localize first like this, second here, this way. In this, I will leave that, sir. Good now. In this, I will demonstrate then the incision. Then again, our incision starts pararectally medial to the uterosacral. Can you see the uterosacral here?
Yes, sir.
So medial to the uterosacral, you travel by the lateral side of the fat.
Yes, medial to uterosacral is the keyword here.
Medial to the uterosacral, lateral to the fat. See here.
Yes, sir.
Okay, very simple it is.
Yes.
Hold that.
Sir, is there any role of any important structure will come across at that place?
In superficial, no, but then hypogastric nerve has to be traced down if you are puckering. I will show that hypogastric nerve also.
Yes. Something has come out.
Can you see?
Yes, sir.
This is hypogastric nerve.
Yeah.
Okay, you travel above the plane.
Yes. Very nicely you demonstrated it.
Now we will see again once we are doing that. Yeah, go inside. Yeah, hold this. Hold it nicely. So I am going medial till the parietal space till I reach the rectovaginal space.
Yeah.
Alright. Okay. Suction.
Any vascular complex will encounter in that area?
If you go deep in the parietal space, maybe a middle rectal artery can be there.
Yeah, that is again very important structure.
Bipolar, give me bipolar. You can have a bloodless vision as far as possible.
We have a good vision here, no doubt, sir.
Yeah. Can you show me your? There is a small bleeding. As we know ureter where it is, so we can. Yeah. So we do that. Can we give me some other grasper? Yeah. You're up. Hold this. Yeah. Perfect. Show me. Your. Yeah. Hold this. Lift up now. Yeah. So this is the reason of our pain. I am not able to see the bowel belly. Show me here. From behind. Yeah. Can we see the bowel belly? This is the bowel belly. Okay?
Yeah.
And this is all the encysted collection because of the inflammatory nature of the disease.
These are the cystic places, I think, over the bowel.
Yeah. We don't have any bowel here for sure. So this is just a peritoneum. We can cut it. Yeah, we can get
Your movements are so fast with harmonics, sir. We are thinking is we are getting fill up your operating 2x speed.
Yes, because this harmonic is a good instrument to use.
Yes, sir.
It gives us a good speed in surgery. And you hold it properly, then pull, then only it will work. Yeah, hold properly. No, you are holding it. Yes, perfect. So I am going. In the
Any role of rectal dilator or rectal probe here?
Rectal probe in this particular case, no, but maybe 1 minute, sir. Leave. Maybe in patient, you can use rectal probe in 2 places. One is if you are not able to identify the rectum.
Yeah.
Little bleed ho jayega. Or you can use to identify the vagina. Okay? To fornix, to whenever there is a rectovaginal dissection. 1 minute. Just
what second thing you tell, sir?
To identify the vagina when you are doing the rectovaginal dissection.
Okay.
Hold this.
Yeah.
Don't pull it too much. ट्रैक्शन दिखने तक ही पुल करो.
Any role of hitching the rectum also?
Maybe because it is required to getting moved from one side to other, maybe hitching may not work. But yes, sacrocolpopexy it works.
Okay.
When you have to have it fixed. Again, this is a transverse incision in the parectal space to localize the disease.
Very good dissection, and the field is too clear, and traction everybody can appreciate it.
Yeah.
So everybody is busy in watching, so at least everybody should appreciate sir with claps so that he can hear there.
Thank you, sir. Thank you so much.
Yeah, everybody is busy in watching, sir.
Yeah. So this was the other incision. Then again I hold this, hold here. See, you can see small implants over it. Again I go pararectally. Can you see the fat? Medial to the uterosacral, lateral to the fat, lateral to the bowel. You want to start doing deep endo cases, for few things are important. You learn how to diagnose it, learn to read MRI. The imaging is very important. Learn to do your own sonographies.
Yeah.
Then be a good, learn to understand the requirement of the patients.
Yeah,
Very well.
For that one has to operate in mass the endometriosis.
Yeah, but then it is a need because so many patients we get which are not either not operated properly or they are the disease is most of the time it is recurrence. It is residual then recurrence. Yeah,
In those cases, when your planes are not good, what you will do? The same principles?
Yeah. He is getting difficulty because you are not shorter in height. You are there is a hand there, no? So you can always. So can we make out the bowel here, bowel fat?
Yes, sir. Yes, sir. Very nicely we can see.
Yeah, vision, no? I think होऊन जाईल एवढं पर्यटन तुम्ही करून नाही डन ओव्हरीचं या सिस्ट काढतो थोडस इथं याचा त्या हाताच्या मागे जातो का तू तू थोडं द्यायचं आराम से पकड़ेगा तो हो जाएगा पकड़ से ओके या so one hand is going in constant traction, one hand is going in. Again, come behind your, yeah. Hold here.
So here 6 hands are working. The ovaries are arranged in 4 ports.
Yeah, you can say that.
Yeah.
So there is a thick nodule here. Can you see the nodule now?
Yes, sir.
So there is never like only 3 centimeter cyst, a simple case of endometriosis. You have to assess properly.
You will go lateral or medial to the nodule?
Bowel is, I am just trying to identify. So this is a bowel belly. Can you see the bowel belly?
Yes, sir.
So we will go medial because it will go in the uterosacral.
Yes.
If we use traction on the nodule. थोडंसं तुम्ही हे घेता का हे bowel wall आहे का बघा पहिले.
And sometimes if we can't make out the bowel, we can go laterally and shave it off, no?
We can do that, yes. Here the role of rectal probe may be there, yes. I'm not seeing anything. This is the bowel. Can you see?
Yeah.
Bowel fat?
Yes. Yeah. How deep you will go, sir?
If there is no disease deep, we don't have to go deep.
Okay.
Go near, na? You're not showing, doctor.
Till you find the good clear place.
Yeah.
Hello.
So
Sir, how is your experience with the medical therapy? Like previously, if the patient has been given Dynogest or Elagolix?
Yeah, long-term medical therapy makes it very worse to operate, especially Dynogested patients. So whenever we have a deep endo patients, we assess the patients by imaging. If there is deep endo, we advise them. थोड्या वेळ लागेल वाटतं मला वाटतं आणि हात पण आहे ना त्याला, he is not able to do it. हा, no problem. हे पकडा. So keeping the patient on long-term medical treatment with the deep endometriosis, I think it is not advisable much. You operate them, use the medical treatment for not letting the disease come back.
Okay, okay.
This is again double-sided sword. A physician will prescribe.
Yeah.
He will postpone it, particularly in infertility cases.
Yeah.
And then it will become a nightmare for the surgeon.
Yeah, again we have to have a close association with our fertility doctors also.
Yeah.
So it has to work as a team. So you should discuss whenever there is a patient with low ovarian reserve, endometriomas, I don't take her for directly surgery. I send her to our IVF colleagues. Let them see, let them assess if they can take out eggs, discuss the possibility of her fertility, assess fertility compromise. And then
Very good point you have raised here is a good collaboration or good discussion and understanding between the infertility specialist and the laparoscopic surgeon, so that at every surgery the reserve is not that much disturbed, because most of the cases with only scissors we can do the cystectomy and all.
Yeah.
But again, it is like a controversy between the infertility specialist and the laparoscopic surgeon.
Yeah, rather than having controversy, you can have a collaboration.
And yeah, collaboration, or the person has to be an endoscopic surgeon and IVF consultant to the one man.
Yeah. You can see whenever there is a confusion, you can split the nodule and take it. This one, yeah.
Do we need to worry for nerve here?
Nerve is down here.
Okay, means
Can we?
because this case is not for bowel dissection, anastomosis or discoid or shaving. So
Yeah.
we generally go deeper in those cases, but just for the sake of peritonectomy, we
We need not go and, if you want, you can go and dissect the nerve and see, but then no need. Unless it is going, you don't have to dissect the nerves.
okay.
Yeah, can we show this? Yeah,
In this surgery, usually we used to remain a bit superficially, so nerve injury chances are lesser. What do you think?
Yeah, I didn't get the question.
In this surgery, the chances of nerve injuries are lesser because we are dealing a peritoneal disease. So
yeah, less chances. Yes.
Yeah, less
Surely.
chances.
So you can see the ureter going down. We can make a cut on the.
Yeah, it's a crucial point to dissect at that place where the ureter is.
मुझे grasper दो दूसरा. My grasper is sleeping. Yeah.
Yeah, this point every laparoscopic surgeon should watch very carefully this point.
You can split the nodule. Can you see the split on the nodule? Yeah. Okay.
Yeah.
I split the nodule on the uterosacral, on the iliac tree.
Yes, yes.
So this will come along with this. And this can be done, taken out, shaved over a, ऐसे पकड़ ले ऊपर. This can be shaved off over the uterine vessel. Yeah.
That chunk, instead of taking in toto, you divided it.
Divided, yes.
Just to simplify the step and
Yeah,
get the ureter out.
Yes, you have to divide it.
Yeah, that is very skillful job there.
And here there is a chance that you divide the uterine artery because it's just over the uterine artery.
Yes, sir.
I'm shaving over the uterine artery. Can you see the uterine artery getting released?
Love to watch you using the harmonic because everybody used you scissor here.
No, scissor will give you a lot of bleeding.
Yeah, but everybody want to be on safer side to avoid the current.
No, scissor, you can actually use the hormonal and bowel scissors.
Harmonic looks good in your hand, sir.
Yeah, I like to use it, sir. See now, this is the uterine artery, this is supple tissue. Can you see? This is the uterine going.
If uterine vessel gets injured over here, what precautions we should take?
we can just ligate it, sir. Most of the time, you may have a small uterine vein along superficial uterine vein, which goes along with the artery.
Yep.
Here now we are very close.
Mhm.
Then I go push. There is a small nodule
At these places also you will prefer sharp dissection.
with harmonic. Yes. Unless a nodule is totally sitting on the ureter, the
Yeah.
ureter is far.
Yeah.
Okay.
How you prevent the blood supply of ureter? Sir?
Don't dissect on the. Don't dissect on the. There is a sheath on the ureter. You maintain that.
Tips for that, starting from lateral to medial, medial to lateral, anything.
That doesn't actually work that way, but you don't dissect on the sheath. So I don't dissect on the
Sheath
ureter.
has to be maintained there.
Yeah,
so
then
the blood supply will
and then you can, if you have ICG, you can see with ICG if there is a vascularity. For that we give IV ICG around 2 ml, 5 ml diluted, and then see in around 1 minute. We see the bowel vascularity, we see the ureteric vascularity, and then you can see the intensity mapping also. The intensity mapping will tell us the percentage of vascularity, and then you decide whether to stent or no.
Okay. How frequently will do it, sir?
We are doing it regularly
Yeah.
because of the complexity of cases in our center.
Yeah.
We have cameras which can give you ICG, but it is very useful. There are a lot of uses, like ICG can be used in the recent conference we saw used for adenomyomectomy because you don't want to enter the cavity. You put the dye inside the cavity. So whenever you are near the opening of cavity, you can make out that you are near.
That's good.
Then ICG can be used for painting the vagina. Whenever endometriosis case, you are not able to see the rectum and the vagina.
Yeah.
And to delineate the vagina, you can use ICG. So many cases you can use it actually. So these are the now.
harmonic. Your speed is too much, sir.
Yeah, thank you so much. Only limitation cost is a limitation which makes us not use this instrument. But nowadays many companies have come out with very different instruments.
And we can notice the disease is completely in your hand right now, and you are taking.
Yeah, I split it here there because this side was more involved. I managed the other side.
So this is the advantage of splitting the nodule.
And you can always remove it in parts. You no need to have the butterfly with all wings intact. Okay?
Yes.
I can remove this and go. I have to still dissect the rectum. I was not getting the plane there. Yeah.
You excise the nodule completely.
So this parametrial disease is gone.
Completely gone.
Nicely. You can see the uterine vessel.
Yes, sir. Yes.
This is nothing. This is soft ureter going. You don't have to dissect more than this, the ureter.
Yes.
So at that place you won't release the ureter much?
In the way it's done, no? We have already, ureter is dissected till the time it is away from the disease.
Okay. In future chances of puckering are there?
Generally the compression, whatever the ureter gets compressed between the lateral and the posterior parameter.
Yeah.
So generally most of the times, maybe 90% of the times, disease which is involving the bladder, ureteric ostia and the bladder at that level, anterior adenomyomas, that is the only place where you require where the disease is here in this area. So that is the area where you really require to dissect the ureter going inside the bladder.
Okay.
Because that is not very, then you require a reimplantation also for that.
Yes, sir. Thank you, sir.
Here, now this is a localized, yeah, can you hold this, doctor? Hold this, pull nicely, yeah. Huh? This part it is less. Yeah, ureter इधर है, huh? Pull out. Yeah. If you are not seeing the ureter, you slightly see it from up. Yeah, hold this here. Hold it down. You can see the ureter. I can't see the ureter here. Yeah, hold it here. Yeah. This is the ear. Can you see the ureter now? This one. Yeah.
If you hold the whole bulk of the tissue, it will give a peristalsis, no? That is the ureter, I guess.
This one, no?
Yeah, just give it a press. Then
Hold
you
this.
will see
Yeah.
some peristalsis.
Yeah.
Yeah, now
Press
we
it like
appreciate
that
it.
on both sides.
Yeah. Okay. Come here. Come here. Come here. Come behind. Come behind. Come behind. Yeah. Yes.
So you will go from lateral to medial over the ureter.
Yeah. You can see the peritoneum is not very normal here.
Yeah.
This is the ureter properly now, you can see. Hold this.
So this is good case for the peritonectomy because it is disease thing.
Yeah.
Poremic and they used to bleed a lot.
Yeah. We can go and open this. There is some inflammation. I don't know whether she has taken any medical treatment.
So which cases you will prefer peritonectomy?
Whenever there is a P compartment disease.
Okay.
Yeah, hold that. वो छोड़ दे ये ले ले ये पकड़ा है pull out completely. Yes. No, don't, the direction of pull has to be better. Yeah. No, don't sleep, make it sleep. Pick it up. No, sir. Pull it like this. Yes. Pull out. Near. Go near. Hold near. Yeah. See, we can see the ureter going there, and then we are. Hold this. So you should understand the pelvic spaces as gynecologist for most of the cases where you may need the understanding of pelvic spaces.
Yes, sir.
In pelvic floor surgeries. So most important spaces are pararectal and paravesical spaces.
Yeah.
Yeah. Here you will get the hypogastric now again. Yeah.
Initially it was messy, but now we can have a clear vision, clear planes.
Yeah.
We are enjoying good dissection.
Yeah, can you hold there? You're down. Yeah.
So we have removed the peritoneum of this pelvic area. So what will happen post-operatively?
See, yeah, many times patient ask, will I develop adhesions? So we have to tell the patient, adhesions will happen because...
We are ready with the diagnostic histrolab case.
Yeah, we can shift there, sir. Then we will come back again. Till that, see, you can see the hypogastric now nicely.
Yes, sir.
There we will spare and then do the peritoneum. We can go to the other OT. Till that time, I will just finish the peritoneectomy.
The question was, sir, what will happen afterwards once you remove the peritoneum from the pelvic area?
Relation is good. Whereas this one has a parafimbrial cyst and a paratubal cyst as well. And that's why.
Hello, we can't hear, sir.
I think the audio is getting shifted on the other side.
Hello.
Can you hear Dr. Neha?
Can you hear me? Hello.
We are not able to hear.
Can you hear?
Yes, you are obviously we can hear you, madam.
Okay, this is a case of secondary infertility. She is para on D1. So we are doing a operative hysterolaparoscopy where we will just see some minor factors which are there. So whenever we do a operative hysterolaparoscopy, we always check the tubes. We check
Please, could you shift the camera to the other OT? We don't have a video in the... Yes. Yeah, now we have, yeah.
Okay.
Yes, madam, go ahead.
So this is a case of operative hysterolap. So whenever we are doing an operative hysterolap, we generally will go and have an overview of the abdomen. We see after entry, if there is any findings in the upper abdomen, any adhesions, so see the liver bed. And then the pelvis. In the pelvis, we will see the tube, ovary, we see the peritoneum, the ovarian fossa, then the uterosacrals if there is any, to find out if there is any endometriotic deposits or patches, and then again the other tube and other ovary. So in this here in the right side we can see 2 parafemoral cysts as well as 1 paratubal cyst. Then after seeing this, we will always check for the tube-ovarian relation. That means, is the tube reaching to 2/3 portion of the ovary or not? So here you can see that the tube-ovarian relation is good, only that the tube may not be functioning as well because of these cysts present. So they should be removed. And then the same thing on the other side.
In cases of infertility, while doing the diagnostic scopy, what other things the external appearance of the ovary will look, or everyone should look about?
So here you can see that there is a corpus luteum cyst in this side. So that means she is ovulating. At least she is ovulated last month. Then
yeah, in generally the ovary is shiny, milky white, shiny color, smooth surface. So sometimes the wrinkles are there. So what other things you'd suggest that we should look while doing this laparoscopy as a diagnostic procedure for the infertility?
So it's reaching 2/3 here also. Yeah. Sorry, I missed the question. I think you answered that also. So here we will do hysteroscopy after this, and then come back, check the tubes, and remove these cysts.
Actually, that has to
I didn't hear only the question.
Neha, why we didn't go ahead with hysteroscopy first in this? Why we thought of starting with laparoscopy and then go for hysteroscopy?
So always when we are doing a operative hysterolaparoscopy, always laparoscopy first to see the external appearance of the uterus if it's adhered somewhere, and then only hysteroscopy.
Okay. Can we have a judgment of one reserve on laparoscopy while doing for the infertility cases as a diagnostic procedure?
Sorry, I didn't understand the question.
What is it? With appearance of the ovary on laparoscopy, can we judge to some extent ovarian reserve by any means?
Yes.
Of course. The size of the ovaries will tell you whether they are small ovaries or no. If there is any, if the size is really small, then obviously the patient is going to have poor reserve.
So whenever we see the ovaries during laparoscopy as a diagnostic procedure for the infertility,
yes,
first we have to look for the size of the ovary,
yes,
how the size is, how the surface is, how the color is.
The ovarian fossa is, if there is
Like if it is milky white, shiny, it will yield a good outcome. But if it is muddy, white, dirty, or has a wrinkles on the surface, that itself indicates a poor result on the laparoscopy only.
Yes.
We'll be going ahead and doing hysteroscopy now. So the same method, vaginoscopic approach, wherein we go see the posterior fornix. Once we see the posterior fornix, we come back and identify the external cervical ostia. You can follow the mucus. The mucus gives us an idea where is the...
As a case of secondary infertility, can you elaborate the primary and secondary folds and the mucosa, cervical mucosa?
So this is the external cervical os.
Yeah.
Then the endocervical canal, which has these normal crypts. These are the normal crypts. This is how the cervix should appear. We follow the mucus. The mucus will lead us to the folds will converge together to the internal os or internal cervical os. So you follow the mucus, and most of the time the mucus will help us. Also, the scope can be rotated from 3 o'clock to 9 o'clock. You can, yeah, that's the negotiation method of entering the uterus. So here we are. this lady has scanty menses, so we may experience either some internal stenosis. Chandra, wo kahte there? Okay, that's not good. So this is one ostia. Yes, we wait here at the, first we will wait at the os and then evaluate the uterus. So the uterus in this case, the uterine cavity appears of normal size and there is a polyp which is arising from the left lateral wall. So you can see that it has a broad base and behind that there is the ostia. So once we will remove the polyp, we can then go and check for the tubes.
So here how we can look for the endometrium? Is it a healthy endometrium or
yes,
not?
Yeah, we can see for the, one thing is the glands, how is the gland population.
Yeah.
Then we see for the vascularity, and so we can make a furrow
in this case, is it look like a endometritis?
No, in endometritis there will be some micropolyps, there will be strawberry patches which will be seen, stromal edema will be there. However, in this case this endometrium is very healthy. This is a normal vascular pattern.
Reduce the pressure. 1 minute. Go to the front. Stop the pressure. Go to the
So usually in cases of endometriosis, hysteroscopy, we used to see the pink color endometrium. That's why
cavity is rotated.
appears as a hypervascular. It's not hyper. You see all the spiral. Okay.
No. Caesar है? Caesar. So we will, to evaluate the endometrium, we'll make a furrow in the endometrium, so that these are all grasper. So, and then go and then go in and see the glands. This doesn't focus. Yeah. So the.
Can we shift the audio to the other OT? Sir is at a critical stage.
Hello?
Yes, sir.
Yes. Yeah, so I'll just quickly tell you the use of the vaginal mound. Okay, can you see this? A valsalum on the gospice hand.
So left uterosacral we have completed.
Yeah,
we are on the right side.
Yeah, completed. You see the picture, the ureter, nerve, and
so something is there in the fornix, I see.
Yeah, this I see whenever there is a toric disease and you want to see whether it's getting completely. You can see, put a valsalum on the sponge on a valsalum, and use it to remove the disease. So this is the last part of the disease which is getting removed. Okay.
Just elaborate on you have saved up the disease from the rectum.
Yeah.
And the audio was not there with you.
So we have to still see the disease in the rectum. We are not, the rectal belly I am not able to identify very clearly, but this part we saw it is away from the rectum. I will just debulk it first and then go and see the rectum.
Yeah, because sometimes the audience missed the bits. So I asked the question to you.
That was inclusion cyst, what even I also thought.
There are the inclusion cysts. Here multiple inclusion.
So what care you will take while saving up this rectum?
The care means you have to positively identify the wall.
But at that disease place it is very difficult.
Put a rectal probe here.
In the vagina, not a probe. No, I have not. It can help, yes. So This is the vagina. Vagina is clear.
Just we want to learn from you that how we can save the top, because while saving like you, we may save the bowel.
Yeah.
Okay. So just tell us the limits till how deep we can go.
Okay. So to identify the rectum, first thing did you identify the fat here?
Yes, sir.
Go identify the fat, go on and going through the fat, and एक आरो गॉस दे बोला.
Gauze there.
I'll just put a gauze piece and put inside.
Yes, sir. Yes, sir.
Till the time you want to just finish the hysteroscopy part, will come again. I'll just make ready things ready. Okay.
You can explain bowel savings also.
Okay, I'll show you. Suction.
फायबर आहेत ना
म्हणजे?
कापायचे नाही आपल्याला वाटते ते
निरोड.
कट करत गेलो ना प्रॉब्लेम आहे त्याने मिडल रेक्टल आर्टरी तिथेच येते कधी कधी आणि
Yeah,
कट झाली ना
so to-
वेळ होते. बोटं
Hello?
काढायचं.
Hello. तिकडे चालू आहे ना?
Can hear on this side.
Hello.
Hello.
अच्छे से vision दे. pass
Hello.
में दे.
Yeah, we can hear you.
Okay, on the endometrial polyp side.
The polyp.
Okay.
We're just getting
Dr.
the
Neha,
polyp out.
when the polyp is little bigger and our judgment is little wrong, has gone little wrong, and we haven't sliced the polyp, then and we are finding it difficult to bring it out. So what should we do then in that case?
Hi Anil, we are with you.
Okay. So I was asking Dr. Neha if we have not sliced the polyp in the beginning, and if we are finding it difficult to bring it out. So then in those cases, for a little larger polyp, what should we do like? Because it keeps on slipping again and again.
Yeah, it will keep on rotating, moving inside only.
Yeah, hello, Dr. Anil.
Yeah.
Alpana here. I would like to make a suggestion. Maybe we switch off the water
Okay.
and then it might come out on its, I mean, we can pull it out.
नहीं फैट किधर गया?
So that
Hold it well. Then we at the internal os and then rotate the instrument slowly so that we can negotiate the internal os, and then you can see that how it is coming out.
Do you think it will come easily with 1%?
No, very difficult sometimes. See, the polyp is here out.
Outer picture. Wait. नहीं.
Yeah. एक minute, can you leave that? So then we have to still clear the pedicle because otherwise the polyp can come back.
Space दिखना है ना?
So the क्या करना है?
Hello. Am I audible? So when the polyp is stuck, in the uterine gate, it's like a after coming head in the breech delivery. Okay. So what happens is that impatient throw or something like that will not help. Now the polyp is definitely not going to come. This patient, it's not coming not because of the disparity between the size of the ovary, size of the polyp and the os, but it is not coming out because of the acute anteversion of the uterus. Okay, show the os, come out. See, the os is so big. So what you should do is prepare the os, remove all the endometrium from there, remove everything from there, prepare the internal os properly. Okay, remove all the debris, all your negotiation difficulty was there. So you remove that and then, no problem. And then you try to remove the polyp slowly by rotational method. Just hold it one place and go slowly on rotation. Just how the head delivery happens by rotation.
Wait, I'm going to still remove this also. I know that.
Can we shift to the other OT? Sir is at the last step, I think.
Hello?
Hello, hi sir.
Clean the camera. Yeah. So the idea is to identify the fat lateral to the bowel.
Yeah, from the auditorium, sir, requires one appreciation because we have seen that how sir has saved up the rectal peritoneum there.
So
See the plane?
Can you see the fat here?
Yeah, yeah.
So you just go lateral to the fat. This is peritoneum. Sometimes, okay. This is the peritoneum.
Too good, sir. Too good.
This is the peritoneum.
This only we are asking, sir, how deep we should go. And always the answer lies, it's an experience.
No, you have an idea.
Yeah.
You go lateral to the fat on this side, you go lateral to the fat on this side, and then go to the rectum space. So bilateral medial parectal spaces medial to the uterosacral on both the sides.
Yeah.
Then last thing is going to the dropping the rectum down. Rectum down, you take, if you have 100% of the disease, you work on 70-30. 30% on the rectum, 70% on the torus.
Okay.
Huh? रेक्टम का काय तिला नाहीये तिथं डिसीज काही खास कुठे
So at just below the attachment of the uterosacral, whatever the bowels are there, you want to free it?
Here you feel?
Yeah.
We can free it to understand.
Yes.
There is a nodule there. There is a nodule.
That is again a nodule?
Yeah. Can you see the fat of the bowel?
One can notice assistant is holding ureter in his hand. So that here also we can save the ureter.
So for the nodule, approach is from lateral or medial. Is it a standardized or depending upon the assessment?
From the lateral, both lateral and side, then the medial one.
Okay, sir.
Yeah. So here, yeah, hold this. The probe can help you. Hold this. This is a okay. But can you put a probe in the yeah, 1 minute. सीधा कर हाँ चला नाही आपलं स्पॉन्जिडो टाक ना स्पॉन्जिडो याच्यात टाक फॉनिक्स मध्ये camera is not hold this up. दो मिनटों के पेरिटोनियम निकालने दे उसके ऊपर का नहीं समझ रहा है ना समझेगा ना बहुत इजी हो जाएगा go inside. And can we are unnecessary rectum? Because we are not doing vision, we are getting worried. So,
very well appreciated and a beautiful plane we can see.
Yeah, so this is the rectum down. It's not. Yeah. Hold this part, no? Hold this part. So this is all.
Above the rectum, this part of nodule or this is peritoneum?
This is a part of nodule actually.
Yes.
Hold this. There is a part of the thickened peritoneum which is come behind. You are going very near.
So you will take out all this.
Better, no? Because she is. Okay, so this is a. Can you see the bowel wall nicely now?
Beautiful, sir. Beautiful dissection, sir.
Excellent. And this was basically parametral and thank you so much. Yes. Then we are very sure. So we have to see properly. So that's the reason.
So can you just mark out the nerves position here, sir?
Nerves are seen very well here. See.
Okay, so they are very high up. Yeah.
This is now. This is a superior hypogastric plexus at the bifurcation on the left side of promontory.
Yes.
Left and right hypogastric nerve will go. There is a uterine artery. There is a ureter. Then there will be a deep uterine vein here. Below the deep uterine vein, they will form the plexus.
Okay, sir.
So is that part of right uterosacral, sir?
This one? Yes.
That he may hold?
Yes, that is. And there is a small shaving on the rectum.
Excellent, sir.
Yeah, it's done. नहीं स्पॉन्ज नहीं डालना है दिखा दे ये पूरा पेरिटोनियम ही है देखोगे ना इधर वॉल है वॉल कैन यू फॉलो द वॉल हियर यू शो मी हियर जस्ट होल्ड दिस कम behind yeah
here the bowel and that disease portion just make out the difference, sir. How we can make out that?
We have to make good traction.
Yeah.
And then you can see the bowel here. You see the bowel here?
Yes, sir.
And this is the peritoneum.
Yeah.
Mavali, you know? Yeah. So this is a plaque on the bowel. Hold this. Yeah, come behind. Come here, come here, come here. Yes, perfect. Okay. So I'll just remove this plaque. And now most of the things are done. I'll just do the ovary also. Ovarian cyst.
So below those plaques, the fatty tissue is the demarcation of what?
Yeah, 1 minute. You can see You can see below this plaque. You can see the rectal wall. Can you see the rectal wall?
Yeah, yeah,
Yes,
yeah,
yes.
yeah.
This is the
Yes,
rectum.
sir. Beautiful.
These are all clear now. I have to just take out this plaque, nothing else.
Yeah.
Hold it. Yeah, hold this side.
So do you use any rectal probe?
I didn't use rectal probe, but you can. It's a good idea to use a rectal probe if you are not able to identify.
Vaman sir, there is question from audience that how we have prepared bowel for that. So again sir, we have one rule of 4. Sir, we only give 4 Dulcolax at 4 p.m. prior day of surgery. And when you are operating your case next morning, 6 to 10 a.m. in the morning, so we give only, even we had thought of this one giving peg leg. Unfortunately, I didn't get peg leg here in Miraj. So we gave just 4 Dulcolax at 4 p.m. yesterday. That's it.
Cleaning kar the camera.
Beautiful bowel preparation, but
Rule of 4 is good.
And we must thank to anesthetists. They have given wonderful anesthesia. So bowels are literally falling down. Thank you once again.
True. You should appreciate the anesthetists, otherwise they will make you appreciate. And you will tell them patient is moving, sir.
Yeah, but it is always a teamwork.
Yeah, it is below the rectum or what, sir?
No. Yeah, this is a parietal.
Parietal
Rectum, this is a fat.
Yeah.
And this is again.
When you pull it up, the rectal will twist.
The rectum is here.
Yeah.
Rectum is here. We can put
Now they are holding. Yes.
Assistant is holding that rectum.
So what look at the
So one upper grasper always keeps on holding the axis. So this was again the plaque. Hold this.
The lower limit of the plaque.
Yeah. Hold this. इधर पकड़ेगा तो. We already taken the uterosacral. This is just a बचा हुआ part.
Is there any need to think of ureter at that place?
No, if you are medial to the uterosacral, no. We are medial to the uterosacral, no?
Yeah.
So nothing. Can we clean the harmonic? Yeah. So there are centers which will try to do 10 endometrial surgery in 1 day. But if you want to do it completely, even a simple case like this will take time.
Yes, sir.
Sir, regarding some MRI and all that diagnosis for the endometriosis.
Yeah.
So we have heard that many people in Mumbai, they used to put vaginal gel.
Yeah.
They pack vagina completely with the gel and they post for the MRI. Sir, any views on that?
Yeah, so we had a lot of discussion on this in our endometriosis conference this time.
Yes, sir.
So the radiology team, most of the radiology team, they would not prefer.
Yes, sir. Even here also we tried with
gel
some
in the
patients.
vagina,
Yeah.
but maybe the rectal gel
Yeah, rectal gel. Yeah.
may be useful.
So that very cumbersome for vagina, for vaginal this one, and patient won't means the maintain that complete gel inside the vagina. Vaman sir, any highlight on that? How you prepare that MRI for such a patient?
I didn't understand completely. What is the logic of using gel while doing a MRI?
I have heard it for the first time. Pardon me.
To delineate the vagina, rectum, see the nodules properly.
Okay, okay.
Hello, Dr. Vikas Alpana
Yes,
here.
ma'am.
Can I make a point?
Yes, ma'am. Yes, ma'am.
This gel sonography is very good. You fill the vagina with gel and then you can pick up endometriosis very well. Dr. Mala Sibbal in Bangalore does a fantastic job with gel sonography, even vaginal. So rather than MRI, you can pick up with gel vaginal sonography. You fill the full vagina with gel and then occlude it and then do it.
The sonography is done by the abdominal route.
No, vaginal, sir, not abdominal.
So vagina is filled with gel and then?
And then you do the vaginal sonography. You can pick up all the, even DIE and everything very well. There is a very good chapter by Dr. Sibbal on this.
Okay.
Gel vaginal sonography.
Okay, yeah. So that is
Not MRI though. I'm not aware of MRI.
what Vikas here talking about the gel is
Yes, sir.
just to see because while doing the abdominal scan, we used to feel the bladder just to get the good contrast images. And with the MRI, we can find the demarcations more clearly.
That's why what Vivek sir was saying, that the rectal gel will be more effective.
Yeah, that's the vaginal gel.
Disease is mostly, we are worried about the rectal demarcation.
Yeah, that is a controversy.
Yes, sir.
Yeah.
So Vivek sir, we are watching you, and Harish sir is about to finish that case.
Yeah.
So can audiovisual person shift mic to Harish sir OP?
Just sir is finishing, I think. I asked him to demonstrate the rectum and then you shift the sound.
See now, the last look. We are done with the dissection. Okay.
Yeah.
So this is the rectum. Can you see the rectal fibers here?
Yes.
And this is going here, here, which is excised.
Yes.
We have these are the nerves. Can you see the pelvic nerves here?
Yes, sir.
And on both the sides, on this side is here.
Wonderful dissection, sir.
Wonderful dissection. Everyone has appreciated it.
Motorcycle, and I'll just do the cystectomy and then we finish the case.
Yeah.
Thank you so much. You can go.
You can listen the appreciation from the audience.
Thank you, sir.
Thank you, sir.
Thank you.
Audiovisual shift to Harish sir's OP. Hello.
So we have finished, we have removed the paratubal cyst and there were two parafemoral cysts, both sides.
Is it necessary to remove the paratubal cyst one?
Yes, it is necessary because it will affect the tubal function, tubal motility. So there is nothing here, no endometrial deposits or anything. We are coming out now. We have removed the paratubal cyst, we have checked the tubes. Both the tubes were open, there were no bands or anything.
If we puncture that paratubal cyst with a monopolar,
It will again come back.
Yeah.
Because these cysts are functional. Once we puncture them, after a month or two, they will be back. Then we have reverse head low. Nylon. Ethylone. Nylon. There no nylon. हाँ मैं सोचा करूँगा नहीं मैं सोचा करूँगी इट्स ओके डोंट वरी अबाउट लंच चलो अब चलिए
Yes, sir. Tubal reanastomosis. आणि हे काय शानबाग सरांचं एक छान होते हे रिडू वजानोप्लास्टी. म्हणजे बहुतेक वजानोप्लास्टी केल्यानंतर हे झाले सिकॅट्रायझेशन स्कार फॉर्मिंग मध्ये आय डोंट नो, पण बहुतेक लॅप्रोस्कोपी असते.
पहिली कशी केली?
काहीच माहित नाही सर, मी पण तुमच्या सकाळी
खालून केलेल्या 2 रिडू मी केल्या होत्या.
ओके ओके
लॅप्रोस्कोपी केल्या होत्या.
ओके
तर लॅप्रोस्कोपी केली असेल तर लॅप्रोस्कोपी पण खालच्या खाली केली असेल तर तो टिश्यूज एक्सरसाइज करून पेरिटोनियम आणून ठेवा.
ती एक चांगली असेल. बाकी काय मायोमेक्टमी वगैरे असणार छोटी अजून 11 म्हणतात एकूण, आता 5 झाल्या, 6 आहेत. DOP. रावळ सरांची एक TLH राहिले अजून.
काय करायचं?
TLH
राहू शकत.
जीवन
As we all can see in the audience, a fantastic job by Dr. Vivek. We all need to give him a very big hand. And as a infertility specialist and IVF consultant, I would like to add a few points that this is very extensive surgery, and if at all we want to look at childbearing in future, this surgery will definitely take care of her pain. Then we should be doing a pre and post operative AMH as well.
Rohit, have you seen that how they have made that endobag and taken out that specimen?
Hello. Yeah, Rohit isn't here.
Okay, yes, ma'am, yeah.
This is a wonderful way of, and a very economical one, I should say.
Yes, yes, ma'am,
Of
yes,
using a glove. This is for all you learners. This is just a glove. And of
Yes,
course,
ma'am.
Dr. Vivek is master of this, but we can do this, and endo bag becomes very expensive.
Yes,
A
ma'am.
glove is a very good alternative. Dr. Vivek has really created a normal anatomy almost from scratch, and that requires some skill. This is wonderful, Dr. Vivek. I'm Dr. Alpana. I really appreciate you. And now we can know from where Dr. Vikas has learned his acumen actually.
Thank you, ma'am. And ma'am, one important thing is that he hasn't increased any of this accessory port. He's taking out that endobag and whole specimen from primary port itself.
Okay.
So it's more and more cosmetic.
Yes.
Yeah, as far as possible, we can.
Yeah, we can see it. He's taking it out from the.
Section. Yes. Thank you, madam. Chala, kya?
So he's just debulking the glove actually, so it's easier to remove.
Yeah,
later.
but glove slightly is delicate, and any hard tissue you may like to, it may puncture and it may give you again more time in surgery. But there is a easy catch bag by Viol Medical which we very routinely use. That is, I think, very good for this.
And so what is the cost of that bag?
That is costing around 2,000 rupees or something, not very costly. Huh? No, but this the endo bags by this COVID and all are 15,000 rupees. So this is better. Yeah, so this is good. Or there is a bag in the rice tube. There is a bag in the camera cover.
DRP set.
There used to be a very good bag in the TUR set which they have stopped. So we have removed everything. Okay, just take. Yeah, दे. ये दे दे, टोकर दे दे. ये निकाल ले ना, हो गया काम इसका.
Vivek, it's pretty impressive how boldly you went around the rectum. Pretty much impressed with that.
Yeah, it was. But she didn't have any rectal infiltration as such. It was
but
it was
with
a
that
SC
vision to go to be, you'll have to be bold. To
Actually,
go that way.
fat tells you.
Huh?
The fat gives you a good guidance. Can you give me the trocar, please? Jaldi. Internal clean. Inside clean. Okay, done. Yeah. चलो तब तो डाल के देख ले. नहीं नीडल होल्डर पे दे. चलना फट से हमको ना ओटी फ्री करके देना है. ओके. वॉश. Yeah, antivert. Suction. So this is a near normal anatomy. You can. Irrigation. Can we take irrigation slightly? Irrigation. Yeah. Leave.
So I also follow the same. Because my meter also using
So this is the rectum. We can see a layer over it completely. There is no need to test. It looks all good. And there is no bleeding as such from both the ovaries. Some amount of ooze will stop. Will come out. Okay? Because drain नाही टाकत. टाकू? काही वाटत नाही असं. हां. Clean दिसतं. Okay. Chala, thank you everyone and thank you Vikas and his team.
Thank
here.
you so much. Would you be putting in Surgicel or something?
I will not be putting, madam. I generally don't put Surgicel or Intercede unless there is a myoma suture.
Okay. So right now
and,
here.
Sometimes if there is ooze, we can put a drain. That is the only thing. Otherwise, we no need to put any Surgicel or Intercede. Yeah, antibiotic. Okay. Yeah, चला गया. Bipolar दे पकड़ा. Pad दे दे bipolar. Show me here. How much is the blood pressure? Is good. Okay. नहीं अभी है और हो गया बाहर आ गया. All vesicular implants we can all. Okay. देखो. Done. Yeah. How to change it? Yeah.
Wonderful, sir. Thank you.
Okay.
Beautiful surgery. I'm sure everyone must have appreciated it.
Yeah. Thank you, madam. Thank you so much. And again, endometriosis surgery, we need more trained surgeons. So more and more doctors who are doing deep endo complex pelvic retroperineal dissection should venture into deep endometriosis surgeries and do it because we have a requirement so much disease load and more patients will be there. And always respect the patient's requirements. उल्टा कर दे हो गया चलो करना थैंक ऊपर का है क्या हाँ I was pressing the other one and thank you Escalab also for getting me the 3D to use. Yeah, vision छान होतो का खाली vision is good. Thank you so much. Yes, you have ICG in this. Okay, you have dye also. नाही तर वापरला असता. हां ओके सगळे आले ना पीसेस वगैरे गॉस पीस आला.
For the sake of audience, in the both OTs now, we are going to do vaginoplasty. One is fresh vaginoplasty and second one is redo cervicovaginal anastomosis, where previously patient has not used her dilators regularly. So again, the vaginal end has been again that due to adhesions and that it is blocked. So we are going to have that redo surgery. And in OT number 1, there will be the MRKHs. So vaginoplasty for that.
Now we are moving to our next case of this workshop. The procedure will be redo cervicovaginal anastomosis. The procedure will be performed by Dr. Sanjay Shanbag sir. Is an experienced obstetrician and gynecologist, has extensive experience in minimal invasive procedures and infertility management, done extensive work in urogynecology and pelvic reconstructive surgeries, has expertise in menstrual and hormonal disorders and high-risk pregnancy management. Today, now the case is 17-year female. She is already gone operated for primary amenorrhea. Now, okay, MRI suggestive of vaginal atresia in its cranial two-third portion. Now, may I request our moderators to kindly guide us through the procedure and interact with the operating team.
नहीं सब को बैठने के लिए बोला
ठीक है सब खाना खाने के लिए गए ठीक है चलेगा शुरू तो करने दो
हाँ मैम के लिए तो हमने तो
बंद किया ना माइक
हाँ
Second case is a 19-year-old girl with primary amenorrhea with CT scan suggestive of hypoplastic cervix with biconjugate uterus and hypoplastic cervix and lower one-third of uterus and ovary. With the suggestive diagnosis is MRKH syndrome. This surgery will be performed by Dr. Anil Magdum sir. Sir is a gynecologist with over 20 years of experience in providing exceptional care and also specialized in minimally invasive gynecological surgeries. Has founded Sparsh Hospital in Sangli with a vision to offer specialized and compassionate gynecological services. We'll now connect live to OT Complex.
तसं नसते पॅकेज रेट असतो तेवढंच झालंय म्हणा तेवढं सँक्शन तेवढंच आहे ना आपलं माहित नाही सँक्शन त्यांच्याकडून तेवढं आहे असं आपलं सगळं 100% सगळं तेवढं आहे हो एक्स्ट्रा आहे ते हो हो कसं सेंड करणार इनिशिएट डिस्चार्ज असतो म्हणा आजच्या टाइमचा तारीख डिस्चार्जची आजचीच टाकली होती
Hemant, are you with me, Hemant? Moderators, who is there in the hall?
Hello. Hi, yes, Vikas.
Yes, I think Rohit, you are there, no?
Hello, I'm also there, Dr. Jyoti.
Yeah, yes, ma'am.
Yeah.
So just wanted to tell that I think previously they have told history, but in this OT, the case is redo vaginoplasty. Dr. Sanjay Shanbag sir from Gad English, he is going to operate.
Yes. Hello, sir. Hello.
Ma'am, he is about to connect his mic. Just give us 2 minutes.
Yeah.
Vikas, hello.
Yes, ma'am. Yes, ma'am.
Yeah, just one question. Since she's got a bicornuate uterus and ovaries.
No, ma'am. Little, ma'am, there is confusion. What they are talking is not this case, ma'am.
Okay. Because I was just thinking whether we should rule out hematometrana, because if they are functioning and we're just going to do a vagina.
No, ma'am. She is, that case is also primary amenorrhea. And now we are going to put the scope and then we are going to decide what exactly it is.
Okay. Thank you so much. Because
And
it
now
was
the-
written bicornuate uterus and so hypoplastic.
Yes, ma'am. What we are thinking, this may not be bicornuate uterus, but it may be rudimentary, that birds will be there, uterine birds.
Actually, you are saying that that's why, because it was labeled Rokitansky Kasterhasa and then it's written that there is a bicornuate uterus. So they are contradictory terms actually.
But now,
We are going to put in the scope anyway.
no, but she is not having any kind of pain there, ma'am. Cyclic pain, if it was there, then we have suspected functioning of endometrium, but this history is not there.
Yeah.
So we are suspecting uterine
because
birds
on the
only.
slide it was written that bicornuate uterus.
Okay.
Hi Vikas.
Yes.
Just tell that redo vaginoplasty case is there. So when the first vaginoplasty and how it is done, lap or open.
Yes, sir. I will tell you, sir. Just give me 1 minute. Sir, that patient was presented previously with the typical symptom of primary amenorrhea. Her secondary sexual characters were developed, and she was having cyclic pain. So first diagnosis was incorporate hymen. So outside in Bijapur, someone has tried to just manage that case, but they failed, and then they were referred to us. Then what I did, I saw the case, I diagnosed it as the cervical agenesis. And so in the previous surgery, what we did, I am just telling. So we went laparoscopically first. We dissected bladder down nicely, and where that internal os was about to there, below that there was a huge bulge was there. So we suspected that menstrual blood was collecting in that one, and outflow tract was not there. So blood was getting collected at that point. So it was planned to do this one vaginoplasty as well as maintaining the tract from that endometrium to vagina exteriorly. So what I did in that case, so that bulge part was inside vertically, the drain, whatever the content was drained out. Then I made from below, I put that after bladder dissection, the dimpling of vagina was there. So we put the dilator sequentially, and we just made that anterior vaginal wall properly made, and then we connected that vagina with the cut end of that the bulge, whatever I just described. So I will just now, before that, I would like to show the current that USG findings.
Yeah.
So if you see here, I will just.
Yeah, we can see. You elaborated it.
So I will just pause for a second and I will tell you. So what you are seeing in this part, sorry, this is what is the bladder, bladder part is there. Oh, sorry. So this what you are seeing, that uterus is nicely seen, endometrium is also visible. Are you with me?
Yes, yes.
And that what my finger is pointing out, that is the junction between that lower end where the blood has collected. I will just switch on the video again.
Yeah, uterus and
So this is block, and again there is collection. Can you see that blood collection?
Yes.
And there is intervening membrane outside the vagina.
Okay. So what is your primary diagnosis?
So primary diagnosis is that vagina is means before after that what happened, sir? It was successful repair. Patient has appeared for almost 5 months. Proper menses has happened, and after that patient has stopped using her vaginal dilators.
Okay.
And then she presented with 2 months of amenorrhea. And then when I examined and once we did that ultrasound, then we came to know that again the vaginoplasty has been, everything has been blocked from below, and then we are posted for conference case.
Yeah. It's a good case, but she has to be close follow-up with the consultant. The similar case I did, she got married just 2 years back. And see, because once they lost the follow-up, and then everything will get fibrous and that tract will be get obstructed. And it is like hematocolpus only. It will collect inside. So once they lost the follow-up, then the problems can arise.
Yes, sir. So here also, sir, that what we are suspecting, that is hematocolpus only.
Yeah.
So now Dr. Sanjay Shanbag is ready with the case. He is about to put the primary trocar, and what we are in this, what we are means he is planning to do Singapore flap for the vaginoplasty, and lot of preparations we did for that. How to maintain that outflow tract once you open up that hematocolpus.
Yeah, one thing is that
yes, sir.
Nature has a great power, you know.
Yes, sir.
And whenever repeated hematocolpus will occur,
yes, sir,
it will create the vaginal wall which won't adhere, because that is a cystic wall inside and that will create the cavity. And the thing remaining is you excise the introitus. Don't incise, you excise it.
Yes, yes,
that
sir.
fibrosis
Yes, sir.
will go off, and only keep on dilating that portion, that will take care of that also.
Yes, sir. Yes, sir. Absolutely, sir. So here in this case, sir has asked fresh and sterile placenta. So we got that placenta from C-section case. It is kept sterile, and we have that sponge also, and we have some condom-like things, so that we are going to cover that. And Sanjay Shanbag sir is going to demonstrate each and everything step by step. So now he has put the primary trocars, and now we are about to put the scope also inside.
External camera.
So now external camera is going to fix on that abdominal wall.
Hello, am I audible?
yes, sir.
Okay, right. So how we enter over here is we have a habit of doing a direct entry, but can you see the abdominal wall? Because, एक minute.
Yes, sir. Yes, we can now.
See, this is the midline. Okay. So generally what people do, they lift like this and they put like this, right? Straight. What we do is we lift on the right side. And we, I don't know if you can see properly, but we go in an oblique direction towards the right side.
Going towards the right side, yeah.
We don't, see the
Not
vessels are
midline.
here. We are going this way.
Yeah, not midline.
Yeah, not midline. So we avoid the vessels altogether. It's pretty safe to go this way. Okay, now regarding this case has undergone a vagina, there was a uterus which had a hematometra. The system. Hematometra, and there was a blind pouch of the vagina. And what has happened is that the blind pouch has been opened and the uterus has been pulled down and attached to the vagina all round. Okay, it was functioning for some time, and then for some reason it has got disconnected, and there is a collection which doesn't necessarily have a vaginal wall around it. So there is a gap between the vagina and the uterus, and there is a collection there. So the problem is that, and she has not consented for a hysterectomy. So the problem is, if I do it laparoscopically, can you hear me?
Yes, sir, very well.
See, if I do it laparoscopically, I'll have to open that collection. And once I open that collection, I'll have to somehow find a way to attach it to the vagina. And if that is not possible, the hysterectomy is a must. Otherwise, she will be menstruating into the uterine, the peritoneal cavity. So the dilemma is to go vaginally and try to reach that pocket, so that we don't have to open that pocket. The problem with going vaginally is there is a high chance of injury to the rectum or bladder. If you go laparoscopically, the chances of injury to the rectum and bladder are less. Vaginally is literally a blind procedure, and the fibrosis is stone hard, and whatever give way you will find will be towards the vagina or the rectum. So what is a successful, how do you define a successful surgery? A successful surgery, a successful surgery is if you can, even if you, what is to have a, go to a plan B. So what happens if I go vaginally and we open the bladder or the vagina? What happens is there is no bladder or the rectum. There is no vaginal wall as such. So there is a, even if we repair it, there is a very high chance of a fistula. Because generally what happens is a vaginal fistula or something, you close the vagina, you close the bladder, and you put a interposing something, okay, right? Here there is only the bladder wall, there is nothing below it, there is no cover of vagina or anything. So there is a high chance of fistula. So what we have planned is to do a Singapore flap. A Singapore flap is a flap which is a full thickness flap with the skin on. And we'll be putting that flap in case we injure the rectum or the bladder. That is how we plan to do it. Okay, only problem with the Singapore flap is it is thick. And if we are not able to dissect enough space in that area, that flap itself will take up a lot of space there. So let us see how it goes. And you need to wish me best in this case. Carbon dioxide? Nahin hai? Okay, we have to wait for the carbon dioxide. In the meanwhile, we'll infiltrate the vagina with saline adrenaline. We have taken around 200 ml normal saline, and in that we have put, in that we have put around 12 drops of adrenaline from an insulin syringe. And that should be enough. Myself, Sanjay, I think Dr. Sanjay is the anesthesia team as well. Yeah, and Rupali's sister is with me, and Dr. Tanvi, yes.
Good afternoon, Shandak sir. Dr. Vaman here, everybody knows you from this area.
Yeah, thank you, thank you.
So where exactly you want to put the Singapore flap?
No, I didn't get this. Can you focus the external camera over here? Dr. Vaman, can you repeat that?
Yeah, you are preparing the Singapore flap. Exactly which is the place where you are going to put it?
No, I still didn't get it. Place means what? Place means?
So this is not a hematocolpus, right?
Yes, yes.
So you'll be putting the flap according to him.
See, I'm going to put it on the posterior wall where the vagina was. In case the bladder opens, I'm going to put it on the anterior wall. So one wall of the vagina will be the flap.
Okay.
Okay. We can use the Singapore flap from the other side to do the anterior wall, but that will take up a lot of space, and I doubt whether I will be able to.
So this is a case of hematocolpus, isn't it?
No, it's not hematocolpus.
There is no hematocolpus. There is a collection between the uterus and the blind end of the vagina.
Yeah,
I very much doubt whether there is a thick wall around that collection.
Yeah, if the thick wall of the collection is there,
yes,
then it mimics like a hematocolpus case.
Yes,
Yeah.
it is mimicking that
I mean.
hematocolpus. मला ऐकलं दे. इथे खुर्ची मिळणार मला एक स्टूल किंवा काहीतरी.
काही आला नाही.
So the dilemma is to do it laparoscopically or vaginally. Laparoscopically, the chances of opening the remove my specs for a while. The chances of injury of the viscous is less. See, what I am doing is to increase the see, all surgery is about the exposure. So I am taking a stitch, I got a screw, and I am hitching it to the side. The labia minor, I am hitching to the side. Can you see it?
Yes, sir, we can. You're suturing the labia to the side of the.
ते मार्कर कुठे ठेवलंय रुपाली? नाही मी पण आणलंय. हा आहे का? ओके. कट कर. Yeah, there is some dimple here. See, till here. इथेपर्यंत. Oh.
Can the cameraman in the OT please put it over the shoulder because we are losing the picture all the time. Hello?
Sure.
Yeah, this is better.
मला सलाईन ॲट्रन मला हे दे ना. नंतर मार्कर लागणार, आता नाही लागणार, लास्टला. See, I am infiltrating this. Mix केलंय ना सलाईन ॲट्रेनालिन? See, it is stony hard. I can't infiltrate it very well. I have to use a lot of force while infiltrating the saline adrenaline. I am hoping that it will give me some way. See, a lot of force, more than a myoma, you know. I would have actually loved to have a sonography machine in the theater to give me a guidance of how it will be going. Huh? Sonography machine hai? हाँ नहीं आता. अच्छा तो सांगतोय ते खोलीत आहे. See now, am I audible in the audience?
Yes, sir.
See, there are 3 vessels basically, which we will be, we will not want to see, but we will be very close to them, you know. We are not interested in seeing those vessels. One is the vaginal artery, second is the middle rectal, and third is the posterior labial. The posterior labial artery will be using to get a Singapore flap if we are successful in creating a long enough vagina. Whereas this space is so low that there is a chance of injuring while doing the lateral dissection, the middle rectal or the vaginal artery. What will happen is there is no space, you know. So we have to depend on luck and put some blind sutures with 2-0 Vicryl in that area. So that also has got a plan B. If worst comes to worst, I will be packing that up. And after packing it up, I will go from above and I will ligate the internal iliac anterior division laparoscopically, retroperitoneally. If worst comes to worst, hopefully it won't come to that. But we have to have a analysis de thode. We have to have a plan B for everything. Then these cases are not very common. Now, can you see that dimple? I don't know whether it's
a little needle.
You can see the dimple, no?
Yes.
Now, what we do is एक माझा simple rubber रुपाली कुठे गेली? Simple rubber कुठे ठेवलं ना माझं? Rubber नाही metal catheter आहे ते. घे ना घे. So what we do is we put a metal catheter in the bladder to delineate the bladder. See, I have not put a Foley's. And with the one finger in the rectum, we are going to guide our way around the rectum. Can you see can you see this catheter? Okay. So we put that here.
Yeah,
okay,
we
so
can see that.
Now as we dissect, I am going to just keep on feeling it and hoping that we are not going to open. The chances of opening the bladder and rectum are pretty high. Now, I think the carbon dioxide has come. We will take a laparoscopic view in the meanwhile. Because we'll see if it is easier to do. If there is a vaginal wall laparoscopically, it will be easier to do and without injuring the vitals. But I have a strong feeling there will be no vaginal wall there and just an insisted collection. Dr. Sanjay, can I have a head low? Head low. Camera चालू होणार काय? Camera. Light. Yeah, head low. Let us see, just give me a little while. Light source, light चालू करा. आणि माझा चष्मा तू आहेस इथे मी लॅप्रोस्कोपी करताना चष्मा तिकडे बस नाही चालू नाही झालं कोणाचा लाईट सोर्स आहे तो नाही Chalo, in the meanwhile, we'll start dissecting vaginally because I think the light source is not yet working. Will not waste time. As it is, we don't know how much time this is going to take. It's come. Sister, 50-degree scope पण घे त्यांना 50-degree scope पण दाखवूया. So that is probably the uterus.
We've lost your picture, sir.
The internal picture you cannot see?
No.
Some audiovisual person will do something.
Audiovisual console. You are in OT2.
Can you give some more head low, please? Yeah. Give maximum. किती होतोय बघ. दाखव पोर्ट तयार करूया चाकू आणि खाली पोर्ट चाकू त्या साईडला चाकू. कुठेतरी टच करत. ओके, क्लीन करूंगी बिटाडिन सोप, क्लीन करूंगी. 50 डिग्री घे, 50 डिग्री, 50 डिग्री आहे घे ना मग. हे 50 आहे ना, मग दे ना 50 दे ना. हे किती आहे 50 आहे. Okay, now you can see probably this is a bowel loop and that's the uterus. Okay, now I'm using a 50 degree scope. Can you see the difference?
Yes, sir.
See, I can go right below and I can see there is some collection there. Okay, that over here, this is the collection. We will try to dissect it and we will try not to open it as much as possible. We'll see what happens. Now we are used to using उजव्या साईडला ठेवलं पाय. You can see the collection there as well. Okay. What I'm going to give you is the chimta. See, all surgeries are about traction and counter traction. So I'm putting this instrument and I'm holding it with this tenaculum. Okay, and I am giving the assistant, Dr. Nikita Tanvi, to hold it like this so that we can get a fair idea what is happening on the anterior side. Can I get a suction? Just hold it. See that it doesn't slip. Okay, otherwise it will cause bleeding over there.
Sanjay sir.
Yeah?
Yeah, your suction is there. That is a vaginal tube.
Yes.
I think. So, this case is a now converted into a hematocarpus. So, if you open that bulge and suture it to the vulva at the introitus.
I agree. Let us see. Let us open that peritoneum and see how thick it is.
Instead of opening peritoneum, if you open from below, what will happen?
From below?
Yeah.
If you see the scan now, there is quite some distance. You mean to say that you don't want me to open here?
No. Just I am asking. If you open from below the hematoma, and if we exercise...
No. Opening that hematoma from below is not going to be easy because there is quite some distance between that hematoma and the...
That hematoma is basically formed because of the menstrual blood from the uterus went there and the hematoma was formed. That means there is a connection between the hematoma and the uterus. And if you open that hematoma from below and suture it to the introitus, I think vagina will get opened and the wall will form by the hematoma wall.
Okay, let us see how it works.
Yeah.
Sir, from what my experience, opening from below, if there is a distance there, there is higher chance of opening the viscous.
No, you will drain completely the hematometra, you will put the hysteroscope in the vagina, you clean it and pass the hysteroscope from below into the endometrial cavity. You will judge the cervical canal and the hematoma connection, and if required, you can dilate with the dilators.
अमित कुठे आहे? अमित सी दॅट ते हे आहे ना उजव्या साईडचं ना, हा ते काढ, हा तिकडे लाव, हा बरोबर बरोबर, हा बरोबर आहे, हा आता बरोबर आहे. See the tip of this. Everyone who's not using a harmonic and are using these kind of shearers. I have got 3 or 4 different kind of shearers with. This works with for a very fine kind of dissection, you know. So for this kind of dissection, we generally use the shearer. What we do, see there, you can see the carbon dioxide. Huh? Plan is to connect that and that. Okay.
That is the bulb.
See, already Dr. Vikas has dissected the bladder. So the bladder is down here. Can you see this fold here? The bladder is there. This is the bladder, this one. So it is pretty safe here. There is no kind of bladder dissection involved, just the peritoneum. So that if we have to close, we can at least close the peritoneum. See, can you see here? I'm very much worried that it will just be a small encysted collection, you know, and then I'll not be able to close it again. But there seems to be some amount of thickness here. What a thickness hai? Huh? हाँ ते वे नहीं, हाँ ते वे नहीं, हाँ 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 okay. Because hey, look, see that. Here, see, it is quite thin. Can you see? Here? Here. We don't want to land it in a situation where we cannot close this, you know. That is what I am worried about. So now we will go from below and see how much we can reach from below. Huh? नाही आहे तर दे दाखव कसं दिसतंय वगैरे. Now we will shift vaginally, and if we can have the vaginal picture before that adrenaline wears off, no, we will make use of it. कितनी अंदर विकास, how much is the distance between this and that pouch? You cannot wait. Light. इथे आणि ते नाही.
Total distance was
Light, this light please. Alice. आणि नाही इन्फिल्ट्रेशन लागणार मला. आता मला पेन्सिल लागणार, पेन्सिल.
चष्मा काढायचा.
हा चष्मा काढायचा आहे आणि पेन्सिल दे मला. हे कॉटरी पेन्सिल. मोनोपोलर, हा मोनोपोलर. ते सिस्टर घेतलेले छोटे रिट्रॅक्टर्स ते ठेवतो, ये इकडे. ते हे डिस्कनेक्ट कर लाईट सोर्स. असं ठेव की काय न जळता. हा कसं तरी कुठेतरी ठेव. हा लाईट बंद केला. ओके.
गेला का लाईट गेला का?
हो लाईट बंद झाला. आणि एक ॲलिस त्या ते असू दे, ते नंतर बघूया. जस्ट होल्ड दिस. आफ्टरवर्ड्स वन्स वी गो डीपर ना कॉटरी चालू आहे. पेशंट प्लेट लावलंय, फक्त ते तिथे कनेक्ट करायचं याचा दुसरा एंड ते मोनोपोलरला. हो.
What's your plan?
I'm planning to cut here and see if I can dissect. I'll put one finger in the rectum, and this is to guide me regarding the bladder. But if the distance is too big, now I'll have to open that vertically and go from above. I don't know, means it is difficult to judge the distance between this and that.
Vagina is ballooned up.
Huh? Yeah, it's ballooned. Yes. Yes, it is ballooned. But it might just be a thin thing. Now, I don't know. I don't want to incise it before unless it's absolutely necessary. There, मागे there. I might not. Yeah, that is the final this, because we don't know how thick that is, no? We should not, she is not consented for a hysterectomy. We are not interested in, means, in landing in a situation when we cannot join the upper to the lower. See now, for all the external this, with this, I am just, see it is a curved thing. So with this, but there is no sonography in the OT. See this is, now with this, I am seeing in between, where, here on this. Not yet. Advance ka. The external picture, can you see as we are advancing?
Yes, sir, yes, we can.
Because my finger is in the rectum, I can say at least posteriorly I can go a bit. Yeah, is guiding the anterior. Yeah, enter the anterior side, and the finger in the rectum will be guiding me not to enter below. I hope you have given her some Duratas or something, good antibiotic, higher antibiotic. Yeah, higher. Can you give a higher antibiotic, because it will help this flap also. Duratas give her. Dakho. I'm almost there. I cannot feel the vault, but I can feel some give way. I'm just hoping it's not the bladder. No, it isn't the bladder. I will have to open that to see laparoscopy wise. And I'm not very confident of suturing it back if it's just a very thin thing, you know, it's just a collection. If there is thickness in that, no, then I should not land up in a position where there is something inside. Okay, we are just next to the rectum. I think we'll go from the top. We are just about to open the rectum. We'll have to put a Singapore flag here. वरून करूया. वरून करूया. We are very close to the rectal wall. I can feel the rectal wall. Yeah, afterwards, after we open that. After we open that.
Different embryology. So maybe in this case only the upper third of the vagina is formed, and because they are embryologically different from the lower
I've got a
third.
big dilators to put.
And that is why we are having this no vagina at the lower end.
माझा चष्मा चष्मा चालू केलं लाईट मोनोपोलर हा आणि मला ते वायर मोनोपोलरची टाका विकास ते मोनोपोलरची वायर टाक हुक दे हुक सिस्टर मोनोपोलर हुक नाही घेतलं हे नाही हुक पाहिजे मला ते दुसरं हुक हे नाही का हुक ग सर्विक्स नाही त्याला कट करून तसंच ठेवलं नाही सर्विक्स नाही Now I want you to show like this in the center. Now you're going to use the monopolar and a hook, and I'm going to cut that vertically. Okay, suction here side la. See, there will be thick. मोनोपोलरचं हे सिस्टर तुझ्या पायाखाली आहे मोनोपोलरचं पेडल इथे वरती आहे ते मोनोपोलरचं हे खाली घे ना इथे ठेवले ओके ते वायर विकास ते वायर टाकलं का निघालं हा Be careful, it will start bleeding. धर हे इथे हे असं कर धर see that it doesn't you don't leave it or don't tear it. Be careful. It is pretty thick. Huh? No, uterus इथे आहे quite big. हे दाखव सक्शन दाखव सक्शन आत आहे बाहेर आहे हा We are happy if we are able to suture whatever we cut. हे काय सर्विक्स आहे का हा तर सक्शन चालू करा प्लीज सक्शन चालू आहे See, because it is thick, na, it will not flow. It will actually it will quite easily come in the suction. चालू है suction? एक काम करा, एक सीझर घ्या आणि हे कट करा. नाही, सक्शन चालू ठेवू, हे कट करा. हो, सक्शन चालू करा. मला इरिगेशन पण द्या. सक्शन चालू आहे का? काय येत नाहीये. नाही, हे ब्लॉक तरी नाहीये ना माझं सक्शन. I'm sorry it's taking time, but that suction is. पाणी देणार का जरा सक्शन इरिगेशन? Okay, can you start the irrigation? ते ब्लॉक झालंय वाटतं. सक्शन इरिगेशन चालू केलंय का की नाही? ते किंग बसलंय का मग? असून देत असं. नाही, कुठेतरी ब्लॉक आहे, काय समथिंग इज. I am actually quite relieved that there is a thick wall there, you know. I was thinking that it will just be a collection. Irrigation on आहे, पण हा चाललंय पाणी. आता सुरू झालं. So we will dissect the bladder a bit and we'll open it further. The Alice type, I think. Dako. I think the pneumo, something is wrong with the pneumo. Oh. It's a wire. There is no pneumo, something is wrong with the cylinder or something like that. Suction दे. ग्रास्पर दे बाइपोलर ग्रास्पर. Grasper bipolar. Yeah, thank you. Now we have put this, we will see till where. See, you can see here the bladder is still there. Okay, so we can dissect it a bit further. This is the bladder. Please pull this upwards.
होत नाही.
And Harish sir's mic, please. Yeah, sir, you're on. Harish sir, you're on. So Harish sir is demonstrating how to make that mold from below. And external picture, can you focus on the trolley, please?
Okay.
So external picture will be shown you soon. Harish sir is showing how to prepare the mold.
Okay, syringe there.
So he has just taken one sterile sponge and now he has taken one Foley's catheter.
Okay.
And one condom is there.
So the sponge is around 7 to 10 centimeter in length. Okay. And then what you do is you place a Foley's in between like that. And then linen. So this is the Foley's is for inflation and deflation. नहीं suture linen वही तो बोल रहा हूँ कब से. Thread. Okay, so you take non-absorbable sutures here to place it in, and then what happens is that it either goes in a condom or better to put it in a plastic bag. Okay, like that. And then at places this plastic bag gets sealed up here. After that you inflate this. So when you insert it in the vagina and you inflate big amount, deflate inflate 30 cc please, 30 cc. Go. So you can see it getting inflated. Okay, so you see it's getting inflated nicely and taking
all the shapes of the, okay? So that's how it gets inflated fully. That's it, enough, okay? So once it is inflated like that, then when you want to remove, you deflate it and remove it. Okay, so that is how you make a mold. Got it?
Yes, sir.
Yeah? So that's it. It's not, it's what happened. What gaya? Karo? Sorry? Section also, yes. First you do that. Yeah. So before inserting, you suck it out fully. So you make it first a linen नहीं है, linen लाएंगे तो I can show them properly. हाँ अभी that's inflating, yeah. बंद कर दे. ऐसे ही आ रहा है बाहर. नहीं ऐसे निकाल, हाँ बस आ गया.
Leave that and
Okay, anyways, we can start now. The trolley again. ते नंतर ठीक आहे अभी ते उसको ऐसे रहने दो. नाही ते तसं राहू दे त्याला सगळं नंतर करूया. We'll start the surgery. Come on.
Air is not going vaginally, no?
Camera,
आवाज येतोय बघ. कुठं आवाज आहे?
Camera light. क्या हुआ? नहीं खाना है? दे. हाँ? It is MRKH. ये पकड़.
आता 30 डिग्री स्कोप के 30 डिग्री स्कोप के
One second. Betadine there. Betadine, please. Betadine, yeah, betadine. Put some in this, beta. Put it some. Bus, okay, wait, and give me more. Give me more. Give. Okay, stop. क्या हो गया? क्या बस इतने? क्या? That's what. So it's this much. Gloves मागवा 7 number आहे. अजून आणखीन मागवा एक. दोन घेऊन या 2. Ready? हार्डवेयर मिल गया. या क्या हो गया? ओके पकड़ा. हेलो.
Audiovisual team, please switch on RS sir's this one mic, please.
30 डिग्री स्कोप.
Okay, so no problem. It's okay. Dender है ना वो. There's no problem.
Gas on, please. वो ते CO2 चेंज नाही केला ॲलनचं? नाही ना, कुठे? कॅथेटर कर. बायपोलर केबल उभं नाही राहायचं, पटपट लावायचं सगळं. कुठे मग लावा ना. कन्फ्यूज क्या होते हैं? कहाँ पे है पॉटरी? कहाँ पे है? Which one it is? कुठे लावलाय? नीचे आहे क्या? हाँ.
आलेच सर. हो आलेच नवीन. सांगितलं सरांनी घेतलं. मोठी आहे.
हिस्ट्रोकट. हाँ, ये रख लो आप. इसमें हिस्ट्रोकट मंगा लो. गैस ऑफ प्लीज.
Can we shift the mic to T2 please? Audiovisual team.
See, we have put in that space which we have created, now we have put a dilator and we can clearly see there is something over here. I have put my finger in the rectum as well and I am sure that that is not this bulge. See, it is far. This, first I will shake the dilator. See, this is the dilator and behind that is the rectum. So I am pretty sure that this is not the rectum, that bulge which you can see.
Right.
So now with a monopolar, I am just going to nick it. The thing is that dilator is steel, but the surface area of the dilator is so much that it is not going to burn even if the monopolar touches it. You understand? See, I am using the dilator on the steel. That is the dilator. ते वेजाइनल डायलेटर्स पण आणले होते ना, ते कुठे आहेत? तुला लागतंय का ग ते? हे बघ, हे लागतंय का तुला? हॅलो, तिथे खाली लागतंय का तुला? हे बघ, हे लागतंय ना, हेच आहे ते. सी माय असिस्टंट डॉक्टर निकिता, तन्वी, शी कॅन फील दिस. ते प्लास्टिकचे वेजाइनल डायलेटर्स आहेत का?
What is that bulge? That bulge is cutting.
It starts sparking the moment it touches the steel.
Oh. Okay.
Or we'll put a sponge on holder.
Sir, so it is there, sir. Just give me 1 minute, sir. One person is coming with the dilator, sir. It's kept in the sidex.
Okay, it's all right. I'll put a sponge holder.
Yeah, ऐसे करके आए हम लोग.
Because this will cause sparking the moment it touches that steel dilator, you know. Wait. Yeah. I'm put my finger in the rectum to doubly check. So I'm not opening the rectum here. I'm pretty sure. And here, it's coming. Somewhere. It's in the rectum. It's in the rectum. Okay. I can feel the sponge in the rectum now. Yeah. Okay. Let's see what we can do. No, now it's no problem, no point. We will be... 1 minute, we'll have to repair it. No issue, come. that dilator, let us see if we can open it here. If we put it from there, no?
Audiovisual, can we just switch on Harish sir's mic? Sir, you are on, sir.
Hello.
Harish sir, yes.
Can we have the head low?
You can
please?
feel it?
I need adequate good head low, ma'am. Give. Yeah, give. Now, चाहिए मुझे. Yes. Okay. So this was supposed to have been an MRKH, right? है ना?
Yes, sir, yes.
But there is uterus in the patient, and of course uterus is appearing as a
light bunker
bicornuate. एक मिनट. ये देखो ये कपलर गया है. एक मिनट रुको, मैं कर देता हूँ. I'll do it. Yeah.
The vision is
Okay.
quite good.
Better?
Yes, sir, yes.
So this is one uterus which has hematometra, and this uterus is probably not having any collection. So I don't know whether this is functional or non-functional, but this is for sure functional because this tube is having a sign of hematosalpinx. This tube doesn't have anything there, okay, except that it is affected by slight endometriosis here. Okay, so we'll just do adhesiolysis and see what to do. Wait, leave your hand, leave. Scissor, knife, blade. No. Small, अंदर मत डालो ज़्यादा, thin patient. Okay, so what is the plan now? Okay, so she has a blind vaginal pouch. So this is similar case to what Dr. Shanbagi is doing in that case. It may have a cervical agenesis, so we don't have a proper diagnosis. Ideally, in my opinion, if you don't have a proper diagnosis, you should not proceed with a surgical procedure, ideally, okay? But we see what we can do best to her in this particular setup right now with this situation, okay? Can you have the pressure in the bottle? Open it, no, don't shut. Pressure, press. Yeah, okay. So I'm just washing the hemoperitoneum so that we have a proper idea what we are dealing with. Okay, so we have a intact rectum here. Okay, we have the ureter coming from top. So definitely this kidney is present probably. Okay, so but at least not, no, bowel. Yeah. Okay, and there, this is the internal, external. Give me that. Yeah, okay. Oh God, this is going to be a nightmare for me. लिया क्यों तुमने? बंधु, डोगा है का तुला? चल. Clean lens, please. तुला कसं असिस्ट करायला लागते? Okay.
Histro ready, hai na? Maybe because the vagina is blind, okay? So what I'm going to do is, so see, it's like this, there is no cervix, okay? I cannot feel any cervix there. Leave it, see that? Okay? So this is just the stump like that. Okay, it's going to be a long distance agenesis. And whenever you have a long distance agenesis, you do multiple surgeries and they come back for the same thing again and again and again. What we are facing in the side OT, similar to that. So I'm trying to see, wait, no, histro nahi chahiye, light chahiye. Ikade there, 7 number gloves. And let's see, I'm examining, keep there, keep the scope there. I'm doing give a jelly please. So that's what, no, I'm just first coming to the conclusion what I'm going to do, what I can do for her. So this is what is the vaginal, external camera, come here. This is the functional rudimentary one, and that's probably non-functional, but I don't know. She may have a septum also, which is like Robert, okay? So she may have a septum, but then both the uterus should show a bigger one. This is not filled up. So, and this tube is not filled. You see that the other tube is filled up with the hemoperitoneal, hematosalpinx. So,
it might be a non-communicating right horn of uterus.
Difficult to say that only one horn, because one horn, if it is communicating, she should get menses. The fact that she is diagnosed as MRKH, I'm really surprised how she is diagnosed, landed up with MRKH diagnosis. Because I can see the hymen here. You can see? Come here. Alice there.
Can we see the external?
Yeah, I'm showing, ma'am. I'm showing. They are coming here. Close camera. Close. Glass piece there, Chandiba. Glass piece there. Down. 1 minute. Okay. Are you able to see the vulva?
No, we can't.
Not yet. External camera, please. ये हाँ पकड़ दूसरा दे ये थे
ब्राइटनेस जरा कमी करा
ये लाइट नहीं can you see?
It's too bright.
Oh, see, 1 second, ma'am. टी लाइट बंद करा, ही लाइट थोड़ी कमी करा. नहीं.
We can now.
No, I can't see then.
Okay, you see.
No, they are enlightening me here. It's not. So you see that now. Now wait. Keep. See there, laparoscopically.
Camera zoom करता है तो क्या बघा? So much better.
So this is definitely a blind pouch. There is nothing there. Okay, but there is only 1 centimeter lower vagina present. So upper vagina is absent. Okay. So this is vaginal agenesis along with the cervical agenesis. And there is no hematopulpus because there is no vagina. Okay, otherwise there would have been hematocolpus. So there is no cervix, there is only hematometra. The only option she has is removal of this particular segment. Okay, now I don't know whether to obtain the consent for that. Dr. Devkare? Is there any suggestion from the audience or from any senior people who have some suggestions for this? Hello, am I audible?
Yes, sir, you are.
Ma'am, there is no there is no vagina, there is no cervix. Okay, so it will be like anastomosing uterus to the vestibule, to the vestibular outlet, which is not a good idea because she will not have any holding capacity.
And infection chances are higher.
So yeah, I mean, this is going to be like pushing her for something more than what we can give her benefit to. So in my opinion, she requires, removal of uterus.
Is there any ultrasound picture which shows us hematoma?
No, no, ma'am. That's what it was.
On the right side.
Surprisingly, it says that agenesis of vagina and
No,
everything.
it
and-
isn't. That. That's what the first question I asked because Tonsky, Cage, and
Yeah.
at least one ultrasound would have made a difference.
Yes, that's true, ma'am. So we can either defer it now and then, give her a proper,
I think that's a better option.
That's what I'm coming out. Because it's very difficult for us to decide and discuss without discussing, you should not remove the uterus.
But she'll keep menstruating in the right.
I totally agree to that. I totally agree. I mean, we are in a fixed situation, but without patient knowing, without parents, yeah.
Right.
So that becomes a sort of a, and then again doing it in a workshop, they generally might take something else that, that was probably done by
I
someone.
think a good ultrasound, MRI, and counseling
Yes, ma'am. And then
benefit,
yeah.
and then she can take an informed consent.
So now most of the patients who have come to me like this, there was one patient who came from Prayagraj. Now patient has severe pain. So they have done a diagnostic scopy and in which there was 7 centimeter size cyst and 4-5 centimeter size hydrosalping. So they did salpingo-oophorectomy on that side. Then the patient was referred to me for vaginoplasty. But then patient did not have cervix only. How will you do vaginoplasty?
Yeah.
So then I said, why didn't you do? So they said, no, we did not have diagnosis. I said that before taking the patient in the OT, we must have a diagnosis. Because you cannot just remove organs like that without patient knowing it, that this is the implication. So what we can do is that she is going to get married in about 6 months' time. That's what I heard. So if she is going to do that, then she requires hysterectomy and a good vaginoplasty in the same sitting. We can do that. So what will be the idea then, ma'am, is to not do the complete removal of the uterus. You should remove tube. You should remove both. Ovaries obviously will be kept. 1 minute. I'm showing something. So what you do is you keep the cornua here. You keep some part of the peritoneum properly, means you have to go inside the uteri, not too much in the uteri, but not like how we do hysterectomy. So that will give a thick vaginal, area for it to have a form. So that at least we can give her a good vagina. So, no, she doesn't have cervix. See, no? See. It will be utero, that is what, if there is utero-vestibulo. So, and then the uterosacrals also. Yeah, that's because it's not there, no?
No cervix.
So, there is no cervix. So, that's the rectum. Okay, this is the rectum. Yeah, that's the best option, yes. So, we are coming out.
So it's complete cervicovaginal agenesis.
Yeah, it's a cervicovaginal agenesis, yes. Only she has hymen, that's it. Okay, section get me.
This is not acceptable at GMC level.
I don't know. We have a sonology machine.
ये नोडुल निकालते हैं पकड़ इसे 1 second छोड़ दे वो छोड़ दे ये लाइट बंद करो ना ओवरहेड है पकड़ोगी
अल्ट्रासाउंड पण नाही झाले मला वाटलं ते एमआरआय फर्स्ट एमआरआय आणि ते पण करेल
दिखा पीछे
But now see, now what we have to look at is partly.
This is IP.
पण एमआर मी पहिला क्वेश्चन मी त्याला काय विचारला तू एमआरके म्हणतो ना प्रॉफिटॉन्स की कस्टमर असं मीन्स that there is no uterus, only ovaries. But this is not Propitansky, na? नहीं, तिला cervix नहीं है. So even if you make
Go
vagina,
back.
and secondly, first you see whether the bloody bigger horn is having any selection, whether it is functioning. नाही माहिती नाही.
That's the ureter.
Normal आहे.
Here,
असं पण
this
असू
one.
शकतं ना.
Okay.
आपल्याला हा एवढासा दिसतो लॅप्रोस्कोपिक व्ह्यू. दिस इज नॉट नेकेड आय व्ह्यू. किंवा हा एवढासा आहे हा नॉर्मल आहे. हा पहिलं तुम्ही बघा ह्याच्यात काही हे आहे का असलं तर यू हॅव टू रिमूव्ह.
Show me.
To remove.
ये part.
You do not have any cervix. Then making a cervical business is not here. But you
One
have
sec.
not informed her. She's getting married in 6 months. She will sue you now. She तुमच्याकडे MRI. मी असले लॉयर तुला सांगणार जा यांना लाखात 20-25-30 लाखावर सुकर.
Smoke card.
गव्हर्नमेंट शुड नॉट पे. आणि आम्हाला इकडे खूप झालं की मग तो पहिली स्लाइड मी बघितला मी म्हटलं कॉन्ट्राडिक्टिंग yourself. You're saying Rockdowski customers. Then you're saying you got biconnect. What are you talking? And then you've not done MRI. आणि ते दुसरं पण he is not done it.
One second.
Vaginal खालीपर्यंत आला होता
That's the ureter.
इंच maybe इंच पण नाही.
That's the ureter. Okay. One sec. Clean the lens.
बाहेर आला असता.
Hmm.
And skin माझी सासऱ्यानी
I was right. One sec. One sec. So internal iliac when it is large, पकड़ो इसको bowel को पकड़ो. Whenever the internal iliac is big, no, generally it is rudimentary one.
outside also.
Okay. Yeah. Because uterine is absent. Yeah.
त्यांनी बंदच केला ना.
पकड़ो अभी. Yeah. Good. So that's the internal iliac.
But no, you say ki it is not you cannot do vaginoplasty. We are coming out.
Lift up, please.
We are coming out. We will do additional investigations. Now that is the only way you can salvage.
Okay.
We will do MRI. We will find
There you
out.
go.
And then
Show the peritoneum. इसे छोड़ते नहीं है बेटा. Yeah.
what he's saying, I've not heard of it. He's saying थोडंसं ते pour out.
हाँ छोड़ दो.
That's vaginal वरचं हे ठेवा.
That's how it is. Okay. A lot.
असं करून आणि छान ठेवायचं आणि मग तो असा I'm not seeing that. मी पण ऐकलं नाही. अगं माझ्या सासऱ्याने आणि जैननी हे वजायनोप्लास्टी एवढ्या छान केल्या आणि मी हाऊसपोस्ट मध्ये हे घातले खूप.
पाणी चालू हो गया.
आम्ही करायचो कारण ज्युनियर मोस्ट हाऊस पण तो काम केलंय. कॉन्डोम घातलं करा आणि घाला आणि पेशंटला शिकवा. सायनला केलं बंद सगळं. हे पण
This is also functional horn because there is endometriosis here.
And since you are going to put a skin na,
Less likely
हळूहळू वरती आणि माझे
because see the tube and all.
बोटांनी असं करून टाकायचं स्पेस तिकडे. एकदा प्लेन मिळालं ना just go. There is enough space to make a
That's what we should do that only now.
skin.
Hello.
मला कळत म्हणजे मला ना तुम्ही आता कळत नाही. सरांना बस
Show me here.
आहेत का?
नहीं ऐसे नहीं. इकडे चंदू कैमरा छोड़ दो बेटा. पकड़ा.
MRI करा.
छोड़ दे. कैमरा दे दे.
No, but then you have to counsel, na counsel. Very important.
ये ऑन करो ना. पानी बंद क्यों किया ये लोग ने पानी. पानी ऑन करो ना प्लीज.
Then that is MRK मध्ये नाही. But it's like this and if this is hey you have to go for inspection. So you have to explain diagram काढून सगळं. मी आधी diagram काढायची पण दाखवायला पण. त्याचं परत खाल्लं चाललंय. मग बेबीच खाल्लं.
नहीं कुछ मत कर.
काय करू शकतो मला कळलं नाही.
नाही.
काय करणार मला काय करायचं असेल.
Press no bottle, press. ठीक है, okay now. Now okay. Wait, don't go. एक मिनट रुक जा. Yes.
Advice put the menstrual blood in. So what you do is, with the lower two-third, he was in the correct place. Go.
Useless.
And replace transverse but not below, below.
Boss, press the bottle please.
Then you put your total skin here.
Thank you.
And then you put these condom catheters. Hey, Jay, honey, tag now. But the patient, patient setup बनवताना
Okay.
चांगला
Sure.
रोज फोन करणार.
Coming out.
नंबर मी करायचं म्हणून त्यांना शिकवायचं की तुम्ही असं करा तेव्हा ते स्टरलाइज नाही करायचे तसंच फॉर्म हे करायचं आणि घालायचं आणि 2 दिवसांनी ते काढायचं दुसरं घालायचं त्याला काहीतरी लुब्रिकंट द्यायचं आणि अजून एक म्हणजे जेव्हा वंदे सपोज शिगत मारायची लुब्रिकंट मारतं ते इंटरकोर्सने रिमेन्स पेशंट you don't need mug type.
Heart. She has. Not everyone have, huh? Chal, come. That's it. Come out. Gas off. Thank you very much.
Thank you, sir.
Thank you, sir.
So we are going to put her now on OC pill, you know that? So that she doesn't menstruate at all. Hello?
Yes, sir.
Yeah, so from now, today onward, she will go on OC pills so that she stops menstruating at least inside. Till she decides about what is to be done.
Gas off, light off.
Hysterectomy should be the best course, right, sir?
Yeah, we can give her Luprad also, but that's expensive. Yeah, expensive, but yeah, true. That is also can be given. Lupride, anything can be given.
Can we shift to other OT?
Yeah. Simple rubber, remove this urine. This. Huh? Okay. Simple rubber. The metal catheter put in.
Hello.
Yes, we can hear you.
Yes, Rohit, 1 minute. Shanbhag sir, you are on.
Yes, we had gone blindly in the vagina and by some fate we had opened the rectum. There was a rent in the rectum around 3 centimeters. Then what we did is we put an instrument from top here and we pressed it into that vagina and we got a small passage into the vagina. So now we have got 2 passages in the vagina, one going leading up to the right wall of the rectum which was opened up to 2 to 3 centimeters. We have sutured it in 2 layers right from the apex to the, it was a longitudinal tear, 2 down with 20 PDS. PDS is anytime better than Vicryl and it is not as expensive as your barb suture. So now we have sutured the rectum in 2 layers. We are going to put a Singapore flap over it and now we are again on top and we have put dilators in that second passage which was in the vagina. Okay, there were 2 passages caused. One is going up to the, let us see whether we can see it now. There seems to be a stunned silence in the auditorium, but I guess you had come to see this, no?
Yes, sir.
See, it is no crime to have a complication. You should know how to manage it.
Yes, sir. Yes, sir. Until and unless I hope it is recognized in time and treated well.
Complications are a part of surgery and right in the beginning I told you there was a high chance of opening it.
Yeah.
And it was informed to relatives also before we have taken that patient inside the OT.
Suction. त्याच्या आत कॅमेरा सोडायचा.
Any specific post-op care, sir, for rectal injury?
Yeah, you will have to give her codeine syrup for constipation, for some days. So you should give her low residue diet and codeine syrup. So what does that show you? That shows you that this is not my first rodeo. Okay, just press it gently. Okay, ते आहे ना?
So that bulge is from vagina and that.
Yeah. Okay, can you see that bulge?
Yes, sir.
Don't worry, if something happens, we'll suture it. Don't. I am pretty much confident nothing will happen to her.
Great, sir.
Focus. असं धर. हे माझं हे अगोदर इन्स्ट्रुमेंट जाऊन द्या. आता हळू स्टक. Just shake that dilator a bit. हे आहे ते? हे आहे की नाही आहे? Put it in ना. एकच मिनिट. आठ टाक. Now, where did that come out from?
एकदम अप्पर मार्जिनला.
आता गेलो होतो ना ते पूर्ण आतमध्ये. हो. वरून खूप ताण होता. ठीक आहे, इथे कट करूया. या प्लीज. मी फोन करतो नंतर. Where is it? दाखव. आठ टाक. Where is it? It's here. Yes. Okay. Antivert it. It's not in the rectum, no? No. It's not in the rectum. Right? No, just antivert it. We'll open it widely from there. Just antivert it there. Antivert. Yeah, this is it, no? See this one. Yes, sir. आम्ही ठेवलंय सर. रेक्टमच्या जवळ नाहीये ना? आलाय डायलेटर. दाखव आठ टाक ना. Wait. It's in, no? Attack. Okay. Now we'll put our finger inside and widen it. Um, It's quite inside. बोट पोचत नाहीये तिथे. कुठे गेलं यार? कॅमेरा आत टाक बघू. सी त्याच्यापेक्षा मोठा आहे का डायलेटर? हा मग एवढं छोटं का गेलंय? सगळ्यात मोठं मला वाटलं तर सगळ्यात मोठं टाकलं म्हणून. ते टाकलं तर मी कट पण करू शकतो ना. वेट हा या 1 hour. आता हळूच आत टाक. दिसतंय का? मॅडम जरा ते त्या साईडला का? एक मिनिट. हा असं कर ना. दिसत नाहीये ना? दिसायला पाहिजे. Put the first one. Put the first one. आत दाखव ना. या एरियामध्ये ब्लॅडर मध्ये गेलो. ओके युरिन इथे आहे ना. दॅट मीन्स देयर इज नो होल इन द ब्लॅडर. Now in this same direction we will have to put the other one. त्याच्यापेक्षा जरा मोठा ते. मला 10 वायक्रेल द्या. दाखव. हा इथे दिसतोय. चलो आपल्याला मोठं वायर पाहिजेच ना. हे कट करूया ना आपण. हे युटरसच्या मागे बघ. युटरसच्या मागणं नाही येत ना ते. नाही. ओके दाखव नीट दाखव. नाही कट करूया. चल hold it like that. I have opened the rectum, I have closed it also. Yeah. Now I'll have to put a Singapore flap. Now I'm trying to find a way. I'm going to make this opening, na, and then I'm going to close it and put a Singapore flap. Then that's it. The end of the surgery. Not, that looks like it, na? There also. कुठे आहे दाखव इथे आहे कट करूया ते मोनोकुलर वायर लागतंय ना नक्की
In another OT, Tuboplasty has been endorsed and Dr. Anil Nagdin is about to start that case.
तो पहिला होल कुठे आहे आणि खाली आहे काय
Dr. Rohit, you are there?
Yes, yes, Vikas, go ahead.
Yes, sir, yes.
Suction. वन 0 वायक्रल मिळणार का किंवा नंबर 1 वायक्रल दाखव That is your dilator bits. Yes, sir. Oh, असं धर ना असं दाबून धर खालून जात असेल ना दाखव 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 8% हेच आहे का ढक्कल बघू मी हे धरतो एक्सरसाइज करूया त्याला हे आहे किती थिक आहे ते इज इट सो थिक फेल टू अंडरस्टँड
Hello. Hello.
तेच आहे ना
Dr. Rohit.
Yes, sir. Yes, sir.
There are people in the audience.
Yes, sir.
So we'll discuss it like a fresh case now. Okay.
Yeah,
So
yeah.
we had couple of cases where there was cervical agenesis. I'm Dr. Harish here.
Yes, sir. Yes, sir.
So there was a cervical agenesis, vaginal agenesis.
So let that be.
Generally, when the patient has cervical agenesis, those patients generally don't do well. Here you can see some part of the cervix.
We'll close.
So we'll ask Dr. Sanjay that if suppose a fresh case comes to you, which has a transverse vaginal septum or a upper 1/3 or so vagina absent, and there is a Sanjay.
Yeah.
So if there is a hematocolpus on the upper side, and there is a blind vaginal pouch there, lower.
Okay.
So what will be your approach?
Blind vaginal pouch, generally we do it we just incise the vagina.
Crucially,
And,
yeah, but then suppose
over there.
that it is quite far on MRI.
Yeah, so we are not going to do
shows
it
4
vaginally.
centimeter.
Yeah, if we never do this, see, there are 2 layers of the vagina here, and there is a loose areolar tissue in between, you know.
Yes, yes.
So what happens is you can never do it vaginally. It is impossible.
No, vaginally you can't do, but
You
what
cannot
will you
do.
do laparoscopic?
So here we do like this only. We open it vertically, the vagina.
Yeah.
We clear it. Generally, it is not so thick. It comes off with
Yes,
the suction.
yes, yes.
And then we take a transverse incision on the lower end of this.
Okay.
After that, from the lower end, we just take an incision and we put a finger or a dilator. You can see it from here.
Yes,
You
true,
put a
yeah.
incise that.
Okay, and then you anastomose.
Yeah, you excise actually from the sides, and then we anastomose. The Vikram?
So you don't put any other tissue there that time.
No.
Surgery, right?
No, what we do is we put a amnion graft there.
Okay.
Not like that. Scissor.
So then what are the chances that there is a possibility of recurrence of, atresia or recurrence?
There are some chances of atresia. What you should do is you should excise it, not just incise.
Yeah.
And
So is there any role of priming this patient by anything like estrogen or something like that?
I haven't done it.
No, no.
I haven't done
There are some papers, Scandinavian, wherein they say that, giving it some dose of estrogen or priming them.
Okay.
But then again, that is not going to increase the length.
So since this case had a rectal injury as well, so now we have an opportunity to do the flap and not feel guilty about it, you know. The Singapore flap. Yeah, because I was not very keen on doing it at the outset if it would have been a clean case. Madam, जरा ओढा ते. ओढा, बाहेर ओढा. No, this is the 30 degree. Yeah, actually with 45 degree it would have been, you could have seen it, visualize it better, but you cannot see the lower part, means the one which we incised with the monopolar, no? That part we cannot see with the 45 degree. That you have to change, shift over to a 30 degree. Yeah, Dakkan. Dr. Shintre, this is a camera is quite good. Huh? How much you got it for? Okay.
It's a really good camera.
Okay, quite good. Uh-huh. Madam, you are coming in my way. Vision. Oh, I forget your name. Just withdraw it now a bit. Your dilator. Yeah, thank you. See, when it becomes loose like this, now you take three throws. 1, 2.
फेलिसिटेशन ओळखून घेतलं बरं झालं ते चांगलं तुला सुचलं बरं तर हे सर्जरी होईपर्यंत म्हणजे
I have not fired your remaining cases, no? Dr. Shintre? Because when you practice in a setup where you don't get a surgeon or a colorectal guy, you have to know to do everything, you know. And in my place, getting a person is unheard of. You may leave that. Leave that. And hold this like this. See that it doesn't go into the intestine. Huh? Just be gentle with it. नाही तसं नाही इकडनं आहे ते तिचं इन्स्ट्रुमेंट येत आहे मध्ये तसं नाही होणार नाही असं Don't tighten it now because you will not see the tip afterwards. Tighten it at the end. Yeah, now I think we are towards the end. Scissor, सुई scissor ना. Stitch कापायला scissor लागणार ना. Excuse me. हाँ मोल्ड ठेवूया पोलीस नाही 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 Fully is not म्हणजे त्याला काही इंजुरीज नाही म्हटल्यावर ते यू कॅन जस्ट ट्रीट इट लाईक एनी अदर नॉर्मल. क्लीन करून घेतेस काय कॅमेरा? क्लीन कर. सक्शन द्या मला, सक्शन द्या. कुठून तरी ब्लिडिंग आहे, प्रिक्ट समथिंग. इथे that's okay. आता दाखव. सुई. इथे गिव मी द कॉटरी. बायपोलर कॉटरी. हे आत ढकला, पोर्ट आत ढकला. बायपोलर कॉटरी जोडून द्या पटकन. हे नाही बायपोलर, हे सीलर आहे, कॉटरी नाही. इथे आहे बघ, याला वायर जोड. जोडलं. सक्शन दे, टाक सक्शन. ओके, कॉटरी दे परत. नीट दाखव. स्पर्टर आहे, त्याच्यातनं हे घेऊया काय. थांब हे काढ आणि मला हे दे, मिडल होल्डर दे. ते बंद करतो. दाखव आता. नाही, कॅमेरा हलवू नकोस. याच्या पलीकडनं यायला पाहिजे ही सुई. ब्लॅडर मधनं नाही यायला पाहिजे. ओके, आता सक्शन दे. एक कथाने दाखवू नको. इथं बांधूया त्याला. नाही, कॉटरी दे. इथे टाक. मॅडम, ओके, झालं. बांधूया, मग सक्शन करूया. थोडं वॉश देऊया, मग व्हेजनली आपण सिंगापूर फ्लॅट देऊया. दॅट विल बी द एंड ऑफ इट. कलेक्टेड आहे वाटतं. Suction. इथे आणि मला हे दे, काय म्हणतात त्याला, इरिगेशन आहे. इरिगेशन सोडा. थोडं कॉटरी करूया अजून. इथे अजून आहे, कॉटरी दे. ओके, सक्शन. ओके, इरिगेशन, सीजर. Okay, Dr. Hemant, I think this part is done. Okay, it's done. Caesar. हवा भरून दे. हा, हळूच काढ. जरा आत दाखव ब्लिडिंग आहे का म्हणून एकदा. नाही. Okay, this part is done. आता दाखव काढताना सुई. Out it goes. चल. चल, now we'll do the Singapore flap. Forget that. इकडनं bleeding नाही ना खालून? काढ ना. झालं, Singapore flap will be on this side. हे light चालू करा. Okay, done. चला pack टाकूया. मार्कर दे हमारा. ये ठेवून दे. माझा चष्मा काढा आणि इथेच ओटी मध्येच ठेवा, त्या खोलीत नेऊ नका. कॉल विकास ना, विकास माझ्याकडे वेळ आहे का? आय हॅव टू डू फिनिश इट फास्ट. टू आस्क विकास कुठे आहे? डझंट मॅटर, तोपर्यंत हे संपूया. ठीक आहे, आय थिंक यू कॅन स्टार्ट द ट्रान्समिशन ऑन दिस साइड. Hello, can you hear me in the audience?
Yes, sir. Yes, sir.
Okay, now I am starting the Singapore flap.
Yes, sir, please. We were eagerly waiting for that, sir.
Okay, the base of the Singapore flap is now, since we opened the rectum, we don't feel guilty about doing the flap, you know. Previously I was thinking, should I do, should I not do? Now since the rectum has been opened and I have sutured it in 2 layers and there is no vagina as such, it's just fibrous tissue, so Singapore flap becomes a must, otherwise there will be a fistula formation there. So what is a Singapore flap is, can you see here? This is the posterior, what you call it, fourchette, no? What it's called, this one. And you feel the ischial tuberosity here. I can feel the, give me the marker pen. See, this is the ischial tuberosity here. Here is the adductor longus tendon. Can you see there? On the camera, this is the adductor longus tendon. This is the ischial tuberosity. All the Doppler studies have shown that this posterior labial artery, which is a branch of the internal pudendal, which comes out from the Alcock's canal, it comes like this, and it is around 2.5 cm. Patti de patti. त्याच्याबरोबर एक पट्टी आहे. You can see here that so it should be, so at least 2.7 centimeters. So the incision should start here and it should go up to the around 2 centimeters from the fourchette, posterior fourchette. So this is the incision for the flap. Now this should be adequate, and this is the fold. You can see this fold. So the flap should come just inside the fold. You cut this. This also you can cut.
In another OT, start the tuboplasty, please.
So you go up here, just medial to the fold, and the flap should be up to here. Okay. Now this one also, because this is the posterior labial artery from where it's going to arise. So the flap cannot come medial to this, otherwise there will be necrosis of the skin. So this goes like this. And because we have to close the remaining, it becomes tapered like this. Here also you taper it a bit like that, so that this skin comes together. Now I'll need a knife to cut this, and a lot of Alice. You can see the markings of the flap. This is where the posterior labial artery will be, and this is the flap. Knife, इथे आहे कुठे काय? Okay. Now what I want to do is do like this. Sister, asa. So stretch. So नहीं, एकदम नहीं, just थोड़ा.
Sir, any specific step that one has to follow first, which is that you have made 3 to 4 markings. So which marking we should do first?
No, the ischial tuberosity is the first marking.
Okay, okay.
So your posterior labial will be 2.5 to 3 centimeters medial to that. So the blood supply comes from that. Okay, now.
Sir, even audience wants to know that once you take out that skin part, are you going to put it inside vagina?
Yes.
Yeah. And what is the next plan? Where you are going to suture that?
No, just watch.
Okay, sir. Okay.
असं stretch करायचं. Now what is important is mop. Now I want the pencil. I need tooth forceps or something like that. Tooth forceps, thank you. Now what is important is you hold this and this has to go up to the चालू करा है ते मोनोपोलर से चेंज करा है
pencil cautery.
So this has to go right up to the fascia because the artery is above the fascia, and here you have to go very superficial so that the artery is in this flap.
Okay.
Yeah, so do you understand what I am saying in the audience?
No. Yes, sir. We are with you, sir.
So see, we are going right up to the fascia. You can see the fascia and you have reached the muscle there. Already you can see the adductor longus tendon there. You can see that fascia has to come up with the flap.
Sir, what are the other options that are available for other than that Singapore flap?
In this case,
yes, sir.
Once we open the rectum, this is probably the only option. Otherwise, see that Marsh's flap is possible when there is a vagina.
Okay.
Marsh's flap, there is no vagina here, no?
Yes, sir. Yes, sir. So this flap is going to cover the rectum and the healing will be much better. And
yeah, there will be blood supply to that area, you know.
Yes.
Now see, once you come up to here also you have to do the same thing. Up to the fascia. This incision goes, yeah, just stretch it, please.
So we have to reach to muscle or?
Yeah, muscle. The fascia has to come with the flap. Alice. Is it visible what I am doing?
Yes, sir. Yeah, kindly, very well visible, sir.
Mop.
External camera, please adjust the
light.
Focus, please. Yeah. Now it's visible. Can anyone, OT people, can you tell what is happening in another OT? Anil Magdum, sir.
On. Am I audible?
Yes, sir, you are audible, but yeah, now you are visible also.
Okay. We are just starting the case. Maybe in between someone can brief about the history of this patient. Is it already briefed? Table khali purna.
Sir, no, sir. I think it just only they have been told there is a case of tuboplasty.
Okay.
That's it.
So she has undergone para 1 living 1. This is her second marriage, and that is why I think for the social reason we are going to go ahead with reversal of tubal ligation.
Okay, sir.
She is a young patient. She is hardly 22 years, so haven't done AMH values for her. टेबल खाली जाऊ शकते पूर्ण अजून जरा जितकं खाली जाऊ शकेल तेवढं जाऊ दे. And it looks laparoscopic tubal ligation. So I'm hopeful we'll get good proximal and distal segments for our surgery then. जाऊ दे खाली. She is a short lady. So is the external picture visible?
Yes, sir, visible,
Okay.
but little bit brighter.
Okay.
That
Hey, like
light
वरचा
has
जरासा
to be
कमी
little
करा.
bit dimmed up.
Yes, we'll do that.
Sir, any specific consent you have taken before this, put the trocars specifically for this lady?
Generally, for open tubal ligation, we take consent that if the distal segment is not there, then we may not be able to perform the procedure, so it will be just a diagnostic procedure. But as this is a laparoscopic tubal ligation, we'll get a good result. So along with this, the chances that I may not be able to perform the full procedure, the risk of ectopic pregnancies, which is little more increased compared to otherwise general population. So these are the two things which we discuss with the patient beforehand.
And anything assurance about the success of surgery and success of getting pregnancy? Not consent, in general we are discussing.
Hospice. Nahi. We always tell them that intraoperative, even if we get the tubes patent,
yes,
the pregnancy depends on many other factors. So
yes, there are multiple reasons for
other
infertility.
reasons also. Yes.
Yes.
So it's direct trocar entry.
Yes, sir.
And she being a very thin built, lucky I am today. Pressures should be little less. Pressures 8 and flow rate 8 in the beginning.
Hello, Anil sir.
Yes.
Dr. Jyoti here.
Yes, ma'am.
Can you please tell how much functional tube should be there so that our tubal reanastomosis success rate will be there? Can you please tell us? And what are the things that we should take precautions when we are doing tubal reanastomosis?
Precautions, it will not be for tubal reanastomosis, but precautions will be for tubal ligation. Basically, when we are performing tubal ligation, I think nowadays we should think more about in case we need to reanastomose this tube, whether we can, how we should do the tubal ligation, like the ischemic region only, and preferably laparoscopic. Even in open cases, I feel if we can apply bands, that will be great, because that gives the best success rate for pregnancy after reversal of tubal ligation.
Okay.
So first of all, hearty congratulations to whole team, Vikas, Ravi and Jyoti and all of you, because this is for the first time. After such a long time, we are having a live surgery workshop in Government Medical College, and no doubt it is like when you are coming back to your alma mater, you feel much more prouder. Local Daddy. So long time back, we used to be here, and Guru sir used to be like our lecturer. Most of our surgery clinics, it's been conducted by sir. We learned from him then, and then some part of my OBGY lecturer post along with you and Prakash Numar from anesthesia, we were together. So very fond memories of IHR and the very busy labor room then. So it's really good to be back over here.
Thank you, sir. Thank you. Most welcome.
I still remember
there was Bhushan was there. One was it Bhushan Patil or someone? During that time? Narayan? नाही, रवी तुला माहित असेल.
Narayan and Bhupendra.
Bhupendra.
Yes, Bhupendra Patil.
Bhupendra Patil, one of the fastest obstetrician. म्हणजे 7 मिनिटात skin to skin. That was his record. I still remember.
Yeah.
Because Kurekar sir, he was like comparing that time, and he said it is like he is one of the fastest ones.
Yes, even we do remember him likewise.
Yes.
So it seems quite adequate length you have got today. So
Yes.
still lucky patient and
Manipulator.
lucky surgeon too, we can say.
Yep.
Many
See,
times,
look
yeah.
over here. This is like ischemic region, and I will be doing anastomosis with ampullary part of the tube over here.
Yes.
And
Can you just tell us what kind of instruments you are using? You are 3 mm or
now these are like
5 to 3?
routine instruments. Only my needle holder is 5 to 3. Means
Okay.
it is 5 mm shaft and the tip is only 3 millimeters.
Yes.
Okay.
Sir, we are watching you that Sanjay Shambhag sir is giving some importance.
Yes.
Just get back to you.
Go on.
Audio visual, can you just shift audio to Sanjay Shambhag sir's OT?
Hello, okay, am I audible?
Yes, sir. Sir, we are watching you. You made some tunnel there. Can you just explain?
For this, why this is going up to this, you can see that I have cut up to this fascia.
Yes, sir.
Can you see?
Yes,
Why it is
sir.
important is because the labial artery is above this fascia, this white thing you can see?
Sir, just take out your hand, please. That right hand, sir. Yeah.
See, this is the muscle,
Oh, yes, sir.
adductor longus, and here you can see that fascia.
Yes, sir.
That fascia should remain with the flap so that the blood supply of the posterior label is in this.
Yeah. it should be
Otherwise, the
maintained.
skin will get necrosed.
Okay.
So the few points to avoid the skin necrosis is this base should be thick because this posterior labial artery comes from here. If you see oozing from here, it's a good sign. That means there is blood supply in
Yes.
this.
Yeah.
Okay. The second point is this tunnel which I am putting inside, making here. It should admit at least 2 fingers.
Okay.
See, 2 fingers are going there.
Yes,
Can you
sir.
see? Otherwise, it will hamper the venous return of this flap.
Yes, sir. Sir, at the top of that, we have seen some bleeding. Was there any significant artery or it was just
It
non-specific?
might be a branch of the posterior labial, no? Because you have cut that flap, no?
Yes, sir. Continue, sir, please. Yeah.
So now, see, we have this. Now we are going to get this flap from here.
Yes.
Okay. Now, once we get this flap from here, can you see it's there? We are going to, we have packed the vagina. We are not going to do anything else, but we are remove it.
So this is forming your posterior vagina, right?
Posterior vagina, more importantly, I am not worried about the posterior vagina now. I am going to cover that hole in the rectum, which I have sutured.
Okay, sir.
The posterior vagina, we can do a amnion if you allow me enough time. Because now time is an issue, no? See, this one, I am going to suture on top of that rectal hole. You understand what I am saying?
Yes, sir.
At least. And now I will mark that this. See, here I am going to put it. इथे थोडं कट करायला लागणार पेन्सिल त्याला टेन्शन देयर शुड नॉट बी एनी टेन्शन इन द फ्लॅप
Yes, sir.
that is another thing. Okay.
Sir, we are watching you. We'll just shift to Anil sir's OT, sir. Just for 5 minutes.
Yeah, you have been watching me for quite long now.
Yes, sir. Sir, but still everyone is enjoying that your confidence and the decision making and the patience. So really, Hall is very happy with the decisions whatever you have taken, and you are not lost.
Thank you
your
very much.
patience.
But how much did you think to say this?
No, sir. No, sir. Just it's coming from bottom of my heart, sir. Don't worry. Can audiovisual people can change to Anil sir's OT, please?
Hello, am I audible?
Yes, sir. You are audible, sir.
Okay. So now you can see we have created the proximal stump over here.
Yes,
we have
sir.
created a distal stump over here.
Yes, sir.
You saw me pulling the end. I will show it on the other side. Hey, ikada halwa.
Sir, we have seen one thing that you haven't injected any kind of vasopressin there.
No,
I have
it's-
missed it.
No, I haven't injected any vasopressin over there because I feel the bleeder, which we use it to avoid the bleeding
Yes,
over
sir.
there.
Yes, sir.
And I feel that bleeding is not very significant one and it stops on its own. That's why I haven't used it. Now you can see here, I am pulling the end of this proximal segment and I am making a nick only on the peritoneum. The serosal surface
Yes.
of it. Okay.
So what kind of scissor you are using? It little bit different or same?
This is disposable scissor which I got from someone.
Okay, sir.
And you can see now
Yes, sir.
the stump of this proximal stump is created over here. You can see the lumen also over here.
Yes, sir. So we have seen that generally all surgeons first that whatever the stump they create on one side,
Yep.
they do suturing on that side and they shift to another side. So here little bit different we are watching. Any specific reason, sir?
No, I thought ki we need to go again double 2 times. So instead of that, we will finish it off in one go. To check the proximal segments.
Yes, great thinking, sir.
So I must praise Sanjay for his courage, and it's not courage, it is his experience and confidence which made us see something different, completely different thing.
Yes, sir. Absolutely right, sir.
Otherwise, we would have, if it wouldn't have been him, anyone else, the outcome of the surgery or the decisions would have been completely different.
Different. Yes, sir.
I will miss his Singapore flap.
Yes, yes, sir. He has almost created posterior vagina
Okay.
and he's about to suture that.
Okay.
Sir, we are having recording. We will share with you, sir.
Yes, sure. So now we have created stumps, proximal and distal stump on
Yes,
both
sir.
sides. We can see here.
Yeah, we can see that mucosa is spouting out from that
Go
left
close.
side
Yes.
distal segment
Yes.
of the tube.
So we can
Yes,
see
sir.
it very clear, very well.
Exactly, sir.
Now we will inject methylene blue
Yes,
into
sir.
the uterine cavity and see the proximal stumps only.
So what the device you are using? It's simple that Leach Wilkinson's cannula or you put that for...
One of my friend, he gifted me VCare, so I am using that. I'll show you that.
So what is your experience about using that Foley's, number 8 Foley's and blocking that urinary part, blocking that another part and injecting methylene blue from that end?
Not, I haven't used it. And most of the time, this simple thing has saved me, or I could perform the procedure with this. That's why I haven't used it.
Yes, sir. It's a very simple method you are doing, sir, and we are really happy to watch you, sir, live.
Okay, chala kala kite. Okay, so we'll push the die from here and then.
Sir, can we have that external picture just to have what is happening below, because
Yes.
we want to see that what cannula you have just mentioned. It's absolutely new for us.
Yes.
No need to take out if you have inserted inside
No.
canal.
It is there. It is outside. We'll just
Okay,
show you
sir.
that. बरं ठीक आहे दाखवता ते मिथिलीन ब्लू जरा डार्क करा बघू दे पुश कर बघू करा पुश
So you are using spice camera there?
Yeah, it's your spice camera and that's why I'm trying to match your speed, man.
No. Are you happy with the vision?
Yeah, completely. So we can see on both sides we are able to see the good jet of this die. Something.
No, sir. We are having external picture.
Power गेली खाली हल्लं काहीतरी केबल पॉवर गेली ठीक आहे.
Can we have internal picture, please?
1 second. ते जरासं लाईट गेली इथली म्हणजे पाठीमागची केबल हल्ली त्यामुळं.
नो इश्यू सर.
ते हे दाखवा तोपर्यंत त्यांना त्याचं नाव पण दाखवा तिथं पाठीमागे लिहिलेलं आहे. So this has got a good curve and it has got a blocker also at the end, the bulb, which we can use, which we can inflate and prevent the backflow of the dye.
Okay. A very nice one, sir. Yeah.
And it is more of a non-traumatic one.
I think, and it is going to help you for manipulation also.
Manipulation and pushing the dye also, both the things we can do simultaneously.
Okay, sir, okay.
I'm going to use 60 Prolene round body.
Yes, sir. Sir, now can we have the internal picture, please?
1 second, yes. He cut kara ita. Okay. Needle holder हे द्या, Maryland द्या, आहे इथंच.
Sir, we are watching you till we get internal picture. We'll see that how that sir is taking the stitch there.
Yes,
and then
please.
we'll watch, we'll ask you about regarding your surgical techniques about the suturing.
Yes.
Audio visual, please shift to routine number 2, Dr. Sanjay Shanbag. Sanjay sir.
Yeah.
Can you just explain how that stitch you have taken, what suture material you use?
It is 20 Vicryl, but what is more important is that there should be no tension in this, in this flap.
Okay.
So now I have released the flap more from the side so that there will be no tension. You can see a little bit of oozing from where I have cut, but that is a good sign. That means there is a blood supply to the...
But sir, where you are stitching this means what is the highest point?
There was a rent in the rectum, right?
Yes, sir.
So I am stitching it exactly on the top of that rent, the upper end of the stitch.
So means on the rectum you are placing it that?
Yeah, on the top.
Okay.
See, it was a longitudinal tear and I have sutured it in 2 layers longitudinally, right?
Okay.
So then now what I am doing is longitudinally the top apex of that rectal tear, apex of that rectal tear on top.
Yes,
I am
yes.
suturing the skin.
Okay. Got it, sir.
And now I am sequentially coming down to fix it to the tissue on the side.
So they are interrupted sutures?
No. Why interrupted?
So you are taking continuous?
Yeah, I'm taking it on the edge now. I'm not taking in the center of the flap.
Continuous that one line from that flap and one
on the side. Then I will take another on the other side.
So the fat plus the rectal wall?
Not the rectal wall.
Now
there is a fibrosis, there.
Okay. Correct, sir. And set another on where you will be suturing that?
Which one?
Opposite part of that flap.
Same thing to the fibrosis. Here, this part. No, I'm going to remove that skin.
Only.
I'm going to excise that skin.
Okay, sir. Okay.
And then I'm going to put your Romovac suction drain here because this part you can't give a pressure drainage, no?
Correct,
we could have put a corrugated drain and given a pressure dressing, but this part you can't give, no?
Yes, sir.
So what we are going to do is we are going to put a Romovac suction drain.
Yes, sir.
What another thing we could have done was we could have opened this here and without excising the skin we could have done it. But problem with that is this centroitus will look horrible here after that.
Yeah, that one V-shaped this
yeah. So the whole purpose of this surgery is for her to have sex after marriage.
Yes.
It shouldn't be that her husband has to take a sildenafil citrate every time,
Yes, sir.
I'm just joking.
That's it.
See, this will look okay.
Yes, sir.
You can see inside the skin is fit nicely there.
Yes, sir. Sir, you continue. We are watching you. Meanwhile, can audiovisual goes to Anil, sir?
Hello?
Yes, sir. You are on, sir. We have seen
Fine.
that. So you have taken one stitch.
Yeah. So the first stitch, it is like from the proximal stump.
Yes.
Not compulsorily we need to go that way.
So it's a inside out?
It is outside in.
Outside in.
And now I will go inside out.
And this is at 6 o'clock position?
This is at 6 o'clock position.
Okay. How many stitches you have planned?
Generally 3.
Okay.
Depends on...
So 6, 10 and 2 o'clock?
Yep.
Yeah. So it's wonderful to watch your hand movements, the way you are using the curve of the needle as well as your supination and pronation of your hand.
All this will matter only after when the dye comes out well.
Yes, sir.
Not before that.
Sir, have you checked that distal segment is working or not? That means patent or not?
No, I haven't. I should have. But I'm giving a benefit of doubt.
Sir,
it looks like
yes, sir. It is there, but I think you are in muscle.
Yep. See, this is the mucosa pouting.
Yes, sir.
Can you see it here?
Yes, yes, sir. Yes, sir. Sir, question from audience that can we put any probe like thing hysteroscopically and
can.
suture over that?
We can.
So time consuming will be there. So it is not required or what?
Depends on how much time you are taking for this suturing. If this suturing is going to take longer compared to putting the thread, then I think we should go ahead with that.
Okay, sir. Sir, and also we have noticed that you haven't taken any mesosalpingeal stitch or that just to have that approximation of the segments.
Yes. Many people, they do it. I feel when I am trying to close the mesosalpinx, there are two thoughts about it. When we are trying to close the mesosalpinx, it will have some amount of healing and maybe some amount of fibrosis, because that is how the body heals like. So that might pull the tube and lumen to some extent towards the fibrosis, and that is the reason why I haven't brought it together. But it's not a bad idea to close the mesosalpinx and bring both the edges together, so that will help to reduce the traction on this suture line.
Exactly, yeah. So that is the only tension free suturing to be there.
Yep.
And yes, sir.
So that to reduce that traction on the suture line, we have retroverted the uterus.
So don't you think that using 6-0 Prolene is little bit difficult for newcomers because it's very small needle and handling of the sutures will be little bit tough?
5-0 or 6-0, there are hardly any studies to prove that no 6-0 is better. It is just like smaller the suture, lesser the trauma.
Yes.
That is the only thing which goes behind this one. And what I feel is monofilament is better than polyfilament. But many are using even 4-0 or 5-0 Vicryl also.
Yes, sir.
So the main principle is like we are trying to avoid the kink over here,
Yes, sir,
which
yes.
I feel may not be feasible over here, because on the distal side, the suture has gone somewhere different. So let us see if I can correct it.
Yes, sir. Don't you think, sir, that what I felt that from one that the middle part of that segment has gone through 6 o'clock, and for that distal segment it is not little bit away from 6 o'clock.
Yeah, because the tube was twisted there, so maybe because of that, but I was thinking it this way. Anyway, yep.
Yeah, so it is correct.
How much stitches do you plan to take, sir? 3?
Generally 3. Sometimes it goes like 4 if there is any leak or something.
You plan to tighten it one stitch at a time or everything?
No, it becomes very cumbersome if I take the stitches and then try to tighten it all the things together. So I generally go for one by one.
Sir, and what is your plan after this surgery? Means many even doctors and many gynecologists and patients also ask for HSG to be done to confirm whether we did surgery correct way or the.
If you are giving a video of this one and the proof that yes, the tubes are patterned, I don't think it is needed. But
sometimes spontaneous closure or the fibrosis may.
Agree, but on many occasions we have seen the blocked tubes, they are open on laparoscopy in most of the cases.
Okay, sir, okay. And how much time will you give for that couple to get conceived?
Depends on age and the other factors. See, if this is bleeding, it's a good sign.
Healing one, sir.
3 months.
Okay.
3 months.
Hello?
Okay, sir.
2 to 3 months are fine.
Hello.
Hello.
Yes.
Hey,
Audio.
My phone,
Kindly shift that transmission to Sanjay Sandbag sir Soti. Yes.
forceps.
Audio visual, please shift that audio to Sanjay Sandbag sir.
See, now this flap is done.
Yes, sir.
If you see, hey, hota, hath.
Yes, sir. We have seen you did it wonderfully, sir.
See, inside you
That
can
flap
see
has gone inside.
this flap, Singapore flap inside, covering that suture line.
Yes, sir.
Can you see that?
That means exactly we can't see that flap.
But chota seems this. Chota
But we have seen that what you were doing there.
See, a few, 2 or 3 points I want to tell you before doing. See this, you can see the flap or you cannot. Inside.
Yes, sir. No, your
Can you
head is
see?
coming in way, sir. Yeah.
Someone is standing in between, I think.
Yeah,
Someone's head,
Pramod,
my
please
head.
adjust the external camera. And now it's visible, sir.
Here you can see the skin there.
Yes, sir. Yes, sir.
I can't see it. Here, see this one.
Yeah, it is there, sir.
Okay.
Because
now,
reflection is on that, this one. See,
it is on that suture line. See, it is on the suture line of the rectum.
Yes, sir.
There you can see. Now,
Yes, sir.
can you see now?
Visible, sir. Visible. That black part or brown
Yeah, black
part we
part
can
down.
see, sir. Yes, sir.
You can see now?
Yes,
It
sir,
has
yes,
come
sir.
in this tunnel.
Yes, sir.
See, this tunnel has got no constriction on the flap. I can still pass a finger. Can you see my finger going through the
Yes,
tunnel?
yes. That means
Now,
it's free, yeah.
I don't know if you can appreciate the 3D depth. This is up to the muscle and this is the flap. This
Yes, sir.
triangular. And this is this much depth inside.
Yes, sir.
Can you see? This is the muscle and this is the flap, triangular flap which is going inside. I have shaved off the skin from this.
Yes,
What is a good sign is that when I dab it like this, you can see some small ooze over here.
Yes.
See,
yes.
you can see some small ooze.
Yeah, yes.
Why that ooze is important is it shows that that flap has got a vascularity.
Yes, sir.
The inferior labial artery is still supplying this flap.
yes, sir.
So we
Yes,
can safely say that skin is not going to get necrosed.
Yes,
that
sir.
necrosis is horrible. It will look black and it will be painful, you know.
Okay.
She will have sort of a pain in the inner side of her thigh. That is where the nerve supply is, no?
Yes,
So now this will, I'm pretty sure that neither the fistula will come up nor the flap will have that necrosis.
Yes, sir.
Now what is needed is just a Romovac suction train here, and I am going to close this with subcuticular stitches if possible. If this two skin doesn't come together, we have to just undermine this edge. Okay?
Yes.
I think you can go to Anil sir.
So your plan is to put one drain and just close the skin.
Close the skin,
That's
yes.
it.
And I'm afterwards for some time, if you permit me, I will show you a neon graft on that inside thing.
Okay, sir. So you are going to use that or you are not going to use
Yeah, I'm going to use the amnion because we have used this flap over the rectal wall. We don't have anything over the vaginal wall.
Definitely, sir. We would like to we would love to see what you are doing with that
Number one,
placenta and all.
Number one, Michael. Because this flap has been used for the rectal perforation. It is forming only a small part of the vagina now.
Okay, got it.
Initially, my plan was to make it the whole posterior vagina, but that has not, because of the rectal perforation, no?
Yes, sir. Yes,
I
sir.
had to put it over there.
So now no need to go to the laparoscope and see what is happening inside.
I have already closed.
Yes, sir. Okay.
Laparoscopically, I have closed that vaginal incision.
And sir, any specific instruction you are going to give to us? Or
Very important is that she cannot sit for 5 days. Because if she sits, what happens is
Okay.
that she will sit on that posterior labial artery flap and that will cause necrosis.
Okay.
She can stand, but she cannot sit.
Okay, sir.
She will have to give low molecular weight heparin for 5 days.
Okay, sir.
Lonopin injections. And what I am doing is I am going to put the hair there, na Romovac suction train there.
Sir, you please continue, sir. We are watching you.
Yeah.
We will have discussion with Anil, sir, please.
Yeah,
Audio
once
visual,
I come
please.
to the Korean this, na, I will.
Yes, sir. Please inform us. Don't start directly. Audience want to see what you are doing exactly with that placenta, amnion, and these things. Huh? Audio visual, please shift to Anil, sir, Soti.
I'm there.
Yes, sir. Please.
Okay.
Yes,
so,
sir.
we have removed that first stitch and we have retaken it now.
Yes, sir. We have seen that, sir.
Okay, so let us see now with 2 more stitches, I should get the much awaited free fall of blue dye.
So no 2 needle holders, 1 needle holder and 1 the Maryland.
Maryland, yeah.
Okay, and preferably in the left hand Maryland and right hand needle holder. You are right
Depends
hand.
on if you are a righty or lefty person.
So I am righty, sir.
So
I'm ambidextrous actually.
Yep.
So now you are taking with the muscle also or only serosa? Everything is taken?
Yes.
Okay.
Everything is taken. So just to reconfirm where I am, this is the lumen from the distal and it should get approximated over here. Okay. Two more cases to go. One is myomectomy and one is
Good evening, everyone. We are going to post myomectomy surgery on OT2, in OT2.
whichever OT gets finished first. So I think Sanjay is finishing, so we can plan it there.
Yes, sir.
Audience side.
Get the placenta first. Placenta.
Hello.
Placenta.
Hello.
Yes.
Shift the
Placenta
transmission to
to
Sanjay Shanbag sir Soti.
No, you carry on. I have to still prepare the placenta.
I think they will be interested in looking at how you are preparing that one.
No, the placenta is not laparoscopy. It's just a preparation.
Yep.
Placenta आहे.
इथे आणि इथे एक लाईन
ओपन करून ह्याच्यात ठेवायचं ना.
How is the vision down? Is it good?
Vehicle lights.
And how many interested people still there?
Anil sir,
Yes.
Any specific advice you wanted to give us for suturing or compact suturing or better suturing? How one can improvise that suturing?
Keep practicing. Keep practicing.
Keep practicing, yes sir.
That is the only
So
thing.
there is role
Because
of endotrainer is
yes, always there.
Yes.
Always there.
So we are watching you that
Yes.
Sanjay sir is showing that amnion graph.
Yes.
Okay, see.
Yes sir, we are with you sir.
This side is the chorion.
Yeah, placental side, proper. Yeah.
Okay, and this side is the amnion.
Amnion,
Okay.
yes, sir.
Now, first is this will be full of blood. So first we will remove the membranes.
Sir, sorry to interrupt you, but audience wanted to know that what is about that blood group? Is there any?
No.
Is there
See,
any,
what is the no?
Nothing
What
to
is
do with
the
that?
See, the few things about this graft.
Yes, sir.
One thing it is antibacterial.
Yes.
Placenta is antibacterial. More importantly, it is non-immunogenic. The amnion, not the chorion.
Okay, sir.
So there is no reaction to amnion. So that is why God has put it in between the mother and the child, which is this, no? What do you call it? Different blood groups.
Okay.
Different antigenicity.
So no need to even wash and.
Of course, you have to wash.
Okay.
See, you have to be the mother's HIV, HBsAg, whatever, all that has to be done and has to be repeated after 6 months. Because of the window period, but if you put 10 ml of betaine,
Yeah.
okay, in around 200 ml of saline,
Okay.
ह्याच्यात ते पाणी टाकते सलाईन.
So now, once you have taken it out, is it possible to make out which one is chorion side?
Yes.
Yeah.
1 minute, I will explain.
So glistening surface will be amnion
Yeah.
and the rough will be chorion side.
No, yeah. The sticky surface and the rough surface is the chorion side.
Okay, sir. Okay.
And the totally non-sticky surface and the smooth surface
Glistening
is the amnion side.
Yes.
I will show you how to separate it also.
Okay, sir.
See, now I have cleaned it in a betadine solution, right?
Yes,
It is
sir.
not yet completely clean. एक बाल्टी द्या, हे
Sir,
टाकायचं
as
मला.
this seems to be taking a lot of time, can this procedure be done a day prior? Any of the deliveries selected?
See, this can be prepared and kept for 1 week in the fridge.
Yes, sir, that's what.
See, now what is happening is Dr. Hemant Shintre is suturing that skin of the Singapore flap.
Yes, sir, yes, sir.
And I am preparing this amnion. So he is helping me out to save time, no?
Yeah.
एक बाल्टी द्या, म्हणजे हे टाकून द्यायचंय मला आणि नवीन पाणी घ्यायचंय. Now can you see there are 2 layers here? This outer shiny one, it is not sticky, see. My finger is not sticking to it, that is the amnion. And this which has got a little bit of dirt in it, and it is sticking to my finger, it is sticky, that is the chorion. Okay, I don't know if I don't think you'll be able to see it on camera.
Yeah, we could
Those who are in the OT will be able to make out.
Yeah, even we can hear it, see it properly, sir.
Now I will show you how to see if it is not like a ovarian cyst. From the edge you cannot do it. It is totally stuck. So you have to try to scrub it with the ani saline there. Ani saline there. We wash it properly so that all this debris you remove.
Yes, sir. We appreciate that, sir. Both the surfaces nicely.
Okay. Bas, हे टाकून दे. Now I will show you how to separate the amnion from the chorion. Actually what we do is we make 2 molds, because while inserting the amnion is a single layer, right?
Yes.
So while inserting it might tear over that mold. So sometimes what we do, we keep the amnion, the same membrane as it is we keep the amnion on the vagina side and the chorion on the inside, we suture it on the mold.
Mold side.
Yeah, but I want to, because this is a demonstration, I want to do it properly. Give me a forceps. See, this is the chorion side. You just start scrub with your nail only, you start pinching it off. Or with the, actually we should do it with a non-tooth forceps. I can't find a non-tooth forceps on the.
Why you are doing, sir, this?
See, this is the chorion side, no?
Okay.
It is not like a ovarian cyst that from the edge you can remove it. From the center, see, it's coming off. Can you see?
Acha, right.
Can you see it's coming off?
2 layers now.
Yeah, can you see it's coming off?
Yes.
Properly it will come out en masse. You just wait and see. And you will get a single.
So you are taking only amnion for that.
Chorion I'm taking off.
Yes. Means for mold you will be using.
In this case, yes, but sometimes I keep the chorion because it gives you some structural strength to that membrane.
Okay.
This is a single cell, so sometimes it tears off that mold, while inserting the mold, no?
Yes.
Te gaste na te. See, you can see it's just coming off.
Yes, sir.
See, it's coming off just like a ovarian cyst.
Yes, sir.
Can you make out?
Yes, sir. Sir, we'll get.
So once it comes, it has come off like this.
Okay.
This again you wash it.
Sir, is it necessary to put some ampules of ampicillin amount?
What they generally do, see, this is, they use, where they use this is in the eye or in burns.
Yes,
so
sir.
they use some antibiotic and also antifungal and amphotericin B injection, no?
Yeah.
They put that.
In the wash solution.
Yeah, and they put, but here I don't know, it will be difficult to procure in the OT, no? And we are already short of time.
Yes, sir.
So in the vagina, it's okay. I'm just cleaning it with normal saline and betadine. It will become sterile. No virus exists in that betadine. Yeah, right?
Okay.
So once that is done, sister, the mold put hai. So even after removing that, the whole thing, see this, I'm just showing you. See, it's coming off. Once the whole thing comes off,
Yes, sir, the amnion has no antigens, but have you come across any time rejection of the mold or graft?
no. What happens is that you cannot really make out while removing. What we do is after 5 days we remove.
Okay.
We will put this in, this whole mold in, and we'll suture the radial walls together so that it doesn't drop out.
Okay.
And after 5 days we'll remove and we'll make a similar one and we'll put inside.
Okay.
After another 5 days, we just remove it and then use a normal dilator.
Okay.
See now how we have made this mold is, for the structural integrity of this, we have cut this. Can you see inside there is a 10 cc syringe?
Yes, sir.
10 cc syringe is very small for a vagina, right?
Okay.
So over that we have put this sponge which you get in that sofa
Yes.
dukan, you know?
Yes, sir.
That, and we have got not the condom but that probe cover is there, no? It doesn't
Yes,
have
sir.
that slimy gossipol, that oily thing on that.
Yes, sir. Yes, sir.
So it is, ते कुठे आहे ते open करना, ते condom time. ते open करून टाकी ते. So what we do is, see, that is the probe cover, sterile probe cover.
Yes, sir.
Open it. Yeah.
Yes, sir. Typical vaginal probe cover.
So we put it on top of that.
Yeah.
See, this is compressible. Why I am using this and not any other type is because this, if it is hard, no, your Singapore flap will get necrosed.
Okay.
So that is the reason why I am putting this sponge here, you know, and only a 10 ml syringe.
Yeah. Otherwise, there will be pressure necrosis.
Necrosis of that skin flap which we have put, no?
Yes, sir.
Wow, great. Dr. Shintre. See how Dr. Shintre has sutured that. You can't make out that there has been a gap there. Can you see?
Yes, sir. Yes, sir.
Nice. He has done a nice subcuticular, and we have put a Ronson drain, suction drain there.
Yes, sir.
Because we can't give a pressure dressing there, you know. You have to have negative pressure in that wound.
Yes, sir.
This will be removed after 10 days. Skin stitches you don't have to remove.
Yes, sir.
So here you can see this. Now where is that? Now we see that even after removing the whole thing, no, you will find that the chorionic side will be little bit. We will just wash it a bit, you know. And I will take the help of Dr. Nikita Tanvi to suture this with some 20 vicryl or remaining vicryl piece on this.
Yes, sir, you were saying that the chorionic side is a bit rough.
Yeah, it is rough and sticky.
Yes, sir.
So what we do is we put the amniotic side. See, by touching also you will come to know that this side is not sticking. There is no sticky nature to this amnion.
Yes, sir.
Whereas this side, even after it has been stripped, it will have little bit sticky nature because it has got the basal, some basal connective tissue there, you know.
Yes, sir.
So that has to come on the outside of the mold.
So there's a question from the audience, sir.
Yes.
Can a split thickness skin graft of the patient herself be used as a graft?
Absolutely, I have done that also, but in this case, why I have not done it is because it's once this case has been done, no?
Okay.
And we use split thickness with the Humvee knife, you mean, no?
Yes, sir. Yes, sir.
Yeah. So we do use that, but this case is different. This is a redo surgery, one thing.
Okay.
We need 100% result here.
Okay.
And secondly, what is the issue here is that since the rectum has been opened, that split thickness doesn't have blood supply.
Yes, sir.
So this will be ideal for a Singapore graft.
Okay.
That doesn't have a blood supply, and I have used that. What happens is all these grafts, the problem is they will have some hair follicles, you know.
Yes, sir.
So after some time, see, now my case is over. Dr. Tanvi will now just suture this and will just insert the mold.
Okay.
Okay, you got it? This one? In the audience, I'm shifting transmission.
Yes, sir. Sir, just wait. Last question. Sir, for how long you are going to keep this inside vagina?
5 days, I told you.
Okay, and sir, how
After
to take
5
out-
days, see, I'm going to keep this inside and suture the labia so that it doesn't come out.
Okay, so catheter will be kept for 5 days?
Yeah.
Police?
Yeah.
Yeah. And
Catheter will be kept for 10 days because after 5 days I'm going to remove this and make another similar one and put inside. Because this might not hold. We have to give it a double safety.
Okay.
You understand, no?
Yeah, and what will happen? What about that amnion? It will stay there or what?
Yeah, sometimes it stays, sometimes it comes off. But this has got a not only anti-fibrogenic property, it has got a property that prevents fibrosis.
Okay.
So this is.
So we are still watching you. We'll shift to Anil sir's OT. Anil sir, you're on.
Okay.
I don't think we need to.
Sir, it was wonderful suturing. You are very fast in suturing. We have seen you are doing effortless suturing there. Sometimes newcomers take time to that tubal ligation also, and you have finished that case very fast.
I wanted to watch Sanjay, that's why I was trying to finish it off faster, but I think by the time I finish, he will be done.
Sir, we provide that CD for you, sir. This one.
It is so exciting to listen to his commentary only, man. So
Yes,
it would
sir,
have been
yes, sir.
definitely worth watching it. It would have been much more interesting.
Yes, sir.
This is just a reciprocation of whatever we do in open surgery, we are trying to do the same thing.
Yeah,
Yes, mimic in the laparoscopically. So nothing great in this one.
Still, it's treat to watch your suturing. Now the last, wow, you just use that wonderful way of that your Maryland grasper movements. It's treat to watch, sir.
Thank you very much. Since morning, actually, I will say the cases are really wonderful. There are really significant number of take-home messages from each and every case for all of us. Even when the other case of vaginoplasty, we couldn't do it. Even that was telling when to stop it.
Yes, sir,
and when
exactly.
not to go ahead with the things, whatever you have planned.
Yes, sir. It was Haris sir who wonderfully used his mind in time not to do anything.
Yeah.
Otherwise, yeah, definitely we will end up in some complications more.
Yep.
So now you are going to check once and that's it.
I feel the mucosa is spouting over here a bit, so I might think of taking one more. If there is any leak, I will try to go for.
But sir, leak even it is not compulsory to take the sutures.
No, it's not. Provided I'm getting the good flow down.
Yeah.
Okay, fine. The khali.
So it seems that you have maintained almost 4 centimeter length after post tubal reanastomosis.
I think it is much more than that.
Yeah, it's more than minimum 4 is there.
Yes. So Dr. Jyoti was asking about how much is the minimal length. The distal functional parts. The distal segment itself is far more than 5 centimeters here.
Yes, sir.
So whoever has done tubal ligation, he or she has done really good job and could get a good opportunity to
So can we suggest that whenever we do tubal ligation,
Yes.
that extra knot, what for safety knot we place below that one knot should not be taken?
I will say the least possible thing is best, because on one side we want the least possible, but on other side we don't want failures also. So if it fails, it is much more disastrous than if if we are not able to do reversal.
Yes, sir. People
Okay, go
says
ahead.
that only
Yeah.
the primary surgeon thinks that I should do correctly, otherwise he will face lot of social issues.
So
with
on
that.
this side we can see the dye coming out nicely.
Wonderful, sir.
Okay, push. And let us see on this side and on
Filled
this
up.
side also.
Wonderful
Yes.
job, sir. Wonderful job.
Okay.
Great,
Thank you very
sir.
much. Thank you very much.
Thank you, sir. Thanks a lot.
पातळ निघायचा. Okay.
Grasper. So in this case, we have used only 3 ports, one 10 mm for telescope, another one, other 2 5 mm trocars. So with these 3 trocars, we could manage this one. Always keep a watch on the needle when you are pulling it back. Once it is in the trocar, then only pull the whole of the trocar and hand it over to assistant. On many occasions, we have lost the needle because it is so small. Recently, it got sucked into the suction machine and went all the way into the suction bottle. Hello? Am I there? Am I audible?
Yes, yes.
Okay.
Yes.
So that's why keep a watch on the needle till end. So the only instruction for this lady will be contraception for next 2 to 3 months. After that, they can start trying for pregnancy. If at all they want to go ahead with HSG, it will be a good idea. But a negative HSG shouldn't warrant that it is failed.
Yes, many a times we always see HSG done in awake patients.
Yes.
Because of the painful situation, we do get spasm of the tubes and they come out with blocks in fallopian tubes which never look out on endoscopy.
Yeah, true, agree. Cutter लागेल मला जरा.
Anil sir,
Yes.
what will be the better investigation? Whether it will be HSG or just a sonosalpingography to confirm our surgery after 2 to 3 months?
Sonosalpingography, I haven't done much, not much experience, but yes, whatever is least painful for the lady, we should go ahead with that. That is one. But only other thing is if a negative or the HSG is not showing any patency, it shouldn't be like the tubes are not patent. That is the only precaution or instruction we should tell.
Okay, sir.
I'll just remove these things. सिस्टर केबल जोडल्या काय कटर दे कॉटरी ऑन करा हे जरा कशाला जोडले सील बरं ठीक आहे हे मला वर देता जरा फुट स्विच थँक्यू दुसरा आणि काय नाही आहे ना हे एकच आहे
Do you think it is necessary to get rid of all these para-ovarian cysts?
I feel so because I have seen at least 2 isolated tubal torsions only because of the para-ovarian cyst, nothing else.
Okay.
And that is the reason why I feel dermoid, even if it is smaller, and para-ovarian, whatever small it is, we should remove it.
Okay. That was unheard of and a good take-home message as well.
Yeah, because it is like one was the pediatrician herself,
Okay.
and it was the first tubal, isolated tubal torsion which I did, and the finding was like it was because of the Caesar there, parafemoral cyst, paratubal cyst.
If at all these patients do not conceive, maybe within say 6 months or 1 year time.
Yep. I think she is young, this lady, specifically this patient.
Yes.
1 year's time should be sufficient enough for trial, and then if she doesn't conceive, then I think she should consult a fertility expert then.
Yeah, okay.
Okay. I thank the whole of the anesthesia team and OT people for helping us for the success of this workshop.
It's your efforts as well to get all the faculties.
They are friends, man. They are friends of everyone. So only, I think I was little doubtful for what Vivek in the last evening when he said I am yet to finish with the last case. So I was thinking whether I should tax him with the additional efforts to come all the way with the overnight traveling, but it was worth asking him to come down because we could see such a wonderful surgery.
Yeah.
Thank you.
Absolutely.
Thank you very much
Thank you
once
so much.
again.
Yeah.
Thank you, anesthetists. Thanks. Kashala? Oh, ithilon na gaya kya? Sorry.
Yes, Sanjay sir, you were saying something?
चलो ते नंतर काढा
हरेश वजवदन
इथिलॉन 20 हे काढाल
केस फायर झाली पटकनच संपलं आता एवढं सगळं काम केलं तरी दिवसभर तरी चालायलाच कॉम्प्लिकेटेड सर्जरीज होतात त्यामुळे एव्हरीबडी कॅन डू
पाय लागणार आहे. लावून ठेव.
Hello. 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 Who is there in hall? सगळे गेले की काय? Hello.
Hello.
Hi, hello. Yes.
Sir.
Patient is about to induce myomectomy.
But what is the history?
Yeah, sir. History is he's having sir 7 to 8 centimeter anterior wall myoma.
That is a finding. History, what is history?
Sir, just a minute.
अभी उसका एनर्जी गया सीधा सर मायोमा दिख रहा है मुझे, एकदम अर्जुन बन गया तू.
अभी नहीं सर.
मुझे मछली की आंख दिख रही है, पंछी की आंख.
अभी
कौन सा पंछी है पता नहीं सर, आंख दिख रही है, सिर्फ आंख.
सर
अभी मैं भेजूंगा उसे.
बात तो सही है सर, टारगेट जो भी है वो पता होना चाहिए.
पेड़ कौन सा है, पंछी कौन सा है,
अभी बताता हूँ सर. 2
कौन से मैदान में पेड़ खड़ा है वो सब बताओ.
यस सर. Sir, Harish sir, we are having 2 cases right now. One is diagnostic hysteroscopy in another OT, and in this current OT, that case for myomectomy, and she is 36-year-old female. She's para 1, death 1, and abortion 2 with previous 1 scar, and now she is having abnormal uterine bleeding, and we have posted for myomectomy, laparoscopic myomectomy.
Okay.
Hello.
शिर्डीची पण केली होती. महाबळेश्वरची 2021
शोधून बघतो. आणि तरी पण किती sambil begini. Patient सकता है उसमें पैसे. Part of this, yeah. अजून आमच्याकडे 6 केसेस आहेत. या ह्याच्यासाठी वॅक्सिनचे 6 केसेस. आत्ताच सगळे गळून गेले. सगळे पेशंट पहिला मेसेज 3 वाजून 53 मिनिटांमध्ये तिथं त्याचे कॉन्स्टंट मेसेज टाकतो. दुसऱ्यांना जरा असं तरी सगळ्यांना तरी किती 6-7 झालं 8-9 झालं. भारतामध्ये सगळ्याच बाकी पण त्या दोघांनी मुंबईच्या लोकांनी पण हेच केलं. That was real evil. जरा reputation झालं ते. छानच ठरला. काही एखादी केस फाडायची आपण काय मागच्या संडेला ही फेल झाली होती. मला सुरुचीचा फोन आला की कॅन्डिडेटला पास करायचं येणार का. हे कसलं बोलवणं झालं. मी एक्झाम घ्यायला चालू केली. आता एक्झाम तर घ्यायला पाहिजे. एक्झाम घ्यायला चालू मला तरी मॅडम म्हटल्या एक्झाम घेतली आहे आता एक्झाम नको घ्यायला.
मला म्हटले मी जाणार आहे काय बोलले नाही बट ही इज लिटल सायकॅट्रिस्ट आमच्या वेळेस आणि आमच्या वेळेस Sorry for this, please, there is
नाही annual चेंजेस पण झाले ना. Annual बरेचसे चेंजेस पण झाले ना.
आणि फारच ग्लिच झालं.
हे सगळं चांगलं झालं की नाही बस. म्हणूनच म्हटलं की मला काय आहे का फक्त पाण्याची बाटला पाण्याची भांडची असेल तर पाठवची मला काही लागली हा युनिव्हर्सल आहे हा गोल्ड स्टँडर्ड आहे.
जरा स्पिरिट टाका पोटावर. Hello.
Yes, yes, Vikas, you can go ahead.
Yes, sir. Now, patient has been induced. We are doing draping. Painting has been done.
Yes.
This is a case of myomectomy, and she's P1 D1. So we have planned to do hysteroscopy first as a rule, and any myomectomy without hysteroscopy should not be proceeded. And so I'm getting my hysteroscope ready for the same. Till that.
इसने फोल्ड किया.
Yes, sir.
वाह भाई वाह.
Yes, sir.
मजा आ गया.
अरे सर.
देवकारी सर.
यस सर प्लीज. आप कुछ तो बोल रहे हैं, मेरे को सुनाई नहीं दिया.
नहीं आपको नहीं बोला. अभी हम लोग थोड़ा कॉफी पी लेते हैं आपका मायोमेक्टोमी देखने के पहले.
ओके सर.
आपको चाहिए क्या?
सर अभी नहीं सर, बाद में. सर आई एम डूइंग दैट हिस्ट्रोस्कोपी पार्ट फर्स्ट.
Okay.
Yes, sir.
So why do you want to do hysteroscopy first?
Sir, first thing, as we are doing myomectomy and she's P1 D1 and she's willing for further conception, and I wanted to rule out any pathology, specifically any submucosal fibroid or any fibroid indenting inside the endometrial canal.
So can you please tell me one of the relative contraindication in the fibroid uterus wherein you will not do hysteroscopy?
Contraindication?
With fibroid uterus.
With fibroid uterus? No, sir, I don't know, sir.
So if the uterus is more than 12 centimeter size,
yes, sir,
and if there are cervical fibroids,
okay,
then you should not attempt hysteroscopically very enthusiastically. Otherwise, you will have something called as broken telescope condition.
Acha, right, sir. Yeah.
You will lose your 2 lakh rupees instantly.
Thank you, sir. Thank you. I was not knowing what the contraindication, and you saved
this
my
is not. This is not from book.
Yes,
this is a personal experience. I'm telling you.
Sir.
And that too from the person. It was the case posted at a person who is such a miser in paying that not even our travel cost was covered.
Oh my
God. So this I will remember lifetime.
And these are the pearls of wisdom.
Actually, Bataki had told me that Harish never do 12 centimeter plus uterus hysteroscopy because your hysteroscope will not reach to the cornua.
Okay.
So then I asked him rhetorical question that what to do if she has pathology.
Okay.
So he said, do it after 2 months. Her uterus is going to be there. It will not go away. But your scope goes away, you can't do any hysteroscopy.
So that's
the
ऍक्टिव्ह तिथे ऍक्टिव्ह दिसते ते ना. इकडे माझ्याकडे फिर बस झालं. परत एकदा ऍक्टिव्ह कर. 30 to 60 कर. कॅमेरा ऑन नाही सुयश. कॅमेरा ऑन कर. माहिती का तुला?
You can fight a case. You cannot give a verdict. Verdict is not in your hand.
Sir, what you always do, sir, that you enter with that your operative scope.
Okay.
Sir, here I'm putting diagnostic scope only.
Diagnostic scope is obsolete.
Yes,
So
sir.
you can perform hysteroscopy with this scope anytime, no problem, no contraindication.
Yes, sir. Yes, sir. Do you have internal picture there, sir?
Yes, we have.
Yeah. Can I get white piece just to have the white balance? Yeah, I need water, please. Yeah. चला दे तिकडे. हे दे तिकडे, हे swish. Just a moment. I think the scope is not that good, but fine. Can please पानी start करेगा कोई? वास्तुप्रश्न घेऊन ठेवा त्याच्यात. असं असेल तर yes please, yes.
डायबिटिक है वो बेचारा.
So as you can see, I'm doing vaginoscopy first, and you already explained everything in the morning. Pani. So this is not buttock sheath, but I'm using 2.9 mm hysteroscope here. So hopefully in front of the Indian buttock, I entered now without touching any structures into the cervical canal.
Wow, amazing.
Into the endometrial canal.
So this is stromal edema. If you can focus one place, I will tell you.
Yes, sir. This
So
is
this
stromal
red
edema.
patches you see is a stromal edema.
Yes, sir.
Okay, and if you see there is some, I don't know, the cavity looks very small.
No,
Short, in
sir.
fact. No, it's
Pressure
normal?
is not good, sir.
Oh, okay, it's a retroverted retroflex
Yes, sir.
cavity. Yeah,
Now
okay.
see here, sir. So this is
So
the.
this distortion is not dysmorphism, it
Yes,
is
sir,
because
yes,
of the
sir.
fibroids.
And now we can see the
Yeah.
nice endometrial cavity, sir.
Yes, so there are lateral fibrosis slightly,
Yes, sir.
and of course there is a fundal small dilator injury also.
Yes, sir. But this
could
is
be
not
because
done
of
by
the-
me.
No, it is because
Yes,
of the
sir.
previous surgery.
Yes, sir. Yes.
So what you can do is, if you have operative.
Sir, I think, sir, what we were that is uterine niche, sir.
This is a niche, yeah, niche.
Yeah, uterine niche.
And that's why this is inflammatory endometrium.
Yes, sir. Correct, sir.
So inflammatory endometrium is one of the reason that you can have implantation there.
Yes, sir. Yes, sir. And you may land up into that.
So this patient
Hysteroscopic.
requires post surgery after 2 months operative hysteroscopy properly.
Yes, sir. Correct, sir.
Okay.
Yeah. Yes, sir. So Aditya is going to assist me from vaginal end. He is putting vaginal, this one, the uterine manipulator. We use that simple V manipulator for the this one manipulation. And on
Where is the myoma? Which wall?
Sir, anterior wall.
Then you can do it without manipulation also, no?
Yes, sir, but I wanted to do that uterine artery ligation, temporary ligation at its origin, as this was demand from this one my all colleagues, and secondly, I also wanted to be on safer side, not to have any kind of bleed during surgery.
कौन है?
Bleed.
सब कली फूल बन चुकी
त्याला हेल्प करा कोणीतरी जरा. बंद करून मग टाका. Anterior टाकू.
कली ग सब फूल बन चुके हैं. कली ग क्या?
थांब एक मिनिट थांब.
ती बोला उसने फिर आदित्य.
खालचं काढ.
कौन?
ठीक. एवढं ब्लिडिंग का व्हायला लागलं?
परफोरेट हो गया वो.
किसको बोला आपने?
डायरेक्ट होकर.
Yes, sir. I always take the director. Can anyone focus on it? So this is the way one should hold the trocar. So just outstretch your hands like this, fingers like this.
Okay.
This should be pointing or the guarding you.
Okay.
And I am trying to maximize my.
Yeah, okay, so that much only, yes.
Yeah, and this should not hit you also.
Yes,
it should be
yes,
always away from you.
right.
So now see
And
that.
the patient is Paris, so generally her
Yes,
teeth
sir.
is not very.
And now what I'm doing, I'm going straight till the rectus sheath. So once I'm hinging my trocars, the distal end to the rectus sheath. Now I'm lifting up the whole abdominal wall, and I'm giving more and more rotatory force rather than the direct stab injury. Okay, so I wanted to crush the rectus sheath, then subsequently muscle and the peritoneum. So crush injury is the word where we will enter without any this one difficulty. So I mean, you can see the nice beautiful momentum, and I'm about to start the gas, please. Head low, anesthetist head low, please. Once again, I thank all the anesthetists
on the holiday, they gave for academics and helped us a lot. So sincere thanks from whole gynec department to all the members of anesthesia department of GMC. So again, I have a lot of additions. Yeah, okay. So gas, please. See, sir, I have, so what entry, sir, you always take that intraumbilical. Here I have gone, sir, almost 2 finger widths above the umbilicus. Still I face this kind of adhesions. So what is your view on that, sir?
On what?
So trocar entry.
No, direct trocar, you want to say?
Sir, you take intraumbilical entry, that is all varies or whatever.
So for example, like suppose if the fibroid uterus is there, then what I generally do is I go 5 millimeter intraumbilical. Okay, it is my inspectory or a surveillance trocar entry.
Just wait. Just wait. Yes, sir.
Yeah, okay. So I put first primary intraumbilical.
Yes, sir.
And that's my inspectory port or a surveillance port.
Okay.
And then I put primary port depending upon how much the uterus is propelling with the manipulator.
Yes, sir. That is my side, sir, actually. Sir, how is the vision in the auditorium?
The vision is good. Camera is not clean. The distal end of the lens, now it is better.
Yes, sir. I'm just going to. I'm not getting any kind of Savlon to clean the camera. I'm more comfortable with Savlon rather than Betadine or any NS kind of things.
Okay.
So I'm taking, sir, 3 ports, 2 on my port and 1 on my assistant port. These 2 apple trocar will be on my side and 1 metallic trocar with the gas releasing wall on the opposite side. So first I will say take out that adhesions. Clean gas पर असेल तर द्या एक मला. And now I'm little comfortable with the vision, sir, in the auditorium. So in the morning, I think Rohit was asking if I hold this tissue and little give traction. So it is always helpful. Footpad, please. So see here, sir, I can see that this is abdominal wall and I can't go here. This is omentum, I can't go here. So this is the correct plane where I need to enter. So see, this one is the cotton setting check karaida. Is it 5, C5?
So if I give you a tip to use a bisector.
Yes, sir.
So when you are cutting it, don't pull it out. Okay.
Okay.
What that? So you're giving that small jerk. No, don't give that.
Okay.
Just
like a harmonic.
No. When you are about to press, that time activate. Activate now.
Okay.
No, so activate at the time of pressure.
So now
give full pressure like a Caesar and activate. Yeah. Leave it now. No, it's not cutting that way. Means.
So little tug.
Which generator are you using?
Sir, Allen generator.
Allen generator.
Yes, sir.
No, that doesn't matter.
Okay, sir.
No, what they are saying is that the instrument is not Allen's, but that doesn't matter. The generator has a special current.
Yes, sir.
Which cuts without giving, that jerk.
Okay. Hi, sir, it is that I know that instrument, sir, where the blades are little bit thicker than this.
No, it's not like that. It is the same generator, same instinct. It's about the usage that you do, but maybe sometime fibrotic, so that way.
Sir, this sometimes happens, sir. Definitely it happens sometimes.
Yes, sometimes it's fibrotic, you have to give traction. There is no...
Okay. Got it, sir, yeah. So thanks for adding so many things.
So how do you identify bowel if it is coming or no in this
Sir, I think
jungle?
It's experience and the typical look of that bowel.
Experience of what?
Experience of seeing the bladder and seeing that omentum and this one
But sometimes bowel is very mischievously hidden.
Yes, sir.
Jungle.
That we have to be very careful and
so posteriorly you should see sometime.
Like that, yeah, perfect.
Yes, sir, yeah.
So while cutting, you can see the peripheral area.
Yeah,
There
yeah.
is a pinkish tissue that is seen,
Yeah,
then you should
pink
be,
tissue means always small
yeah, so
bowel.
you
that,
should
yeah.
check whether it is.
Yeah.
So in the morning when you said fat belongs to bladder,
Yes, sir.
actually that statement of Dr. Puntamekar is half complete.
Okay, sir.
So I would only use, only add one word into that
Yes, sir.
called only.
Okay.
Fat
Acha,
belongs
acha.
to bladder only? No, it doesn't only belong to bladder.
Yes, sir. Yes, sir.
It belongs to many. And another
yes.
thing is that fat is not bladder.
Yes, sir.
So you can sometime, in very difficult cases, cut some fat.
Yes, sir.
Like you did in the ventrifix case, some fat was there on the uterus.
Yes, sir. Yes, sir. Yes, sir.
So fat belongs to bladder, but it's not bladder.
Yes, sir. Now again, it's gift for me in the last case that so many adhesions and that whole complete curtain-like things in front of me. So, sir, while using harmonic, sir, you don't give any kind of traction with the right hand in this case. See that, RS sir, you are with me.
वो लगता था पोस्टर इंग्लिश पिक्चर उसमें एकदम ऐसा अपने को लगा ये आएगा कभी तो सीन ये सीन वो सीन
Manipulate कर जरा and so it is not, it's quite well seen. जरा sorry, put जरा sir. Now I'm just praying it should not be adenomyoma for the last case. Yeah, it's an anterior myoma and doesn't seems to be this one adenomyoma. What do you think, sir? Hold this.
Mostly it should be clear on ultrasound because
Sir, they have done MRI also. MRI findings also suggested that it's a myoma only.
then it should be myoma hopefully.
Okay. I'm just reflecting all the small bowel. Here we have taken pressure of, so just increase the pressure please to 16. 16 is it? Okay.
The fluid has come from hysteroscopy. That means tubes are patent.
Tubes are patent, yes sir. So
If you have to check a tube, when will you do it?
Sir, very
After myomectomy or before?
No, before myomectomy. Never after myomectomy.
नहीं करना है ना?
Huh?
No, nothing. Somebody
Yeah.
is asking me, are we testing the tube?
No,
No. She's conceiving.
Yeah. So now I already entered in the retroperitoneum. You can see that, and I'll just take out this. I think our sigmoid colon is so much.
मेरे हाथ में hammer है.
Yeah, it's completely loaded with the. Either it has a puppet, please. Yeah. So now I will try to stay here. So there are two approaches to. Now I'll tell the plan of my surgery. I'm going to ligate uterine at its origin, temporary ligation by shoelace technique, and then I will be performing myomectomy. And after my surgery is finished, I will take out that knot. So while doing that uterine at its origin, my assistant should hold this. So as soon as I entered that retroperitoneum, you can see something is there, first structure is exposed. So this is nothing but psoas major muscle, and as my little bit crossing of my instrument, so I will change the direction, this one ports, and now I'm proceeding in my left hand, it's a plain grasper, please traction. So there are two ways to encounter the vessel. One is endometriotic approach and another is oncological approach. So the endometriotic approach, also called as medial approach, and this one oncological approach, also called as the lateral approach. So now I am doing all this case by lateral approach or this one oncological approach. खाली उड़ जा रहा, खाली उड़. So now, as soon as you can see, as I entered, gas has entered, and I can see the impression of external iliac vasculature system. So this must be external iliac artery. As soon as I go down, I will be exposed to external iliac vein, and this is what the blood vessel was just bleeding. It was the posterior lip of broad ligament. So I would like to go little high up so that I can see the, yes, I was expecting that ureter to enter into the pelvis here, and as again Tuntambekar sir used to say repeatedly something called as predictive anatomy.
Yes.
So yes, so I was predicting external iliac vascular system there, and it was there. I was expecting ureter there. Yes, ureter is there. So now here this is the ureter for postgraduates and newcomers. Ureter should not be only identified by its peristaltic movements. So there are so many ways. So first thing is that if you see, ureter always follow the posterior peritoneum. So if you can see that, it is posterior peritoneum. Okay. Secondly, it's a typical vascular blood supply. So see that all around that, what we can say, the blood vessel is typical of that one. And one vein that will be always going along with the ureter. Now I will just show that. Can you see this on the lateral aspect of the ureter? Just below this sheath. जरा ureterला तुझ्याकडे ओढतोस का असं थोडस yeah. And now can you see this vessel? So this vessel will be continued till its entry into the bladder. So this, as soon as I go on, see the
There's a mesoureter.
mesoureter, yes. And whenever you see any this one tubular structure in the body, I think it's a double ureter or what? Just wait.
Yeah, it is the.
Yeah, it's a double ureter. Yeah. So this one, yeah, this one. These are the two ureters. So
hopefully there are not two uterines, huh?
Wait, sir, wait. Don't scare me.
Why should I scare you? Yeah, you are such a brave heart.
No, sir. So you see that one vessel is there, which is going along with the ureter. And what I wanted to say that, see that I should not dissect like this. I should be parallel to the vessel. Yes, any tubular structure. So you will not encounter any kind of bleeding. So now I am, see, if you see this is posterior peritoneum, and this must be the bowel loops. Okay. So I am just retracting that bowel loops, maybe the rectum. And I am now going little bit lateral to the ureter. As soon as I go down till some point, my movement will be restricted. Can you see this? My movements are restricted here. So here I am expecting, now I was in pararectal space. As soon as I entered here, I am expecting uterine artery here. So can you see this? There is something. So there is impression of uterine artery, yet I am not confirmed, but I am sure it must be the uterine artery. So now, as soon as I have seen that external iliac vascular system, specifically the vein, one should not this one play with the external iliac vascular system. And as soon as that common iliac gives two branches, one will go laterally towards the leg, that is external iliac, and at sacroiliac articulation that they divide into two. One is anterior trunk of internal iliac and another is external iliac. So as soon as we go down along the root course of the internal iliac, it gives first tortuous branch, but as textbook has shown that directly perpendicular vessel, it always transverses little length parallel to the external internal iliac, and then it courses towards the medial aspect.
Yes.
So I am holding uterine artery in my right hand grasper,
Very nice.
and I am retracting internal iliac's obliterated part on the lateral aspect. So here I am expecting the impression of internal obliterated umbilical, and this is just median fibers. I will just cut it and get rid of the suture material. I wanted to ligate it. So this is, see that what I was telling is little bit, though artery has started from somewhere here, but it has traveled little parallel to the internal iliac, and then it has courses toward the middle aspect. So I am just holding this vessel, and with the divergent force of my grasper, I am just, can you see this? This is vesical vessel. Vesical vessel. So it is supplying the bladder. I have made nice window here. I will take the suture material. केलेत कशाला बसलाय कट करायचं चांगलं थोडं ओपन करून ठेवा.
So are you going to clip it? You going to do what?
Sir, I don't have, in the morning only told I am Garib gynecologist. I don't have clip. I will use the routine suture material, Vicryl #1, and I will take that shoelace.
You take a free hand or you take with needle?
So no, sir, free hand, sir. Already, sir, I am made window now, so there is no need of suture, this one. So I will just see, in the morning also I told, I always like to use 2 needle
And you
holder.
going to remove this in the end?
Yeah, yes, sir, that shoelace not, sir.
Okay. So you do it in all myomectomies?
No, sir, this is for demonstration purpose with the keeping safety of the patient, that's nothing else, sir. So now if you see this, I will notice that I was holding that uterine artery with the needle holder.
Yes.
So don't worry that, so audience and the newcomers, no need to scare of uterine artery while holding this one. So now I will take 1 throw, 2 throw, and little I want this, please. This kind of thing.
You going to do both uterine artery ligation?
Sir, you tell me what to do. I will do that, sir.
No, this side you shown this retroperitoneal type, no? Other side, can you show?
Sir, I am not showing the shoelace not here. Already I have crossed that part, so I will just cut at the end, and the opposite side I will show you this one. Okay, we are little bit.
No, other side, can you show that anterior or posterior uterine?
So I am not getting anterior posterior uterine.
So broad ligament dissection and then, doing the, that's shoelace now. You can just cut that.
Yes, sir. I will do that later on, sir. Scissor, please. Uterus आता यावरला lift करशील जरा, sir. So I will cut that once I finish my myomectomy. Then a spinal needle ready ठेवा. I want spinal needle. Sir, you remember, and in one of the conference we met, and you told me that spinal needle works well for vasopressin injection. Since then, I am using, sir, only this one. What we can say, yes.
Dr. Vikas?
Yes, please.
I'm Dr. Neha. We can see that the bowel, the bipolar touch the bowel at one place. Will you be doing anything?
No, not
Where
at
the thread is?
Thread I have just kept there only.
No, there is the bipolar touch the bowel there. There
This
is a
one,
white
na?
color, yes. Will you be doing anything to it?
No, not at all, ma'am.
Okay, nothing will happen?
Nothing will happen. See that now I am holding, again I am going to the pelvic triangle, and I will just lift up the things, and I will go parallel to the infundibulum pelvic ligament.
No, not from there. So what I was saying is to go. Okay. You want uterus antibody, not there also, because she has cesarean scar, no? So the uterine will be slightly difficult to get there.
Yes, sir.
You can get in the ovarian fossa.
So you mean to say go from here?
Yeah, lift up the ovary or towards the round ligament. Yes, ask the assistant to hold that, and the camera can go there.
Sir, I think little bit bowels are coming in my way. I am not going to
try. No, at least just see.
Sir,
if it is seen.
Sir, though antiversion is not completely happening here.
Yes, agreed. Just see, no. Someday you have to do something new.
But not now, sir.
Go inside. Not now, but just see at least.
So now again, there must be some queries why you are holding that bowel with the needle holder. So don't worry.
You can hold.
Yeah.
There is no problem.
I am holding that yellow part only, which is very, very
and again, the cat holds their
exactly,
mouse
sir.
also,
Yes,
and
exactly.
the kittens also with the same sharp teeth.
Yes, sir. Yes. Sir.
But the kittens don't get injured.
Yes, sir. Yes.
And the mouse gets torn apart. So
Okay,
so go there inside. Camera go inside. Camera go inside.
Sir, but,
go inside.
Sir, there will be difficulty in.
I agree. I'm not telling you to do it. Just see the feasibility.
Yes, sir. Yes, it's quite possible, sir.
Yeah. So there where the ureter is going in, if you dissect that window, you will get. This is the posterior technique.
Completely.
And then there is an anterior technique which you are supposed to go there. You can go ahead with the lateral one, or you can just skip it. We have seen on the other side.
Okay, sir. I will skip it, and I will go with the vasopressin injection.
We've got some lovely coffee here.
Great, sir. Great. So, can you see this, sir? What your method only? External picture, please. So, this is spinal needle number 22. I guess I am taking only 10 cc syringe. 20 cc will not work. And I will go straight onto the this one, just above the bladder. Don't antivert it, just straight toward. And see here, very little fat is there. So 1 point entry will be sufficient. I will try to stay at one place only.
and bevel end has gone in. I have seen the pulse of the patient. I informed my anesthetist. I am going to inject the vasopressin. Dose is 1 ampoule in 200 ml of NS. So I will push just I see I have nicely aspirated it. If you can see in my external camera, so nothing else came in this one after aspiration, and then I am starting my injection. So I am facing little bit difficulty. So I will just take out little bit needle upside and I will reinsert. Again I will aspirate. Yes, sir. And then only I will inject. So now it is smoothly going in. Most probably I must have gone into the myoma in first attempt. Little bit difficulty. Just maintain the traction over the uterus, please. Let over the uterus little bit. Maintain the traction. So every time I came out, again I have to aspirate, and now you can see the nice blanching there happening. Okay, so the 10 cc has gone in. I am waiting for anesthetist to say yes, you can proceed, because there is no change in pulse, there is no tachycardia, no bradycardia. So this is take home message for everyone sitting inside the hall, or there are almost 20 people are inside the OT. So don't, I don't know what to say that, but don't inject vasopressin haphazardly and without this one aspirating anything. Okay, so we can see the nice blanching has been happening at the uterine level. Also the ligation of unilateral uterine must have worked. So sir, how much to inject vasopressin? So this is enough, or you want me
So
to?
I generally use, up to 5-6 centimeter myoma. I use only 4 unit.
So
and I never go directly like that. I give 0.5 unit, that is 5 cc of the diluted one, and then wait for the reaction on the on the monitor, because sometime anaphylaxis can occur.
Yeah, actually what happens, I tell you, sir, I want effect not at the incision on the this uterine wall. I want the effect of that vasopressin to happen when I take out the myoma at the base level. So it is, I personally feel I just injected 20 cc, 2 units, so I will go with little more, and I will choose little the fundal site, or the, please. So I will go somewhere here.
Hello, Vikas.
Yes, sir.
Is it okay if I leave?
Sir, there is one gift I have kept in my car for you.
That's all right. I'll call you up later.
Yes, sir. Please, sir. Thanks a lot,
Okay,
sir.
thank you. Thanks a lot.
Yeah. Harish, sir, what do you think? I still in one of my this one 6 inch saying it's not myoma but adenomyoma.
It is adenomyoma.
Exactly, sir.
It would not be so much blanched otherwise.
Yes, sir, exactly. Only 10 cc and it has given so much. So, but sir, what consent I have taken that if it is adenomyoma, I will take the biopsy only and I will come out. So, what I will do, sir, in the central
But
part.
how will you benefit the patient then?
Yes, sir, I know that, but I will take out at least this part.
So you open like a vertical incision and scoop out some tissue, no?
Yes, sir, yes,
and
sir.
then like suppose a very a fibroid where there is no plane, how do you do that? Something like that. So you give a vertical or a transverse incision
Yes,
and
sir.
scoop out some tissue.
So you mean to say vertical or elliptical, sir? I think it must be elliptical.
I mean you are giving transverse, no, because you are ipsilateral. So you can give a transverse incision and scoop out.
So I'm little bit going, sir, on the fundal aspect of this one and the posterior aspect. I'm again injecting little vasopressin. Please check the pulse. माइक थोडासा हल्लाय कुणीतरी सरळ करा कानावरती आलाय. So today luck is not with me. Since last 5 days I was saying it should not turn out to be a adenomyoma, and finally it came that adenomyoma only. Yeah, comfortable. So I will do, sir, I am scissor person. I know you don't like scissors, and but still I will go with scissor only. मला एक टिराकुलम किंवा हा ग्रास पर द्या, टूथ ग्रास पर द्या प्लीज. सुरेश एक टूथ ग्रास पर देशील मला प्लीज. ट्रोकर बाहेर आला बोलतो. फाईन, आला चल. So sir, what I am planning, so you mean to say I should take out like this? Harish sir.
Yes, sir.
So complete this portion, I'm going to take it out.
But don't take circular incision. It will be very difficult for you to.
So
because there is no. Take just a horizontal incision first,
okay.
and then scoop out. What I think is, so you just give a cut like that. Because see, you have a outer myometrium much better.
Incision is not that.
Give much
important.
deeper now.
Yeah.
It is adenomyosis.
Yeah,
okay?
it is adenomyosis. Yes,
See that?
Yes, exactly. It is adenomyosis.
I don't know how MRI also missed it.
अभी कुछ बोल नहीं सकते सर अभी मैं
No, you must learn to read your own MRI.
Yes, sir. But the consent is like that I should take only biopsy and but
no, it's not like that. So suppose you are doing a patient is already having a very bad luck. Okay, she is sectioned, having no living children. So don't do elliptical like that. No.
Okay.
What I'm saying is go cut inside only. Outer myometrium you don't cut. Yes, cut that way. Yes.
Yes, sir.
Now you see you're getting slight plane there, little.
Yes, sir. But sir, how long we should go deep? That is the main issue.
You go little bit at least.
Sir, I remember one case at JJ. I was operating in live workshop.
Okay.
At that time, they given me one myomectomy, and it came out to be a ACUM, accessory cavity uterine mass.
ACUM,
This conference, the HOD has allotted me.
So
this.
first you do one thing. You remove this much chip first.
Okay.
What is there in your hand? Don't try to dig too much.
Okay.
So go chip by chip. Yeah. Like how you do myoma resection.
Yeah.
So we do adenomyoma resection like that. So you go cut it deeper. Yeah. Similarly, then you go on the upper part, the fundal part.
Yes, sir.
So you see you're debulking it. Okay.
Yes, sir. Got it, sir.
And this is adenomyosis.
Yes.
Meiosis hai. It is
और मेरे को
adenomyosis.
in the
No, but it is only on anterior wall.
someone
So
just
you'll have a
keep
good response after
count
this,
of
you know.
that one. So one.
See, you'll have fantastic response once you debulk a little bit. At least 50-70% of the disease also if you reduce, then with one GnRH it will go much down and she can conceive here.
Yes, sir.
So you will add to good luck of her, you know. But that's it. Now you give vertical cut to the part which is transverse. I mean to say transverse cut. Slightly inside. No. In the center. In the center.
In the center, yeah.
See, yes. And then you may, the upper wedge you remove again.
So
The wedge which you created now, give slightly deeper from your end.
Yes, sir.
That's it. Now go to your end and then go further deep. Yes.
And,
so now what wedge you created on the top, remove that, and there is a small wedge you see below, and that's it. Then you suture it.
Yes, sir.
Yeah. So there are two wedges now.
Yes, sir.
So this upper wedge you remove, then
sir,
this.
chances of opening the endometrial canal here in this case particularly.
You don't worry about that. You just do good things and think of good things. That's it. If you give a good, I'm telling you, you have a good intention, no? There is somebody sitting on the top.
Yes, sir.
But if you try to escape, nothing good will happen to her, believe me.
Yes, sir.
If not Devkare, who will be her savior?
Arre, sir.
You got it?
Yes, sir. It is nicely coming, sir. And
yeah, it will come. I'm telling you. And see the upper myometrium, so regular. What you have left, you see. Observe that upper myometrium, which you cut with the scissor first.
Yes, sir.
I would suggest to remove this screw and take a tenaculum and hold this edge.
Sir, I have
remove the screw.
Yeah, one tenaculum only we are having right now.
Okay.
One more tenaculum I have zara. Needle holder नहीं sir, I will use the needle holder for that.
Or to put a tooth grasper, no?
Yes, sir. Yes, sir. I have given tenaculum to him. I am using the tooth grasper, sir.
Yeah. Okay.
Yeah. So now this second, third, this one wedge I am cutting.
Center. The assistant hold center.
Idhar pakdi.
Let him hold first. Let him hold. Vertical bite.
Yes, sir. Yes.
Like that. Like that.
Yes, sir.
And pull it. Very good. Now remove that upper edge. Upper wedge. That wedge. And then you have one lower wedge. That's it. So you will not open cavity, I'm telling you, because you see the cavity.
I'm not worried about the opening of cavity.
No, because sometimes people are worried about that. Because why I'm saying is, you did the hysteroscopy. The cavity is posterior.
Yeah, more
it is retroflexed.
Yes, sir.
And this is post-cesarean adenomyosis.
Yes, sir.
It's a bad luck.
Yeah,
Today she will be relieved. yeah?
Shruti is there in the hall, Shruti. I was telling her this, it should not come out, this one. And while preparing the
Nice.
cases, yeah.
And again, I also encourage you to put endo bag for every case like this. Because that's it. So when there is a good bleeding,
Yeah, that
means
means,
adenomyoma is over.
Yes, sir, yes, sir, yes.
At least in this area.
Yes, sir.
So that's a fantastic sign, you know.
Yeah, yes, sir, yes.
Lovely. Very nice.
Thank you, sir.
Now,
Yes.
take the assistant's grasper in your hand and you hold the lower edge. You hold the lower. Okay, fine. Now you try to approximate. Try to approximate and see what is happening.
It will approximate, sir, definitely.
No, not that way. What I'm saying is, I want to see if there is a bossing.
Jara sir.
Try to approximate. Take two grasper. No, please take two grasper. Bossing hoga, bossing. What is bossing mean? There is a something in the bag and the bag doesn't get folded. So it's coming up, but yeah, if you remove this part slightly more,
Yes, sir, this
yeah,
part
then it
I
will
will-
come very nicely. Yes.
I think this part is over. I can
Yes,
try
that
with
part is
this one.
over. That part is
Yeah.
also over. Only this area where you touch now.
Yeah, yes, sir, yes, sir.
Otherwise, it is done very nicely.
Yes, sir. So again, scooping like this.
Yes.
Very good. Thank you, so Vinayak.
It's a wonderful technique, Sanjay Patel's technique.
Yeah, yes, sir. Yes, sir. I have seen, I think, somewhere on the YouTube that.
Now you're going to have a barb, you have a barb suture?
Yeah, yes, sir. Yes.
Wonderful, yaar. She will have such a good relief. Believe me. You will, I'm going to receive a call that she conceived, sir.
अरे सर आप फोन उठाओगे तब बोलूंगा ना.
अबे देवकरे. How many cases you call me, you tell me?
Sir, hundreds, but whenever required, you definitely, sir, you were there. For audience, I tell you that I was operating at one of the corporate hospital, and I start very early in the morning. I usually start by 6 a.m. in the morning, and I just given call to sir at I think.
Superb. This is almost
yes.
out. You can see the tissue quality
yes,
down.
sir, yes, sir, yes, sir.
Post-operatively, tell resident to somehow give her one depot of Zoladex.
मैं दे दूंगा sir उसको, कोई बात नहीं.
Zoladex or Lupride. Zoladex is better because it will work for 5 weeks.
Sir, I can.
Wonderful. It is so good. Now don't do anything. Just suture. Lovely.
Yes, sir. Thank you. Suture this way.
Awesome.
Yeah.
This is the best case of today.
Oh, sir, please. So, sir,
नीचे
this
में कुछ
one,
नहीं है अभी. ऊपर वही वाला वैसा.
sir,
नहीं वो कुछ नहीं फर्क पड़ेगा because see mostly the adenomyosis which is very close to endometrium, it gives a lot of effect on the endometrium. So all that cobweb and that fibrosis which we were seeing on hysteroscopy was because of this adenomyosis.
yes, sir. Sir, this one, based
Now I would suggest one more thing is not to go very deep enthusiastically and make this barb appear in the cavity.
Yes, sir. No.
Okay.
Sir. Yeah, you told me this, sir. Long back.
yeah.
We had discussion.
Because with the transverse incision, if you read the literature, everybody who is doing transverse incision myomectomy, the number of barb coming in the cavity is the highest.
Oh, wow. Sir, thank
Because
you.
with ipsilateral, your throw goes much better.
Yes, sir. Sir, what should I do, sir? Baseball or what?
No, regular. Why baseball?
आदत हो गई है, sir.
No, not in this baseball. And I would tell you to go one stitch behind.
That इसके
Angle,
बाद-
yeah.
Okay.
Angle.
Yes, sir.
Because see, adenomyosis, healing is slightly, it's okay. All these pieces can be collected later on.
Okay.
Go one behind. Yeah, yes, go much behind, yes. And then start from there. Very good, excellent. and then take one in between and then come regularly like that. And what I would suggest is after you cross your first bite, don't completely tighten them.
Yeah.
So you can go deeper and deeper. Understood?
I got it, sir.
And then in the end you can, so assistant just be very careful that he should not entangle. Just hold the barb, hold the barb.
पकडून धर फक्त. हा, तिथे नको.
Yes.
Sir, just one question. Why not
Yeah.
baseball, sir? Just for academic purpose.
Okay, so what happens with the baseball is that this is a adenomyosis. If you see, now one minute, listen to this.
Yeah.
Camera go close to the edge, which is cut edge of the myometrium. No, not there.
Yeah, he's there.
Where it is open, go very close to the cut end. Go close. Go close. Now see, the upper part which you see very delineately, that is serosa.
Yes, sir.
Upper one.
This one.
Okay, edematous serosa, yes.
Yes, sir, yes.
And the lower part is the myometrium. That's it.
Yes, sir.
So now if you overlap one another,
Yeah, yeah.
you don't have much myometrium here.
Yes, sir. So you want to go me from this?
Go with the proper alignment, yes.
From here or here?
Yeah,
sir?
no. In between your tab and the first one, yes. Go. You can take slightly deeper afterwards. This is okay. But otherwise, after this, you don't tighten them fully. This one you tighten.
So nice barbs are visible with this camera 4K
Yeah,
camera.
this is CT1, so barbs
Yes,
are
sir.
visible and they are dangerous also.
I am little bit happy with the vision. In the morning, I got stuck. I was not happy. It was irritating to my eyes.
Your coupler has been repaired by me, you know that.
Yes, thank you, sir. Sir, no, this is another system, sir. That was.
But
sir,
it will give you trouble. So you'll have to give whenever you're going on holiday,
Yes, sir.
send it for a service.
Oh, sure, sir. So not going too deep, but enough deep just to approximate and not to keep any kind of
Yes.
dead space, because this is the main.
Yes, don't go very far, you know, come, no, go further deep. Yes.
So you want that
Complete obliteration.
okay, got it, sir. Very close to each other, that first and second bite. Yeah. Hold there, sir, please.
So after this you don't tighten too much.
Yeah,
hold
got
it,
sir.
yes.
Got
Hold
it.
the barb.
So after 2 or 3,
You have a good assistant, yeah.
Yes, sir. I'm lucky, sir.
Go right at the bottom. Yes.
So no dead space.
No dead space should be there. नीचे और थोड़ा और नीचे. Yes. And now don't tighten.
Okay, sir.
Keep it slightly loose. Let it be that much. Yes. Now you hold that loose loop. Assistant. Hold the loose loop.
इथे धरून loop.
Loose loop पकड़, loose loop.
मध्ये पकड.
बस.
थांब. पहिला पकडू द्या.
आराम से. You're doing wonderful. Don't worry about it.
No, sir.
You picked up all this from Vivek sir very nicely.
Yeah, thank you, sir.
No, that was not a compliment. That was a critic.
Sir.
What you've taken from Vivek sir is distress. I'm saying do it with ease. You are anyway doing wonderful. No, nobody will criticize you like that. Believe me. I tell it to Vivek also on face.
In the morning, I already said.
If you get time, whenever you have time, you see your first case and see your vagina. Bas, don't tighten.
And what will with this, sir?
No, we'll tighten in the end because you will not be able to reach till the bottom.
Okay,
Last sutures. It's okay. Don't bring it back now.
Okay.
You can't bring it back. But while tightening, just remember, because you will not be able to see after some time it will close.
Sir, वो नहीं आया तो फिर?
आएगा नहीं, ऐसा हो ही नहीं सकता है. रूल ही नहीं है ऐसा.
Okay.
Barb cannot be not tighten, ऐसा हो ही नहीं सकता है.
Sir, I have seen long back.
No, then if you have gone back, then it will not.
So when the quill was there, sir, this one I have seen Rajesh Modi sir operating.
No, don't. थोड़ा नीचे. Yes, include that. Yeah, come to the bottom. Come to the bottom end. पीछे पकड़ needle थोड़ा.
Sir, जाएगा sir.
Needle पीछे पकड़ना भाई.
Sir, आ गया
Thank
sir.
you. आया I know. पीछे पकड़ने के बाद आ गया.
Thank you, sir. That's why I've kept this conference, to know from the stalwarts what we are doing, wrong things or under wrong things.
बस
No, नहीं खींचूंगा, अभी नहीं खींचूंगा, कैमरा क्लीन.
No, if you खींचो then I will tell you, no. I'm here, I'm not watching, and coffee was lovely, so now I'm fully alert.
Yeah, thank you, sir.
इधर तूने खींचा कि मैं तेरे को खींचूंगा.
Oh, sir. Because I'm
Clean the lens, huh? The dirty image gives headache to the surgeon and everybody who is watching. Sorry, huh? Vikas?
No, sir, please, sir. Morcelator. My needle is on, please come fast. Yeah, fine.
नहीं हुआ, clean नहीं हुआ. Sorry. हाँ बस वेट डालो, सूखा मत करो उसको, ऐसे ही डालो, सुखाओ मत. हाँ perfect है, बस. Put it wet. Ah, good boy.
Yes, sir. Wow.
Always put a wet lens, never dry it up. So there was a IIT person came to me and he was doing a PhD on fogging of the lens.
Oh, wow.
And I removed his topic in one day only. I told him that you sit in the car, AC car in Mumbai, in the humid days, and you wear glasses. So when you come out of the car, what gets fogged? Eyes or glasses? He said glasses. I said, why don't I also get fogged? They are also lens, no? He said, oh, I never thought like that. I said, because your eyes are wet, they never get. So only surface, if it is wet, it will never get fogged.
Sir, now?
Now, wait, don't do anything. Wait, now tighten the last one which is loose. Wait, don't do it. Leave this needle.
Good man.
Leave the needle. Both of you now tighten couple of sutures so you will get a length.
So now pull,
tighten this.
Pull it?
Pull it, yeah. वो टाइट ही है, कर दे फिर भी टाइट कर रिया. So if you see Sanjay sir's vault suturing, he never tightens the
yeah, sir, I have
seen. He keeps it loose.
Yes, sir.
And then tightens in the end.
Even you don't take the uterosacrals also.
No, because sir doesn't cut uterosacral. I said, don't say he doesn't take it.
No, means same thing, sir. Don't take.
Okay, loose.
Yeah.
That's it. You tighten this later on. This was to get you length.
Okay, got it, sir. That means I should go inside. That's why you are telling this.
Hold your needle slightly behind for such cases. Yes. So you can go in one go at the bottom. Yes. This is where you will get hematoma. Because this is the corner end. And
yes, sir. Mostly vessels will be there.
Yes. One more suture and you are almost done. Then you will get tightened. Then it will be able to go complete it.
So
now you can tighten all the sutures. So you will get a length to go back and complete some area in between.
So 2 layers or single layer enough?
This is single enough, more than done. This patient will do so good, believe me. You align that upper area which is coming, align it, push it inside. The upper edge, push it inside.
Yes, sir. Vinayak, ek minute.
Yes, some more on the top, in between the last two, second last and the last. No, push the upper one inside. Push it inside. Upper one, not that. The upper means kefaled. Yeah, yes. That's it. Your assistant can push very easily. Your assistant can push that. Push. That's okay. That all is good. Now tighten this. Place it nicely. Place it. दबा के रखो assistant को. Yes, very good boy. थोड़ा फंडस से दबाओ assistant. What is the name of your assistant?
Vinayak, sir.
अच्छा, तेरे पास तो गणपति है भाई. विनायक है तो फिर क्या? विघ्नहर्ता.
So it is not coming that more than.
बस, that's more than enough.
Yes, sir. Yes.
So barb is very good in that because after a certain limit, barb will never get pulled.
Yes.
And that is why they are adequate suturing. It's not too tight, not too loose. So now take that. Yes. There, come here. Yeah, come wherever you're coming is proper. Yes, you're coming in between. Yes. Okay.
So you wanted
you should go that side.
That's it.
Yes, and one more after that and that's it. बराबर. अभी ये इसको ऊपर जो रैगेड एरिया है ना उसमें से आप
ये एक इसमें लेना पड़ेगा. यस.
Yeah, go from this side to that side. Means cross the barb.
From this side to this one or
This way. Whichever, that also is okay. Not so much, not so much. Little bit towards you.
end. Yeah.
Not samne, make it cross.
Okay.
In between the second last gap and the first gap.
Got it, sir.
Yes. You'll have to rotate your hand first. I mean pronate and then supinate. Yes, fantastic. Lovely, excellent job. You getting the barb out? Yes, done. Cut do. अरे तोड़ भी दिया. Superb, यार.
Yeah. I will take out right now only.
Lovely.
Yes, sir.
Yeah. Needle should be. You must always see the needle coming out, huh?
Yes, sir. Yeah, till that last point, I will always see what is happening.
Superb job. Very good.
Thank you, sir. Thank you. It's uterus is really looking like uterus now.
Yeah.
He delay morcellate that, please. Yeah.
And you also put whoever is a resident, no?
Yes, sir.
Tell this another tip, okay?
Yes, sir.
So see, adenomyosis is dependent on estrogen and progesterone, okay? So you give Dynogest and you also give her letrozole. Okay, like how we give in breast cancer or any estrogen dependent tumors. So you give 2 months letrozole daily.
Sorry, sir, I was little bit busy with the morcellator. Can
No
you please
problem.
repeat what was?
So you are going to, morcellation will not be required actually. These pieces will come out from the umbilical port if you put a bag.
Yes, sir. Sir,
but it's okay, you can put it, no problem.
Yes, sir.
So what I was saying is post-operative medical therapy is very important for this patient because adenomyosis is never complete.
Yes, sir.
You always leave some disease behind.
Yeah.
And you want a good healing. So that time the disease is inactive, healing will be complete. You get it?
Yes, sir.
So you give one GnRH, whatever patient affords. Zoradex is preferable or Lupride. And give her Dynogest and Letrozole every day for 2 months.
I couldn't get it, sir.
Got it? Letrozole 2.5.
Letrozole 2.5, yes, sir.
And Dynogest 2 milligram every day.
Okay, sir.
And 2 months later you do her hysteroscopy. Huh? That's okay.
Ulta. Yeah, it's done. Okay, probe, please. I need tenaculum, please. Tenaculum, I have. Yeah, thank you. Washer is not there, I think.
अरे वो विवेक है, इसको क्या करेंगे?
I will put it on the cut only, not cut plus.
What?
Yeah, only cut. Sir, you are using Versator only or anything else, sir?
I use Rotocut.
Rotocut.
And in some places I use Versator like Surya or Bethany.
Sir, for the first time I am using this Versator and I think yes, it's a very nice and very smooth. These movements are there. The feel is there.
So you have somebody from Versator in the OT?
Yeah, yes, sir. They are there, sir.
Who's there?
I think Ananda is no. Ananda is there, sir, from Pranav Medicare.
Okay.
Shailesh was about to come, but he got busy with some work. He didn't come.
No, Re Baba.
विनायक
मॉर्सरेटर बंद कर दो.
यस सर, बंद किया उसको सर. ये सिर्फ पकड़ने के लिए यूज कर रहा हूँ मैं. ये स्विच ऑफ दिस.
Nice.
Yeah,
Good job.
I need to check any remaining.
Now you will cut the suture of the uterine, no?
Yes sir, uterine artery I will take it out.
Suppose you leave it like that, it is okay?
कुछ भी नहीं होता है सर, रख सकते हैं ऐसे भी. अच्छा. आपका क्या बोल मतलब आप जो बोलेंगे वो करेंगे सर.
So there are two thoughts actually. If you have multiple fibroids,
Round ligament to say.
so you have multiple fibroids, like multiple means too many, and you are unable to remove all of them, then it is better to do bilateral uterine artery ligation.
Yes, sir. Yes, sir. So now I think for audience, you can see nice anatomy here. Uretary, two ureters are there. Sir, this is second time I am getting two ureters. Otherwise,
Yeah.
yeah. So now I am just lifted up that uterine.
No, you cut one loop. No, it will come out. So you pull. One is. No. Oh God.
सर सर नहीं था वो प्रॉपर शूलेस नहीं बैठा था सर वो
नहीं, but one knot would have come out.
ले लूंगा सर मैं. I'm just staying very top of
Actually, it took double throw नहीं लेना चाहिए था.
हाँ ना सर वो.
It's okay.
Now it's very difficult.
Let it be. Don't worry.
I will check whether cut
Just
हुआ
leave
है
it
कि नहीं
now.
हुआ है.
Just leave it. Don't worry.
Okay sir. Okay.
You cut the hanging
Yes
part
yes
of the
I am
barb.
going to cut that sir. जरा वर पकड़.
Just keep 2 barbs.
1
or
2
3 barbs. Yeah.
1 2 3 yeah fine.
Bas, that's it.
Yes sir. Wash please and I will come out.
Nice. Good job.
Thank you sir. Thanks for. Thank you. Action and irrigation.
ऐसा इतना नहीं, काफी टच होगा. इतना टच होगा तो कुछ नहीं होता है. प्लस
Section 1.
इसको कुछ नहीं करना. ये नहीं होना चाहिए. थोड़ा आराम से करने का, कुछ जल्दी नहीं करना.
Section होत नहीं है. Sir, what about Surgical and Interseed? You routinely use in Mumbai or what?
Useless.
Oh, seriously?
Absolutely useless.
Okay, sir.
It's a waste of.
Anyhow, we are not using that.
The surgery, alignment, no exposure of raw area.
Yes,
There is
sir.
nothing compared to that.
Oh, okay, sir. Okay.
And now you compare, you would have taken biopsy versus this surgery. You tell me Interseed is better or this surgery is better?
Obviously, sir.
Of course, this surgery is better.
Yes, sir.
You have reduced so much burden of this disease that this patient will have very good relief. Don't wash too much, it's okay.
Yes, sir.
Because it's all adenomatic tissue, no? So it will disseminate. The gas is, the stomach is completely, so riles tube डालना पड़ेगा.
Yes, sir.
Otherwise she'll have a lot of belching in the post-op time.
I hear I'll stop talking. Okay, sir, we'll do that.
Do you see the vasopressin effect is still not gone?
Not
Come
completely.
Come
Yes,
back
sir.
and see the blanching, okay?
Yes, sir. That's
So this is typical of adenomyoma.
Yes.
By this time, myometrium would be having a good vascularity. So that is why what happens is that the compact tissue in the adenomyosis is so much that it does not allow too much of vascularity.
Okay. I'm checking just another side of ureter, whether it is single or double.
Single. Generally, it is only one side.
One side, yes, sir.
And statistically, it is more common on the left side.
Okay, sir. I don't know. Thank you, sir. ये पकड़ लो. एंटीवेट करना आदित्य कर गए एंटीवेट ये पकड़ लो. ये तू पकड़े.
The left kidney is lower, no?
Yes, sir. Okay. Thank you, sir. Thank you, anesthetic team. Thanks a lot.
Very nice.
Thank you, OT assistant. Thank you, staff. Thank you, Pranav Medicare. Thank you, Praveen and all sharp team. Thank you, Tanvi. Thank you, Aditya. Thank you, everyone. So I'm just coming out, sir. Audience,
Over, right? The workshop is done?
Yes, sir.
Workshop is over, right?
Yes, sir. Well, sir, last tip, sir, what you always tell us to not to take peritoneum while taking out this one. So I am just following you, sir, since long time.
Yes.
So it is very good tool to prevent lot of pain happening to the patient.
Yes.
So here, for the sake of audience, I am dictating. So see that I have gone through the muscle, but I will skip the खालचं peritoneum पकडणार. So see here, the muscle, I have pierced the rectus sheath, rectus
And then
muscle.
it travels out
Yeah.
of the, yes.
Yeah, and आता पकडून जा. जास्त उडू नको, thread छोटाच आहे. The same thing I will do on this side.
नहीं होता है.
तो गैस जा रहा है इसलिए
So
थोड़ा सा ले लूंगा मैं आगे.
if you do figure of eight, it causes a lot of pain.
Yeah, yes, it has came nicely. Sir.
If you take simple sutures, no, two simple sutures, they don't have pain. If you cross it, it will have pain.
कट है कैसे?
समझा?
नहीं राइट से
Oblique muscle है ना?
स्टमक में
So
रखना.
you take like this and like this. This is your incision. You take one suture like this, one suture like this. If you take one also like
So that you can see the gas is not leaking right now, and just show तिकडे दाखव तिकडे.
you take one.
Now the rectus muscle and rectus sheath nicely pulled up. सोड जरा.
Not like this. टेढ़ा नहीं करना, straight लेना. ये incision के line में.
Scissor, please.
Thank you, Vikas.
Thank you, sir. Thanks a lot for
And thank you entire, Miraj GMC team, the OT team, the, Dean, head of the department, Dr. Rawal, and everybody, right from top to bottom, all the residents, lecturers, anesthesia team, thank you very much.
Yes. Thank you. ठीक आहे, हेच लावायचं का क्लीन करायला त्याला?